Good afternoon. I welcome you all to Fogsi-Jogi-E-Picsep 2020, program for inculcating culture of scientific inquiry and pursuit, organized by the Association of Obstetricians and Gynaecologists of Delhi. On behalf of Jacksonpal Pharmaceuticals Limited, makers of Lycorate soft gels for preeclampsia, IUGR, and infertility, Cyclorex CR10, norethinosterone 10 mg controlled release tablets, and Dynogest 2 mg tablets as Endorec. I'm Dr. Vipin Tyagi, along with my teammates, Dr. Deepika Chabra, Mr. Arvind Singh, and Mr. Amit Saxena. We feel honored to have as chief guest Dr. Alpesh Gandhi, President Fogsi. We thank you for gracing this webinar, sir. We thank all the esteemed medical luminaries for sparing your valuable time to enlighten us today. Guest of honor, Dr. Jaydeep Tang, Secretary General Fogsi, Dr. Suvarna Khadilkar, Editor-in-Chief Jogi, Dr. Geeta Balsarkar, Associate Editor Jogi, Dr. Madhuri Patel, Deputy Secretary General Fogsi, Joint Associate Editor Jogi. We welcome convener of this webinar, AOGD President Dr. Mala Srivastava, Senior Consultant and Professor Ganga Ram Institute for Postgraduate Medical Education and Research at Sir Ganga Ram Hospital. We thank the ICOG for accreditation of 5 ICOG points to all attendees of the webinar today. Welcome to all attendees. Please keep posting your queries by text in the Q&A box, which will be answered. Please note, this webinar is brought to you as knowledge sharing initiative by Jacksonpal Medical Services, and this session is streaming on Facebook Live. The recording will remain on Jacksonpal YouTube channel for reference and promotion. I will now request Dr. Mala Srivastava ma'am to kindly initiate the session. Ma'am, please unmute.
Thanks, Dr. Vipin. Good afternoon, everyone. I welcome you all to this e-learning on Fogsi-Jogi-E-Picsep 2020. This is an excellent initiative of our Chief Editor, Dr. Suvarna Khadilkar. Madam is very passionate about scientific material and high standard of scientific writing. Dr. Suvarna has contributed a lot in making our own journal very popular and gets considerable impact value. This program is an extension of our passion to catch young PG students and train them into scientific writing. It's my pleasure to invite Dr. Alpesh Gandhi. Sir is Fogsi President. Under his dynamic leadership, the entire Fogsi fraternity is vibrating with scientific program and e-learning. Sir, you have really taught every one of us how to be innovative and experimental and keep our aim of learning and teaching continued during this pandemic. It's my pleasure to invite Dr. Kanika Jain, who is a Vice President of AOGD and Senior Consultant Endoscopy Surgeon at Institute of Obs and Gynae, Sir Ganga Ram Hospital. And I will request Dr. Kanika Jain to introduce our guest of honor, Dr. Jaydeep Tang. Over to you, Dr. Kanika.
Thank you, Dr. Mala. It's my honor and privilege to be introducing Dr. Jaydeep Tang. He is a dynamic personality, Secretary Fogsi, and he has been helping us throughout our tenure as AOGD in Delhi. And we welcome you, sir. And I would like to request Dr. Jaydeep to please address the gathering and say a few words of encouragement on this Pixel, which is a very informative workshop. And the initiative has been taken by Dr. Mala to carry it in Delhi. So I request you, sir, to please address the gathering.
Thank you very much, Dr. Kanika Jain. It is indeed a pleasure and a privilege to address members of the AOGD. I'm not sure whether you're aware, but currently the AOGD is the largest member society of Fogsi. It is also one of the most, it's also one of the most vibrant and active societies. And it's always such a pleasure and privilege to speak to all members of our national capital of New Delhi. So thank you very much for having me here. I think this is a very, very important program, and thanks are due to the President of AOGD, Dr. Mala Srivastava, the Vice President, Dr. Kanika Jain, and the Secretary, Dr. Mamta Dagar, and all the faculty members for putting this program together. I must acknowledge the dynamic leadership of our President, Dr. Alpesh Gandhi, the Vice Presidents, and all the other office bearers. And of course, the wonderful work that is being done by the editorial team of the Journal of OBGYN in India. Suvarna has been leading from the front as the editor, and Geetha, Dr. Madhuri Patel, Dr. Ashwini Bhalerao, Dr. Anaita Chauhan have all been ably assisting her. I must acknowledge the fact that the topics that you have chosen for this webinar are quite excellent. And I wish that more attention is paid to these topics, both in undergraduate as well as postgraduate years. You know what they say about India, that we are a data rich but publication poor country. And perhaps this is partly because of the less emphasis on publication. That we have due to our very, very large private sector. I, for example, may have the largest data on some things, but till I don't publish it, really speaking, what is the use of that data? And if I have to publish, then programs like this are very important for someone like me to inculcate both the knowledge and the spirit of how to publish and make sure that our data is recognized throughout the world. So I think you've selected wonderful topics. I'm sure everybody who attends is going to be extremely helpful for all of them. And let me also please acknowledge the wonderful faculty that you have gathered, Dr. Geetha, Dr. Ruma, Dr. Radhika, Dr. Vanamail, Dr. Pikee Saxena, Dr. Sunita Mailk, and all those whom I have already mentioned earlier. So again, thank you very much for having me. I do believe that this initiative, which was started by, I think it was started by Dr. Mahendra Parikh when he was the editor of the Jogi, and I'm so delighted that it has continued. And in fact, under Suvarna, Geetha, and Dr. Madhuri has taken and reached new heights. So again, thank you very much for calling me Dr. Mala, Dr. Mamta, and Dr. Kanika. And I do hope that this webinar will be useful to all who attend. Thank you very much.
Thank you, Dr. Tank, for such encouraging words. And actually, what you said is right. We have a lot of data, but publication and research work is lacking in India. And just to promote that, this initiative has been taken, which is a very well organized initiative agreed by Dr. Mala. So I would now like to introduce Dr. Mamta Dagar, who is my colleague and friend and the secretary of AOGD. And she would be taking the proceedings further. Dr. Mamta is the senior consultant obstetrician and gynecologist and endoscopic surgeon at Sir Ganga Ram Hospital, Professor Gripma. So over to you, Mamta.
Yeah, thank you, Kanika, and good afternoon, everyone. On behalf of AOGD, I welcome you all to this Fogsi-Jogi-E-Picsep workshop. And thanks to the Foxy for giving us this opportunity to hold this workshop on a very pertinent topic of research. And it is my privilege to introduce Dr. Suvarna Khadilkar, who is editor-in-chief of Jogi. She has already been introduced. Has Dr. Suvarna joined?
The madam will not join. You
Okay.
just give her introduction and then we can start off with the session.
Dr. Suvarna is the editor-in-chief of Jogi, and I now take this opportunity to introduce Dr. Geeta Balsarkar, who is Associate Editor Jogi, to say a few words. Over to you, Dr. Geeta. Are you there?
No, I think you can have moved to this first session.
Yeah. So now, yeah, we move on to the first session, and to chair this session, may I invite Professor Dr. Kanwal Gujral, who is HOD and Chairperson, Institute of Obstetrics and Gynecology, Sir Ganga Ram Hospital, and the second chairperson, Dr. Achla Batra. Madam is the professor in VMMC and Safdarjung Hospital, Delhi, and she is also the president NARGI and chairperson AOGD Urogynecological Committee. So we start with the session first. So over to the chairperson to introduce the speakers.
Right. Good afternoon. Am I audible?
Yes, madam.
Yes, ma'am.
Fine. Good afternoon and hi, Achla. We begin the session, and I great pleasure in inviting Dr. Geeta Mediratta, who is a senior consultant with us at Ganga Ram Hospital. Her interest is in urogynec, and a word of praise for her that she's a voracious reader, very sound academician, and a very good human being. Without wasting time, I invite you, Geeta, to speak on your talk, selection of a topic for research. And I think this is the most important topic in the whole scenario. How do we select a topic? Geeta, over to you.
Thank you, the respected chairpersons. Am I audible?
Yeah.
Hello. Am I audible?
Yes, you are. Carry
Yes,
on.
Dr. Geeta.
Okay. Thank you, respected chairpersons. And I thank Dr. Deepika in advance, who will be running my topic, the slideshow from her side. So now, welcome to this program for inculcating culture of scientific inquiry and pursuit, or PICSEPs for short. I have been given the opening batsman title, and I will start with selection of a topic for research. What is the guide's role? Then I will talk about what is the feasibility of the research topic and the time management which is required with this. Right. Next, Deepika. So just a brief outline, as I've already told you, the introduction, guide's role, formulate a good research question.
Dr.
We
Geeta,
can't
you're
hear
not
you,
audible.
Geeta. Yeah.
I will tell you about these, and I will tell you about the time management finally in the end of the lecture. Next slide, please. So first of all, it's very important that we know before we start writing a research protocol what we want. Next slide. So it's good to read a lot. Next slide. Read a lot. And as Dr. Tang has definitely very rightly said, we are a data-rich country. So publish or perish is a phrase that we come across very frequently. This is the only way that we scientists can communicate with each other and give authors credit for the work they have done. And publishing is important for career advancement. Also in the government hospital, etc., it's a mandatory government regulation. Also, it gives greater opportunities for international collaborations as well as monetary incentive for grants, etc., based on the studies you perform. So in other words, the desire to publish these days is really increasing, especially from our side of the world, where more than 3/4 of the world population resides, and the clinical data is so abundant that we cannot even imagine how much data we have. And governments also are in their own place striving to provide adequate resources and training, like this current one which we are doing. Collaborations and short-term courses are being offered by the governments. Yet one faces many barriers while conducting a research study. Now, what are the barriers? Mainly choosing the appropriate study, the design, ensuring a good quality data collection. You should not just typo from your neighbor or from the Western people. You have to ensure that your data collection is of good quality. It's 24 karat gold quality data you should ensure. And then you should store the data, and entry and appropriate statistical analysis is a very, very important component which shall be discussed as the day goes by. Now, after we have overcome these barriers, we have chosen our topic, we have got a good data, we've got 24 karat data. Now, how do you write? So, to write a research work for publication is like giving shape to your ideas. The art of scientific writing can be acquired by following certain basic rules for writing a manuscript. And for this, you have to have the guide is very important. Now, the guide is someone who guides you so that music comes out and not cacophony. So you should have good music coming out. So the first role of the guide is to, you should not only do science, but you write science. So you must tell your story in a clear, simple language. The title of paper, very important to choose the title of paper. Now you can choose an indicative title, which tells you the purpose. Or you can choose a declarative title, which tells you the conclusion. Like, for example, an indicative example is like preterm premature rupture of membranes, diagnosis, evaluation, and management. This paper tells you that the author is trying to tell you about what is the purpose of his study. But if I write a paper on the risk of, say, risk of uterine rupture following induction of labor in women with a previous cesarean section in a large teaching hospital, now that's a declarative title. That is telling me what will be my conclusion. I'm looking at the risk of uterine rupture. Next slide. So now, therefore, it is very important for us as guides to formulate a good research question, then do a comprehensive literature review, Then you optimize your time and resources. This is very important. You should have a feasible question answers, and the mentorship all along the writing of the thesis is very important. And keep at each step, you do a critical appraisal of the postgraduate. Now, choosing the title is very important. It should be very simple, concise. It should be informative. It should be interesting. It should grasp the eyes of the reader. It should be accurate. You should not beat about the bush, and to the point. And it should be very specific and to the point, as I said. Now, coming to the language and style, you should speak simple, clear language. Your sentence construction is very important. We are often faced with this problem of poor grammar and poor sentence correction, construction, punctuations, etc., which is very important. And please tell the PGs not to misuse the words. The correct words must be used. It's like not data, it's datum. Now, effect of the study, not affect of the study. You compare between two things, not among. You use the dosage, you don't dose. How efficacious it is, not efficacy, and the effectiveness of the drug or the intervention you're doing, and not effective. So these are small points. Then construct a summary, which should be a succinct summary of the research paper. It should show your transparency in the publication. Your disclosures must be mentioned. Your acknowledgements to the patients, to your colleagues, etc., to your parents, etc., should be there. An effective presentation of the research must be done. And under the discussion column, you write down the systematic interpretation of the results. Now, coming to the feasibility of a research topic, that is the second part of my lecture, or how do you build a good research question? So a lot of scientists and authors have given us a very simple framework called the PICOT framework. These are the questions that you need to answer when working with this framework in a clinical research design. So what are the questions you need to answer? What is your population going to be? What intervention you are going to do? What will be the comparators? What is the outcome? And what is the time frame? So going over them one by one, very simple. Population. What is your target population? Like, for instance, in the topic I started, preterm premature rupture of membranes, diagnosis, evaluation, and management strategies. So obviously, your target population is ladies with the PPROM. So you have to define that. Then, is the target population narrow or broad? From your data what is the incidence of PROM. So how much your thesis will consist of, how many patients you need. Now, is this population vulnerable? That's a very important question you have to ask, because in case you are going to do an intervention in a vulnerable population, and because of the delay in intervention, you may have some adverse results, please do not use this target population because it's a vulnerable one. However, if you're doing a study which is simple, it will not make them vulnerable, go ahead. Then you must set out what are the eligibility criteria, the inclusion criteria, as we call it in our thesis. So these are very clearly set out. Then what is the most important recruitment strategy? Do you want to do a retrospective analysis? You want to do a prospective? You want to go and do it in the, in your clinic or in the society or your nearby college or school or in the field? The next part of the PICOT framework, or the question which we need to ask, is the intervention. Now, what is the intervention? Now, like in the study which I examined, which I quoted, like if you have to do the factors, say, predisposing to perinatal death related to uterine rupture during birth after cesarean, during a VBAC. Now, if this is my study, then intervention is that I'm going to study what are all the interventions I'm going to do to prevent this from occurring. So, or it can be an intervention in the form of a treatment, like you compare misoprostol with Foley's balloon for induction of labor. So you have to identify what is the intervention. Is it a treatment? Is it a diagnostic test? Is it a procedure you are going to do to find out whether you are giving a TAB block, a transversus abdominis block? So is this procedure going to help relieve the pain or not? So you have to find out what is the intervention. Then, is there any standard of care for this intervention? You have to write down if this is a point of care test which you have agreed upon. So you have to tell in your thesis, yes, this is the standard of care. Then is there a need for standardization of the intervention? Then what are the potential side effects of the intervention? Now, supposing you are going to give misoprostol, you should know the dose and what are the side effects, and what is the group of women who should not be given misoprostol because of the side effects. Then you have to write down whether your side effects you will record or not. And if there is no intervention, what is the risk of the exposure? Next. So next point is the comparator. The comparator, the Picot framework, we come to comparator. Now, how has the control intervention been chosen? You have chosen between misoprostol and Foley. So in your review of literature, you have to tell that yes, there have been studies which have said that misoprostol was effective in these many cases, Foley's was in these cases, these are the contraindication. So you have to know the comparator. Then are there any ethical concerns related to the use of a placebo? Now you have a patient with high preeclamptic toxemia and you're going to induce her or not induce her. Now that is an ethical thing. You are having patient bordering on eclampsia and you're not going to do any intervention. That's unethical. So you must address that. Now has a sham intervention. Again, if you have a sham intervention being considered or a placebo, you have to justify that and it should be ethically correct. Then also if you have multiple comparisons, say if you have misoprostol with Servigel, with Foley's, then you will have multiple comparisons. So you have to adjust your statistical analysis, your statistical methods to be able to identify and interpret these multiple comparisons. Now coming to the O of the Picot framework, outcome. So this you have to ask yourself, what is the primary outcome? What are the secondary outcomes? Like in the study I quoted, the PROM, the diagnosis, evaluation, and management strategies they have studied. So there are so many outcomes they are studying. Or what is the effect of pushing or not pushing in the second stage of labor? So you have to see how many tears you got. So that is one. Secondary outcome can be how many of these women developed incontinence, urinary or fecal or flatal afterwards. So you have to be very clear in your mind what is the primary outcome and what are the secondary outcomes. Now, are these outcomes exploratory, explanatory, or confirmatory? All this means is that are you going to ask, it's a questionnaire which you're going to ask them, and that is exploratory, or the explanation you will give, or you will just confirm, yes, patients who had tears had more incidence of incontinence. Now, also you must ask yourself, have other outcomes been or other surrogate clinical outcomes been considered? Then you have to be very important in telling your PG that are these outcomes validated? Are these, so you have to resort to validated questionnaires. Like we have in the SUI, we have validated questionnaires, quality of life questionnaires, urinary incontinence questionnaires. So you have validated questionnaires for these and which you can use. And then another very important outcome is the safety outcomes, how you're going to actually measure these safety outcomes. You have to consider these safety outcomes. There should be no harm or hazard to the patient. Then how are you going to measure it? Is it just say measuring the amount of deliveries in induction delivery interval, or you're going to say, as in the second case I said, how many had a rupture uterus, etc. So how are you going to measure it? Then are the dependent and the independent variables which you have chosen be numerical or categorical, or they can be ordinal? And do you have enough statistical power to measure the secondary outcome? Say if it's a very rare side effect of a problem, then you may not have enough statistical power to say, yes, this outcome is significant or not. Next. Now the T comes to the most important, the time frame. Now, whenever you design a study, you first see, is it a cross-sectional or a longitudinal? You're going to do it at a particular point of time, or you're going to study that patient over a long time, or apply the intervention you are doing to her. Say you're putting Servigel or you're putting misoprostol and you study, or you do something like a cervical consistency index, CCI, and then you follow this patient from say 20 weeks till term. So is it a longitudinal or at a particular point? Then how long the recruitment will take? Supposing the incidence of the disease is so rare you're going to wait for many months to recruit 2-3 patients only with that disease. So if you have to see what you are studying is rare or common. Then data collection, you must know that you must to have enough data, you need enough time. But if you don't have the time only, you have to submit your thesis, then you have to choose a topic which will fit into the time frame. For the ample time frame is given to collect the data. Then the frequency and duration of the intervention. Supposing you say the pain score, say the pain score after giving epidural. So you have to specify immediately after epidural, how much of the pain relief, after 5 minutes, 10 minutes. So you have to have the frequency and duration of the intervention specify. I will check the pain relief. Then how often you will measure the outcome, same case, how often you will measure it. Then how will you prevent or decrease outputs? Maybe by doing adequate counseling, maybe by taking consents, or maybe by giving some incentives to the patient who will participate in your study. Next. So having done the PICOT framework, which tells you how to frame the question, helps you to frame a question, a research question, we come to the final criteria. Now, these are the criteria. Again, they will help to formulate a good research question. So they can, final stands for feasible, interesting, novel, ethical, relevant. So starting with feasible, it's very obvious. The feasibility criteria is very simple. First of all, ensure adequacy of the research design. Your research design, which you have thought of, it should have adequate data with you already existing in the literature. Plus, you should have in your design adequate number of people who you will recruit. Then you must, in case it's a drug you are testing, or maybe a new machine like we did the FIPTEM, the ROTEM, do you have the machine to perform that test? So whether you have enough funding for that. Then target population recruits. Is it possible to recruit strategically? Are you going to have an achievable sample size? Are you going to prioritize the measurable outcomes? Is it feasible to prioritize the measurable outcomes? Then optimize the human and technical resources. Supposing you don't have enough data or enough technical resources to do the study, then you must think and don't do that research there. Then you must be committed, goes without saying. Then also you must procure high adherence to the treatment and make sure there are low rate of dropouts. And also the appropriate and the affordable time frame is, again, time management is very important. Next. So the I of the final stands for interesting. Obviously, it should engage the interest of the PI. It should attract the attention of the readers once it's published, and it presents a different perspective of the problem. The N stands for novel, the novelty. The novelty is what will make the people read your topic, read your thesis. So it should provide different findings. It should generate new hypotheses, induce us to think of new things, that improves the methodological flaws of the already existing studies, and it resolves a gap in the existing literature. Like the study on the levator hiatus before delivery and after normal delivery, and levator hiatus before a cesarean and after the cesarean. So there was always a doubt whether cesarean is protective or not. So these kind of studies, when we study the levator hiatus before delivery, after delivery, before cesarean, after cesarean, help us to, clarify our minds, and it resolves a gap which was there in the literature, that yes, cesarean is protective, provided it is done before the labor starts. So these are very important studies. And now the E part is very, very important. It should be ethical. It should comply with the local ethical committees. The study which you start should safeguard the main principles of ethical research, and it should guarantee the safety. And in case there is some side effect, it should be a reversible side effect. Next. And of course, it should be relevant. You should bring new knowledge and not just put some old wine in a new bottle. That doesn't work. That's not allowed also. And you should contribute to improve the clinical practice. And it should stimulate further research. It should, after the end of the thesis, you should say, okay, now the next step, I'm going to study this part. Like we had a research on the ODS, obstructive defecatory syndrome. First part was just the MRI difficogram. We learned there was, maybe in some cases, intussusception, grade 1, grade 2, grade 3, the size of the rectocele. Then that led to the next step of generating this thought of doing a STAR procedure. So it's one research stimulated another research. So then they did STAR procedure with different variations. So then how successful it is in ODS patients. And the final relevance is that it should provide an accurate answer to the specific research question you have asked. Okay, now after this, we come to the time management. I've already dealt with it in the PICOT framework, but time management amongst the PICOT components, it is the most likely omitted component by the researcher, because the two key aspects that you need to be clearly specified is how much time you will spend in measuring the outcome variables and the duration of each measurement. Say if you're going to just check the fibrinogen levels in a patient who's having PPH or TEG, you should know patient is a hemorrhaging patient. You must say that it is just 5 minutes and not do some test like INR, which will take 2 hours. So that is the important thing. So second part, which is very agreed with all of us, is that theses are always written and a wet thesis is given to you to sign. So please, you should allot 6 to 8 months for the proper study, recruitment, etc., and do your simultaneously literature search. Allow for 1 to 2 months of writing your project, which includes tabulation, statistical analysis, discussion, conclusion, and then allow 2 weeks for the final correction between you and the your guide, right? So it is very important time management. Otherwise, this is what you are going to be trying to cram 2 weeks of studying into one night because I didn't have the time management skills, or it was like a potato. Next slide. So of course, this was not included in my topic, but I thought just in the poster is a very, very important and a very nice way of getting across data. So you can have the guidelines and the design. As you can see, you should have the logo and your abstract number on the left-hand side. The title, it should be the declarative that gives the study conclusion. Remember, I told you they can be purpose or the declarative. And the title should be large so that the text can be read from a distance of 8 to 10 feet. Then you write the list of authors, underline the presenting author, write the affiliation. Now, how you should do? 1.5 meter by 1 meter. So write your abstract in 3-4 lines. Top, introduction, which is background, rationale, objective, hypothesis, material method. Main results should be in the center of your poster. You're clearly writing the content, the observations, table, graph, etc., and headers, footers. And on the right side, write the discussion and the systematic interpretation. Bullet statements are fine. And then finally, the conclusion, your key references and acknowledgements. And then you write down, presented at the annual conference of this, held at this. So this is just, if the PGs are listening, this is just an outline of a perfect poster which you should follow the guidelines and the design. So my dear friends, now coming with the working with journals, now very important, you select a journal which has a good impact factor, or there are Eisenfactor scores. I think there is a lecture down the line on journals. You should have the article influence score, the Scopus 2-year citation date, etc., which will be shortly shared with you. Now to summarize, formulating a good research question can be fascinating and challenging, even for experienced investigators. Clinical experience in combination with accurate interpretation of literature and teamwork are essential to develop new ideas, and compliance with the PICOT framework in conjunction with the final criteria in order to translate a clinical dilemma into a research question is required. And working in the right environment, I will put my money on this last topic. The last thing, the right environment with adequate support of experienced researchers is very, very important. And I'm proud to be working in Ganga Ram Hospital, where the last topic is very, very, bang in place. And I thank my chairpersons for this patient hearing and all the listeners.
Thank you, Geetha. That was really nice. And we're running short of time, so we'll have questions later at the end of the second talk. And hand over to Dr. Achla. Please introduce the second speaker. Dr. Achla, are you there? Dr. Achla, can you hear me?
I've just
please
unmuted
introduce Ruma.
myself.
Yes.
Good
Please do
afternoon,
that.
and thank
Good
you,
afternoon.
Mala, for making me part of this wonderful CME. And the topic to be spoken by this young dynamic lady is very important. The types of studies, because I see so many times the students, they just do so much work without knowing what they're going to do about it. What type of study should be there for the question they want to answer. So to talk about it, we have Dr. Ruma Satwik, who's a consultant in Center of IVF and Human Reproduction, Sir Ganga Ram Hospital. She is the co-convener of a special interest group in research methodology. I think no better person than her to talk about this topic of, types of studies which are there. Over to you, Ruma.
I thank you, ma'am, for that introduction. I'll share my slides. I thank Dr. Mala and her team for giving me the opportunity in this very important forum. The topic given is the types of studies that one does in research. We understand that if we have to look at the composition of, let's say, the ocean, you can't sort of go around checking the entire water. You collect samples. And you collect it in a glass, and you probably try and measure whether what you have in the glass is equal to what is there in the ocean. And we do understand that sampling from different sites might produce different results. Clinical research is something like this. It's knowing that what you see might not be the truth. And it's basically employing methods to determine how close you are to that truth by using methods and proper study design. So everything would depend upon various factors, but we do realize that we cannot study the entire human population if we are trying to prove that X leads to Y. We can only do it on a small population. And in order to say that what I'm saying is actually true for the entire population, I have to have a very well-designed clinical research study, of course, after asking the right question. So we do come across various terms, and these terms could sometimes confuse us. The study designs are sometimes labeled as observational, experimental, prospective, retrospective, descriptive, analytic, cross-sectional, or longitudinal, qualitative, or quantitative. The objectives of this talk are largely to help you identify the type of study design. Hopefully by the end of this talk, you should be able to do it. Appreciate the advantages and disadvantages of each type of study design, and be able to choose the right study design after you know what question you're asking. So for one kind of question, you usually don't have all study designs may not be able to answer your question. So you need to know which one to apply where. So the question again is why have different study designs? Some of this has been answered. I just spoke about it. But let's say this would depend upon how, let's say, the condition was novel, and we are going through the pandemic of coronavirus. We know that it's leading to all sorts of conditions, and everything that we see could be reported as a case report. And if you see more of those, maybe as case series, you have a good chance of this being published. Rarity, again, of the thing, you could do a case control study. A case control study may not be the right thing to do in the coronavirus pandemic, but let's say you were into IVF and you were looking at long-term health results on IVF babies, IVF children. So because it's a very long drawn process, you pick up cases and you had this hypothesis in your head that IVF babies are more likely to have, let's say, childhood asthma. So you pick up children who have childhood asthma, those become your cases, and then add, along with maybe another set of controls, if IVF was more common in a certain set of children. So a lot of this will be determined, like I said, by some of these characteristics: novelty, rarity, experience, expectations, in which case you do qualitative research. And then again, what is the time available to you? The cultural constraints and costs. So remember that prospective studies take a lot of time. They might take, experimental studies especially could take a lot of cost. One may not have the funding for this. So sometimes you have your research questions answered by observational studies, and sometimes even by retrospective observational studies. So we're looking at the first division in studies here, and this is a rough division that I have made in order for understanding what study designs are all about. And please do understand that these are not watertight compartments. So even when we talk about those boxes, which I showed in slide 2, they could be, a study could be prospective and prospective and qualitative, longitudinal, and one of these. So it could be a combination of things. So the first division I'm talking about is qualitative or quantitative. And as the word would suggest, that qualitative has more to do with words, meanings, and so it's basically exploring ideas and experiences in depth, whereas quantitative is talking about numbers, statistics. It's calculating, at the end of it, giving you percentages, means, ratios. But so we are going to focus on qualitative research over the next 2-3 slides. Qualitative research discovers things that one never thought of. So you don't have a hypothesis yet, but you're trying to find out, what is, let's say, it largely has to do with trying to find out the experience of individuals, expectation of individuals out of a treatment, which is when you do qualitative research. So look at this example. Once again, I'm sorry, a lot of my examples are on IVF. So let's say the question was, you were trying to find out, why do people stop IVF treatment after a failed treatment? And let's say you have the answers in your head. You think it could be one of these 3. Maybe it's cost, because it's too expensive, because the family doesn't want you going back to that center, or because of health reasons. And this is what you've thought of in your head. So you design a closed questionnaire, ask people to answer, maybe tick and express your, this is the question you ask them, and express your answers as percentages. 70% say cost, 30% say family, 1% says health, and that kind of thing, and you get a result. But how do you know it's not something else that is making people or women drop out? So you do what's known as an open-ended questionnaire, and this becomes a qualitative study. So the question you ask is not what is written parallel to this, but you ask, why are you discontinuing treatment? And you might get a range of answers from wherever, and you find that these answers are patient-centric, and something that you probably never thought of. It's not just the cost, it's basically because perhaps the woman feels that she's being treated as an object, and a loss of autonomy and all kinds of things. So qualitative studies, the means to do this are surveys. First, you have to design a questionnaire. This could be a longitudinal, where you do, let's say, a longitudinal studies where you started a questionnaire today and checked the responses again, maybe after some change happened in their lifestyle, and did it again maybe 2 years later, and try and compare the results. Cross-sectional design is that everything has been checked within one visit to a house, or one answer of the questionnaire. That's a cross-sectional design. You don't go back to the person to ask them what their responses are after maybe some intervention has been assigned or some event has happened in their lives. Objective questions are most needed. Dr. Geeta spoke about this in the past, and there is a way to determine the objectivity of questions, where you don't allow the investigator to introduce his or her own biases into framing those questions. Third is wording the question, which has to be, of course, all of these are important, and you could choose to have either open-ended responses or close-ended responses. So that's how you design a survey. After, let's say, you had these open-ended questions, how do you analyze results? So everyone is giving all kinds of answers. Closed questions, it's easy. You have those 3 or 4 fixed answers, and you can express your results as percentages or graphs or whatever. But what about open-ended questionnaire? You know that these are numerous. You put it all into a transcribing software, which is trying to study patterns concerns, and it gives themes, recurring themes are identified, it gives a code to these themes, you define categories, and now you state that, you know, a lot of women felt that their autonomy was being hampered by repeated IVF or something like that, or that they were being objectified. So all those answers can be put in one category, or it was cost-related thing or something like that. So we do know that this has been used for studying experiences and for studying perception of respondents, and this is where you'd use qualitative study. The second division that I bring in here are largely you want to know whether your study would be descriptive or analytic. So even when you're reading a paper, these are questions that, or terms that you come across. Now, the major difference is that descriptive is describing. It's saying who, you know, got the disease, you know, when they got it, or what caused, who, what, or when of a certain disease, or again of a condition you are describing. It does not need to have a control group, a descriptive study. And in a sense, most papers that you see in journals will have a descriptive element. So when they describe the demographic characteristics of the population, it is descriptive in that sense. A purely descriptive study, it is difficult to find unless the findings that you're describing are very, very rare. So we'll just come to the examples later. So descriptive is describing who, what, when. It has no control group. It has no hypothesis to begin with. And at the end of it, you might generate a hypothesis based on the results that you have. Analytic is largely trying to find out why. So let's say you said X leads to Y, or you know, the variable X leads to the condition Y. Then you want to say that this is probably because, so you are then generating a hypothesis that that's your hypothesis. X is more common in the condition Y. So how do you prove it? How do you prove a hypothesis like that? Only by having a comparison group, that X was present as a 10% in condition Y, but X was present as 5% in condition Z. So it is more likely that X is leading to condition Y, something like that. So you have to have a comparison group in analytic studies. It describes the association between two variables, largely a cause-effect relationship. A control group is usually present. There is a hypothesis to begin with, and here you are largely testing the hypothesis. That is the difference between analytic and descriptive study. So like I said earlier, descriptive study, while it's describing all of this distribution, frequency, trends and all, when you're talking about publication, it will find you know, a place in a journal if you are describing something about which very little is known. So right now, of course, you know, you have a wealth of data on coronavirus and let's say complications in pregnancy. So if you were looking at something as specific as post-COVID complications in women 1 month after delivery. So, I mean, that would of course be rare, and you could go on describing 5 or 10 COVID complications. That would become descriptive, and it would find place perhaps in journals as well. So I give you 2 quick examples of what descriptive studies are like. Now here, this study found a place. It was published in 2019, and all it's talking about is the distribution of PCOS phenotypes across the 4 regions in India. And you find that we do know that there are 4 phenotypes of PCOS. Type A, we do know, menstrual disturbance and hyperandrogenism. Type B is menstrual disturbance and PCO picture. C is hyperandrogenism and PCO picture, and D is all 4. So you see that because of this, and we had very little data apparently before this, the type C phenotype you find is very less in East India, and whereas it might be equal elsewhere. So it's studies like this which help you in defining, let's say, the distribution of a condition which hasn't been defined before. Second is, this is a study from 2008. Now what it is doing is, again, it's doing something very simple. It's trying to establish a reference range for TSH in the first trimester of pregnancy in Indian women. Okay, now this has been identified that the range, whatever your 95th centile is, or what is considered normal, 5th to 95th, varies based on ethnicity, right? Until 2008, we did not have a study on Indian population that would define its range. So this gentleman, the researcher here, finds that in the first trimester, while the mean in Indian women is 2.42, the upper limit, we are looking at the standard deviation, and I'm trying to find, so this is the fifth, hang on. Sorry, my own thing is here. So we find that TSH, the 95th centile, which is up to 5, even in the first trimester, should be considered normal, right? So we get to know that it might be different, and this finds a place in British Journal of Obs and Gynae. Again, we're looking at a third kind of study where, again, it's a descriptive study. It's looking at trends in reproductive lifestyle factors in UK women. And you can see on the x-axis is defined the birth cohort. So 1930, let's say we're looking at what was the mean age at Menake of women who were born in 1930s. And you find that it was closer to 13. And as you go ahead in 1950s, the age at Menake has come down, and this is how it describes how the age of Menake is coming down, how the age of menopause is going up, it's expanding, and then of course you see a trend here. Here you could ask the question, this is a descriptive study, this is not hypothesis, there's no hypothesis to begin with, but when you see an observation like this, why is, you could ask the question, why did it rise, and why did the age at menopause, why is it falling from 1950s onwards? And you could maybe have a hypothesis. Is it because of increasing use of hysterectomies? Is it because of something else? And then of course go on to design another study. So first you have to observe, then come up with a hypothesis, ask the right question, and then of course design the right study, and similarly so on and so forth. So you see the importance of descriptive study. It's not an all goner. You don't suddenly jump at RCTs that this is what I'm going to do, right? So this also has its place of pride. Next, so this we already know, I'm just recapitulating it for you. Features of descriptive studies, it describes what, who, when, how, but not why. There is no study control. It's best for studying characteristics, frequencies, trends, experiences, undertaken when little is known about the problem. Results are presented as frequency and percentage if it's a numerical variable, but if it's a sorry, it should be the other way around. If it's a categorical, it's frequency and percentage, but if it's numerical, it's presented as mean plus minus SD. And these are hypothesis generating studies. This brings us to analytical research. Now, I told you that we are, this deals with the why of the problem. Why is it happening? And then you generate a hypothesis, you try and think of an answer, and you say this is happening because of this, and that is a hypothesis. And so of course you're trying to establish a cause-effect relationship, and you can't do that without having a comparison group. So these are the three key features of analytical research. You can divide them into observational or experimental studies. In observational, a simple difference is that there's no intervention designed. You're observing the participants in their natural environment, and in experimental you assign an intervention and then you see the results post the experiment, right? Now the question is when to use observational studies. Again, observational studies you would want to use when there is a new observation, and of course the hypothesis, or you think that you have a new research question and that there is data around you, you'd like to collate it, you'd like to link one with the other and then come up with a new answer. So when experimental, and second, you'd like to use observational studies when experimental research is not feasible. And you saw how the point FINER, F stands for feasible, why you cannot do experimental research in every situation. So like some examples are here, when the outcomes are rare, childhood cancers after use of ICSI. Again, how long it just takes forever to try and find out if ICSI is leading to childhood cancers, maybe 15 years or who knows how much. And then of course, because childhood cancer as it is rare, it's probably 1 in 1,000 or 1 in 5,000. That's the order you're looking at. Look at the numbers you would have to recruit. So it's not feasible at all. So time constraints again, and unethical. So let's say you had the proposition that donor egg IVF leads to higher incidence of preeclampsia, right? And that is now an established fact. But let's say this was happening before this could be established. How do you intervene? Do you do donor egg IVF, intentionally to try and prove that this is going to lead to preeclampsia? You cannot, right? Because this can only take the form of an observational study. So these are the reasons why you would rely on observational studies. Type of observational studies, there are largely three: case control, cohort, cross-sectional. Before I describe case control, you have to quickly understand what is these studies based on the direction that they follow. Now, case control design is a retrospective study. You know the outcome, and now you're going to the exposure, and you're trying to find out which of these exposures may have led to the outcome that we already have. So that's the case control design. So you're going from present to the past. There's a prospective cohort study. It's a longitudinal study. So you have population like which has been divided into two parts. They have similar characteristics, except that one has the exposure and the other doesn't. And now you follow them up to the outcome. This could take forever, or sometimes maybe you decide that I want to do it for 1 year. For obstetricians, the time period is very sort of, it's there, you can do it. 9 months, let's say that this is the modality of pregnancy, and I'm trying to follow if this modality of pregnancy, natural conception versus IUI versus IVF, is going to lead to this outcome, let's say IHCP, a little more in women at term. So that is what you're trying. So you would want to design a prospective cohort, and then it becomes a longitudinal study. You have a retrospective cohort also. Remember, it's a forward-looking study, even as a retrospective cohort, because here again, you are moving from exposure to outcome, okay? And I'll give you examples in just a short bit. And then you have cross-sectional. It's happening in the present. Cross-sectional are prevalence studies. You're not going to the past or the future, but you're basically going to people's houses or let's say OPDs and trying to find out if a certain kind of people have a certain kind of trait. That is what you would want to do with a cross-sectional. Now, this is a simple case control study design. And you can see that there are, first we identify cases. That's the first thing you do. Next, you select controls that are matched to cases. Third, you do measure the exposure or risk factor of interest in both the cases and controls. Fourth, you compare the presence or absence of exposure and come up with the statistical figure called odds ratio. And sometimes you also may need to do what is known as an adjusted odds ratio when there are multiple present and you want to find the influence of one exposure on this particular thing itself, right? So this is a simple case control design. Case control studies are good for examining rare outcomes, okay? So if you are, let's say, trying to see DVT in pregnancy, that becomes your case. DVT in third trimester of pregnancy and becomes your case. The control is third trimester, a woman of the same age but not having DVT. And now you're trying to find out what is causing this DVT. So you go back, look at their records, maybe look at their blood tests, and you find that DVT in third trimester of pregnancy is most likely a result of obesity, whatever. So there's some factors that you find more in them, some factors that you find less in the control group, and then you come up with an answer. Second is long duration between exposure and outcome. Case control is good. Multiple exposures or risk factors can be examined. Existing records can be used. Quick, inexpensive, right? So, however, remember you're looking at records. You are also sometimes interviewing the patients. And so this is going to be susceptible to recall or information bias. And whatever records you're looking at, you don't know if what was written was correct. So there's no way that you can validate information. And hence, control of extraneous variables is incomplete. Similarly, in a case control study, you cannot find out the prevalence of the disease, right? So DVT in pregnancy, basically you're picking up 10 cases of DVT and 10 cases of non-DVT in the same stage of pregnancy and then looking. So you don't know what the incidence of DVT in pregnancy would be, right? Based on a case control. Now we look at a cohort study design. This is again a very basic cohort study design. You have a study population and they have similar characteristics. Okay, you have to ensure that they have similar characteristics. Now within that, you are not introducing the exposure, but you know that one will have the exposure and the other cohort will not have the exposure. And now you follow them up prospectively or retrospectively based on their records to arrive upon whether who developed the outcome and who did not, okay? And then compare. The comparison here, the statistical term we use is a risk ratio, okay? And this is different from an odds ratio. It's a different way to analyze it. So for forward-looking studies, usually risk ratio is possible. For retrospective studies, you're still looking at odds ratio, okay? Now, one example here is, what have I written here? Endometrioma, infertility, laparoscopy, okay. So this is like, you want to know how in women with endometrioma who are infertile, will respond with after laparoscopy in terms of clinical pregnancy. Okay, so women who are infertile with endometrioma undergoing laparoscopy, whether they will have a clinical pregnancy or not. Okay, versus women who have not undergone a laparoscopy, whether they will have a clinical pregnancy, and you define a time frame that has already been spoken to you about in 6 months after laparoscopy. Okay, so that becomes a cohort of infertile women who have with endometrioma who've undergone laparoscopies, cohort 1, and cohort 2 is women with endometrioma with infertility who have not undergone laparoscopies, cohort 2, and then look at clinical pregnancy 6 months later. Okay, so this, in fact, so like I said, these are not watertight compartments. Cohort study design can also be a part of experimental studies. So in this case, in endometrioma example, laparoscopy is an intervention. It's not purely observational, but this still remains a cohort, right? So if you want a purely observational cohort study, one example that I can give you here is what is the natural fertility in women with PCOS? Okay, so how do you go about design? That's the question I want to know, and there's no way that I can answer it because all women who come to me with PCOS are likely to be infertile. So I wouldn't know if these women can be naturally fertile as well. So if I have to answer that question, I will have to go into the community. Okay, I'll have to define, let's say, the population of Rajendra Nagar, of women who are in the age group of 30 to 40 or some age group who are trying for a child. Okay, recently married women who are trying for a child, and now I follow them up to see who gets pregnant and who does not, and basically make 2 cohorts, one who has PCOS characteristics and one who does not, and then try and see within 1 year how many women conceived. So I then know that PCOS women within this community, about 40% might have had natural fertility. They needed nothing at all to do. And of course, the comparison group is there. Non-PCOS, you find that 60 or 70% women were able to conceive. Of course, you derive risks. And so you are able to know the prevalence of natural fertility in women with PCOS. Okay, so cohort studies have a stronger association with causality, examine multiple outcomes for a given exposure, good for examining rare exposures, can calculate disease rates, but the disadvantages are that larger numbers are required, they can be very expensive, long duration of follow-up is needed, and of course, there can be a loss to follow-up. Retrospective cohort studies will suffer from the same biases that case control studies do. Okay, now a quick example, again, of trying to tell you the differences between case control and a prospective study. Let's say your hypothesis was risk of IHCP is higher in IVF pregnancies than in non-IVF pregnancies. Okay, you could have 2 study designs based on how much time you have. Okay, first one is a case control design. So what do? You look at all records with IHCP, and these become your cases. You select controls from amongst IHCP negative cases. So basically, you're trying to match every other characteristic. So let's say IHCP cases were from the 3rd trimester. So I want to pick up non-IHCP cases also from the 3rd trimester. Age, you could also match for number of gestations. So, twinning or singleton pregnancies. Now you scan their histories and look at exposure, whether IVF happened in IVF pregnancies, what was the percentage, and whether IVF did not in the control group, whether IVF happened, right? So you find that IHCP women, which were about, let's say 50, about 5 of them had IVF, versus non-IHCP women who were about 500 and about 10 of them had IVF. Okay, now you make a 2 and 2 by 2 table and calculate the odds ratio, and then make conclusions that the odds of a pregnancy being conceived by IVF are higher, lower, similar to pregnancy conceived naturally in IVF. Naturally, okay, that's the end. So the other design is cohort study design. Here you are choosing a population. You are collecting all data of women conceived by IVF. Okay, so you actually are going to the IVF lab of your hospital. You collect, the names of all the women who have conceived by IVF. Also, you know the names of women from the same hospital who have conceived naturally. And in both these cohorts, you calculate IHCP rates and then come up with calculate incidence or relative risk, make conclusions that the relative risk of IHCP in IVF conceived pregnancy is this times over naturally conceived pregnancy. Clearly, cohort study design is a better design to come to any conclusions or to establish a cause-effect relationship. Okay. Now, cross-sectional, I'll very quickly come to the example itself. What percentage of women, now this is the question you're asking, attending OPD in hospital X have IVF pregnancies, okay? So you are looking at pregnancy. So these are the 4 cohorts you'll get, right? 4 kind of groups you'll get. IVF, they had and they have a pregnancy because of IVF. They've not had an IVF and they have a pregnancy still. Outcome, the 4th column, the 3rd square is IVF positive, pregnancy negative. They had IVF, but there was no pregnancy. And then there is no pregnancy and no IVF. So this is how you do a cross-sectional study. Basically, you're not looking at too much. You're dividing them into exposure and the outcome that you want, and you're gripping them into 4 categories and looking at what the prevalence of IVF pregnancy in a certain hospital is. So case control study, it might look very much like a case control study, but remember that case control study picks up a small section of outcome negative individuals and matches them to cases. That matching does not happen here. So this brings us to the last part of my talk, experimental studies. Okay, we saw that analytical research design can be divided into observational or experimental. Observational we saw was case control, cohort, or cross-sectional, and now we come to experimental study designs, where there has been an intervention introduced by the researcher. Okay, and when you talk about experimental studies, you might come across terms like controlled, uncontrolled, randomized, non-randomized, quasi-randomized, open label, single-blinded, double-blinded, or parallel arm crossover, factorial. Just a brief bit about all of these, right? So uncontrolled studies are basically a cohort on which an intervention has been assigned and you're looking at outcomes, okay? So you have 2 designs here within uncontrolled study. You could have single arm studies, or you could have what is known as a before and after study. Now, all vaccine trials, remember, phase 1 is a safety trial. You're doing it in a small set of individuals, and you know what outcomes you're looking for, any anaphylactic reaction, any other untoward reaction, and that is all that you are noting, that this vaccine in 20 people produced no adverse effects. That's phase 1 trial. There's no comparison as of now. Phase 2 trials are efficacy trials. So vaccine, coronavirus vaccine given. What am I looking at? The generation of immune response. What is the vaccine doing to the body and the body doing to the vaccine? So those are phase 2 trials. These are both single arm studies, right? Phase 3 is, of course, a controlled trial, and we'll talk. I haven't brought this here because it's irrelevant to uncontrolled study. Before and after study is what was the pain score before laparoscopic surgery? Do the surgery, and after again you assess the score. So that's a before and after. That's also a decent design, especially when you have outcomes like pain to be measured. Okay, now let's say in an unexplained infertility, we all do IUIs, right? And after doing an IUI, there was a live birth. Should I be able to say that this happened because I did the IUI, or did it happen because a spontaneous conception is also known in unexplained infertility, because this was going to happen any which ways, or this happened because I introduced that catheter into the lady and she got that sense that she's being treated, and that psychologically kind of made some changes in her, and that brought about the pregnancy. Okay, that's a question. So that's the job of a researcher, to always doubt what you're doing. If you start saying that I did this and everything was right because of it, and not ask these questions, then you are not a good researcher. Okay, so which is why to answer those questions, you need a control. Okay, this allows the researchers to determine how much of the effect is due to intervention. And here what you have, participants with similar characters, something like the cohort study design, right? You have similar characteristics, one that receives the intervention, one that does not, and then you study the outcome and calculate relative risk or risk ratio and say whether this helped or not, okay? Which is why you need controls. But then again, the question that remains is, and an intelligent researcher should ask this, that of course I assigned intervention to one group and I did not assign intervention to the other group. What if the characteristics within the interventional group favored the outcome any which ways? Okay, that's a question that we are supposed to ask. Okay, and here, and it is very, very possible that, let's say I did IUI, I said I'll do IUIs and I'll see whether natural conception takes place. So one group was subjected to IUI in unexplained infertility, and one group was subjected to just spontaneous conception. You allowed them to conceive naturally. I found that naturally this pregnancy rates are 10%, and in IUI it's 30%. But what if the women who were undergoing IUI are 25 to 30 years of age and have just 1 year of infertility, versus the control group, which average age is about 35 to 40, and the infertility duration is higher, right? So that itself can affect, which is why you need randomization. Why do you need randomization? So that every participant in the group that you have chosen should have equal chance of being allotted into the treatment arm or the control arm, and not be controlled by the administrator, because this reduces selection bias. Now that's a term that you'll come across. So randomization reduces selection bias. Types of randomization, quasi. Now a lot of us tend to do this. Monday, Wednesday, Friday, we will assign them to one treatment. Tuesday, Thursday, Saturday, we'll assign them to another treatment. But that's not done. That's not randomization, because maybe the units on Monday, Wednesday, and Friday favor one treatment, okay, and the other 3 favor the other, or they perhaps in their administration of the treatment, they might differ. So it's quasi-randomized. It will not find a place in meta-analysis, or a good quality meta-analysis, okay. Second is simple randomization, and this is what most students are expected to do. And a randomization is basically that, you know, like I said, each event has, and each participant has an equal chance of coming into group 1 or 2. So any of these examples you could take, but most commonly what students would do is use a random sequence table or a computer generated numbers. Most softwares have this, so don't worry, computer generated numbers are easy to generate. Then you come across these words, block and stratified. You needn't do this, but what block randomization is trying to do is that it is choosing a number, a random number. So let's say you have 2 groups, and you can choose a multiple of this, 4 or 6 or 8. So I choose a block of 4. Okay, now I ask the computer to give me a block of 4. So what it'll do is, in position 1 and 2, it'll put my interventional group. In position 3 and 4, it'll put control group. Okay, and then similarly there are 4 combinations that can be made. Controls could be here, and so that is one way of generating randomization. The reason why one would do block randomization is to absolutely equally allocate the numbers in group A and group 2, especially helpful in small studies where your sample size is small. Stratified, again, is a kind of randomization, and in fact it's the best kind of randomization, where you take into account that although randomization is done to equally distribute known and unknown factors, but stratified randomization is done when you think that one factor which could influence the outcome, age for instance, has to be equally divided between control group and this. And so you specially stratify, so less than 35, more than 35, based on age, and pick up, so to generate 2 different sequences for less than 35 and less than and more than 35, right? So that's stratified randomization. Any questions? I'm happy to answer on this later, but there is shortage of time, so I'm quickly running through the slides. Blinding, now that has happened, right? What most experiments will have to be assessed, right? The assessed, so I could be the assessor. What if I do an intervention and I'm trying to check something very subjective like endometrial thickness, okay? So my endometrial thickness measurement could be very different from my colleagues. I could say that this is 7.5, and then she tilts it a little and she says, oh no, it's 8.5, okay? So based on what I have used, I could change my finding. I might see a little more thicker endometrium than it actually is. So it is important to blind, not just the assessor, but also the patient. What if the symptom that you're trying to study is pain, and the patient knows that I've been given the treatment and not the placebo, and the patient says, or the placebo, and she says, oh, my pain is not relieved, right? So it's important to blind in order to remove biases due to assessment or due to other reasons, right? And then again, you have these 3 words that you can come across: single blind, double blind, all blind, open label. Open label is nobody's blinded. Clearly, all studies cannot be blinded. So again, we go back to that laparoscopy, endometrioma, infertility example. clearly, I mean, everyone knows that laparoscopy has been done and not done, right? So that becomes an open label trial, if at all. One word again that you'll come across is allocation concealment. This is slightly different from blinding because here the allocator, so the person who is assigning who goes to which treatment is the one who has to be blinded. And this is the thing is concealed in envelope. So it's a very specific term for allocation concealment, that envelope kind of thing that you do. So I don't know who's going to which treatment trial, right? So all of this put together, randomized control trial is the gold standard of research designs. It provides the most convincing evidence of relationship between exposure and outcome. And these are some other designs for RCTs. The words that you come across are placebo controlled, right? So one is placebo, one is this. One example of this would be progesterone gel versus placebo for luteal phase support after clomiphene citrate IUI. The second term that you'll come across is parallel arm. So intervention and control. So one treatment, treatment two, and both of them being done at the same time. That's parallel arm. So letrozole versus clomiphene citrate in obese PCOS is a parallel arm design. You have a crossover design. So where, again, what is the example here? The example is letrozole versus CC in ovarian induction. Again, the same thing. The same thing can be done by a crossover design, where women who start their treatments, let's say 100 women start their treatment, for 3 months they receive letrozole, and of course some of them conceive, let's say 20 of them conceive, 80 of them undergo what is known as a washout period for 2 to 3 months, and then enter the clomiphene citrate arm. Okay, and similarly vice versa. So the importance, I mean, the advantage is that it reduces sample size, the confounders are balanced, the same group receives both the treatments, there's a washout period. There could be a carryover effect, of course, so which is why you're introducing the washout period, and there is a high dropout rate because, you know, you are going through one arm and then the second arm, and so it's taking just way too long to get pregnant. There is a lot of chance that women may not want to continue into the second arm, right? And last is the factorial design. Factorial design is when you have two non-dependent confounders or non-dependent variables that can influence the outcome. Okay, so you basically within your population, you create 4 groups. One that receives, or these are treatments basically for independent interventions. So one group receives both A and B, one group receives no A and B, one group receives only A, and one group receives only B. And an example is like metformin and clomiphene citrate in ovulation induction in PCOS, right? So this will lend itself well to a factorial design because metformin action is not dependent on CC or vice versa, right? So now this is a quick look at what we have studied so far. Did the researcher assign an intervention? No, it is observational. Yes, it's experimental. Is there a comparison group? No, it's descriptive. Yes, it's analytic. Then you can put in the layer of qualitative or quantitative following this. Descriptive examples could be case reports, surveys, interviews, literature review. It could be case series, it could be cross-sectional or prevalence studies. In analytic study, you look at the direction of study, and outcome to exposure is case control, exposure to outcome is cohort, and then you have the cross-sectional, which is basically looking at everything within the present time frame. The experimental trial, again, so you have an intervention assigned. Do you have a control group? Yes, it becomes control group. I'm sorry. Are you saying something? All right. The last thing is meta-analysis. It also mentioned that I should talk about meta-analysis, so I'm just going to quickly run through it. Meta-analysis is a statistical method to systematically assess previous research studies and combine their effect into one quantifiable variable. It gives a precise estimate of the effect of treatment. And how you do it is basically, first you need to have a question. Then you have to assign what is it that you're looking for in the studies. You define inclusion and exclusion criteria. You do a thorough literature search, and the person who's doing the meta-analysis or the reviewer, the toughest part is doing a study selection, and 2 independent reviewers do this. So based on the criteria that you've already defined, you select the studies for analysis. Finally, you identify heterogeneity. So what was the intervention? What was the outcome? Whether the outcomes are clearly defined? How long did it take for them to define the outcome? All of this has to be studied, and some studies may have done slightly different or have reported different outcomes. This would increase the heterogeneity. Then you identify biases in the study based on those 4 things that I talked about: blinding, randomization, selection bias, allocation concealment, reporting bias, and all those errors. Finally, you assign a weight. Weight is largely assigned to studies, and this is based on sample size. Higher the sample size, higher the weight. And then you do what is known as a pooled sensitivity analysis to come out with the sum total of all the odds ratio to say that this is the result, whether it favors the intervention or it does not favor the intervention. Okay. You also do a heterogeneity analysis, and you report on publication bias through what is known as funnel plotting. Now, let us just quickly look at the example. I know a lot of that is like jargon as of now, but this is something that you come across. Okay, so this is a forest plot that most students will have to learn to read, and this is where I'll end my presentation, but not without explaining it. Okay, so what is this talking about? It's talking about the incidence of severe respiratory distress syndrome in women between 34 weeks and 36 plus 6 weeks given antenatal steroids. So for the longest time, we thought that you don't need steroids at 34 weeks or beyond 34 weeks, and we are looking now at whether giving steroids would help reduce, in this time frame, 34 to 36, would reduce RDS. Okay, so the first column is always the first author's name and the study in which it was published. Okay, so you see there are 5 studies here. The second column will talk about how many events took place, right? And normally this is divided into 2 columns, and the total number of cases in the corticosteroid arm. So 18 upon 228, in the control 50 upon 224. This has been given a weight of 20.4 based on the total numbers that the study recruited, and of course the variance that the study had. So risk ratio is 0.3. What does this mean? That it is 0.3 times less likely that women who received corticosteroids, their children would have RDS. Okay, and similarly, so on and so forth. Each one of them defines the number of events here, total patients recruited, and finally total with 95 is 165 upon 2787. This is 257 upon 2811. And here, this is the weight. Finally, it's a sum total of all this. It says 0.56. The confidence interval is 0.37 to 0.86. Less, it has moved to this side. So the balance has tilted on this side. All right, it's moved away from that little line which says this is no effect. And so it favors corticosteroid administration between 34 and 36 plus 6 weeks, right? So each one of these, when you see this line, this is a line of no effect. If it's touching this line, you know that there is no effect. But as you can see, apart from these 2 studies, so this box denotes relative risk, and the hands denote confidence interval. So even if the confidence interval touches this line, you know that this is not significant. Okay, so but in 1, 2, 3 of these studies, it does not touch, which is why it pulls the final diamond to one side of unity. All right. So this is the hierarchy of evidence based on study design. This is with decreasing bias. Of course, it lists everything that I have spoken of. Expert opinion is at the bottom, case series, time series, cross-sectional studies, followed by case control studies, followed by cohort studies, non-randomized control trials, RCTs, and at the top of the pyramid, of course, is a well-conducted systematic review and meta-analysis, right? And this is what generates evidence, 1, 2, 3, 4 in the decreasing order. Systematic review and meta-analysis will generate level 1 evidence, and so on and so forth. Well, I think I'll end my talk here. There are some questions which I had put out for students, but I think I've far exceeded my time. So I'm going to end my talk here.
Thank you, Ruma. I think you are really full of knowledge about types of studies, and maybe the PGs may not have got everything what you said, but I think it will stimulate them, and it will make them read, what they have to do when they want to do a study. It's just not picking up something and started doing it. I think it was a very, very comprehensive lecture, and I thoroughly enjoyed it. Thank you much.
Thank you, ma'am.
I think we can't take the questions now because we are already out of time.
Yes, ma'am, we'll take up the questions in the end then.
Yeah,
we had few questions for Dr. Geeta and Dr. Ruma. Yeah, we're exceeding time. So thank you, ma'am.
Yeah, thank you both the speakers, and we move on to the next session.
I would like to thank Yes, now I would like to invite Dr. Suvarna Khadilkar, the Editor-in-Chief, Jogi, to kindly deliver her Editor-in-Chief message.
Hello, I'm Dr. Suvarna Khadilkar, Editor-in-Chief of Jogi, the official journal of Foxy. Our journal was founded way back in 1950, that is almost 69 years back. And I really feel proud to be associated with this journal since last more than 25 years. I thank the President and Secretary of your society for organizing this workshop in your city, because it is very, very important that the students and the medical professors and students all learn the correct methodology of scientific research. The workshop is called Picsep workshop. The Picsep means the program for inculcating culture of scientific inquiry and pursuit. This particular workshop was the brainchild of our past editor, Dr. Mahendra Parikh. Since then, we have been organizing more than 100 workshops all over the country in many cities, many Foxy societies. In this particular workshop, we will be covering all aspects of medical writing and the research methodologies. We ethical aspects of medical writing, the plagiarism, the scientific misconduct, as well as we have medical statistics. So all these aspects of medical writing are very, very important for today's students, and I'm sure these workshops are going to tremendously help all the students. I have witnessed over the years, after organizing 100 workshops, that the quality of the papers that I'm receiving on this journal have improved a lot. And I hope that the same improvement continues from all over India, and one day this journal will be indexed in Medline. We are already indexed in Scopus, Embase, and so many other very, very important indexing agencies. I wish you all the best. I hope all of you enjoy this particular scientific research methodology workshop, and wish you all the best for your future. Thank you.
We would now begin with our next session. To chair the next session, I would like to invite our chairpersons, Dr. Dr. Harsha Khullar, Vice Chairperson, Institute of Obstetrics and Gynecology, Sir Ganga Ram Hospital, Delhi, and Dr. Amita Suneja, Head of Department, Department of Obs and Gynae, UCMS and GTB Hospital, and Chairperson, AOGD Oncology Committee. Ma'am, I would request now our Chairperson to kindly introduce our first speaker.
Yeah, thank you, Dr. Bhavani. So at the outset, on behalf of my co-chairperson, Dr. Harsha Khullar, and myself, thank the AOGD team, Dr. Mala and her team, for giving us opportunity to chair this session during this important CME, which is on research methodology. And the first speaker, can I have her slide, please? Dr. Bhavna. Actually, for nowadays, the manuscript publication has almost become an obligation for all our budding doctors. So it is very important to know in depth how to write a manuscript. And the art and science of writing a manuscript will be taken by our very senior member of the Foxy, Dr. Madhuri Patel. And so 3 things which I think is very important, which you will highlight, that ABC, anywhere you do anything, remember ABC, accuracy, B for brevity, and C for clarity. And manuscript writing is, first part is art. It is more of an art, then you have to be very clear. And to throw on light this, we have the speaker none other than Dr. Mrs. Madhuri Patel. She is a very active member of the Foxy. She's at present Deputy Secretary General Foxy, and she was Joint Secretary Foxy in 2009. She was a former committee member, FIGO preterm birth in the past, and she is Joint Associate Editor of Jogi. And she has been ex-HOD of the prestigious institutes of the Mumbai government hospitals, and now she's visiting consultant in Wadia Police Hospital and Elizabeth and Messina Hospital. And she has been awarded prestigious awards by the MOGs, that is Mrs. Shelza and Mrs. Narayan Pandit Award. And she has delivered many guest lectures, has many publications to her credit. And she has been part of the important book which won the Foxy Award for the best book. And madam, over to you for your talk. We are privileged to have you on this platform. Thank you. Dr. Madhuri, please.
Yes. 1 minute. I'll open my presentation. Thank you, Dr. Amita. Am I audible?
Yeah, yes, very much audible. Yeah.
Okay, thank you, Dr. Amita, for your kind words. I would like to thank Dr. Alpesh, Dr. Jaydeep, Dr. Suvarna Khadilkar, Dr. Mala Srivastava, Dr. Kanika Jain, and Dr. Mamta Dargar for giving me this opportunity. So today I'm going to talk about the art and science of scientific writing for the publication. Let me tell you that my job has been simplified after listening to the Dr. Geetha and Dr. Ruma. They've explained so well, so my job is really simplified and I must thank to them. So in early prehistoric times, all knowledge, including medical, was communicated orally by words of mouth and was transmitted down from generation to generation. Later on, prehistoric tribes developed primitive symbolic writing. With civilization, widespread navigation, large-scale shipbuilding, the commercial trading flourished. These needed good trading records and accounting. In 1200 BC, all knowledge got progressively documented on the writing media available like stone, wood, etc., and ultimately on papers. And today, majority of us are doing on the digital platform. With the advent of writing, medical knowledge ensuing from the observation, incidental finding, accidental discoveries, purposeful research and discussion at meeting spread in a written word, and thus many books appeared from time to time. When the professional bodies dealing with science, including medical science, sprang up in the Western countries, they published the proceeding of the meeting. So in due course of time, there were medical journals, many medical journals were published, and Lancet is one of the earliest medical journal, appeared in 1823. That is around 200 years back. Currently, thousands of medical journals are regularly published for your research work. So every research, irrespective of its outcome, must be publicized and published to fulfill the main purpose of conducting this research, which is to benefit for the sick people in particular and also the society in general. Research outcomes benefit society by influencing policy making, administrative decision, and patient management. And in this pandemic COVID-19, we are seeing how much is the research is useful. We are studying the mild cases, moderate cases, severe cases, and what is to be, given, that it has been, almost, told to the us, from the government of India, what is the they've analyzed.
रास्ता बना दिया, यहाँ से बाहर निकलते हैं, अंदर कहाँ से जाते हैं?
And so it is very, very helpful for the policy making, administrative decision, and patient management. So the research is very, very necessary. Publicizing research at conference takes it to your peer attending the conference. So you know, your peers know that what are the work you are doing, what is the research you are doing, and what is the impact of that research. It must be also published in a prestigious journal since they have far wider reach and much long, life. But I must tell you over here, before, going to my presentation, other part, I must say that, this rejection rate of the highly prestigious, prestigious journal are very, very high. It is almost 85 to 90%. And the very good is about 75%, good is about 50%, and the others are 25%. So when you want to do in a prestigious journal, you have to look into that what is your job profile which requires this research work, and what want you want from out of it. So depending upon that, you can select three journals. So if first refuses, then second you can go, and third you can go. So now let us come back to the presentation. Until the middle of the last century, there was no uniformity in the style and format in which different journals were used for to publish the research articles. Some would publish the abstract, the other would publish only summary, and some would not publish both. There was no fixed order, no uniformity in the publication of the reference list also. So what happened in 1950? Bradford Hill proposed IMRD structure, that is introduction, material and method, result, and discussion. For the text of paper, which is now almost universally accepted for publishing articles presenting the original research work. Now there is another part that the title, abstract, keywords, acknowledgement, references, they have also become integral part of the published article, and it is often referred as TAKA. In 1978, a group of editors of journals met in Vancouver in Canada and formulated uniform guidelines for submitting manuscripts to their journal in a standardized format. And this is called as Vancouver Group, where our journal, that is Jogi, Journal of Obstetrics and Gynecology of India, we follow this Vancouver Group pattern. Vancouver Group has evolved into International Committee of Medical Journal Editor, that is commonly known as ICMJE, and they post their uniform requirement on their website, that is www.icmje.org. So if you want anything, you can go from that, and whichever journal you want to publish, the journal always gives you, the idea what type of study, what they want in their manuscript. So even the journal you can ask from them. So let us come to the anatomy or structure of the paper. It contains title, short title or running title, authorship, abstract, and keywords. The text is under the following heading, which is introduction, material and methods, results, discussion, conclusion, acknowledgement, vested interest, reference list, tables, illustration, graphic, photographs, etc. So the title should be short, specific, relevant, easy to grasp, and don't use abbreviation in your title unless it is universally accepted. Now, avoid dramatizing the title. It is a business of the journalist. So what a businessman has to write, what he will write or she will write, gunshot therapy for iron deficiency anemia. So here we don't know what does he mean by gunshot therapy. But if we write in a proper manner, that is single intravenous dose of 1 gram FCM for iron deficiency anemia, it is very, very clear from these titles what is your paper about. Do not use uncommon words. That is example, clinical research in obstetric and gynecology, or Baedeker for busy clinician. Now, majority of the people will not know what is Baedeker. I also came to know when I started working on it, and the Baedeker is a simple word, it is a guidebook. So if you write a guidebook, everybody will understand, but Baedeker, we have to search in the dictionary, and that becomes difficult, then we don't go anywhere. We don't read that paper. So you must, use the simplified word. The title should be readily conveyed to the reader what the paper is about and what all she or he expects to find in the paper. If the title is not clear, your paper will be ignored. So the ideal title should be Role of Laparoscopy in Vagina Hysterectomy for Non-Prolapsed Uterus. For some gynecologists, the non-prolapse vaginal hysterectomy is very easy, but some of the other people, other gynecologists, they may have a laparoscopic role to make it simplified. So it tells us what are the effects and what are the side effects. Similarly, trial of 2 versus 3 doses of human papilloma virus vaccine in India. All of us are aware now we have to give 3 doses, but before that, they have analyzed everything, and now these are the clear-cut titles which tells the reader what is there in the paper. So at the right upper corner, when you open the journal, at the right upper corner, on each page or on alternate page, there is a called a short or running title. So why it is given that when you open the journal, pages, the running title will tell you that which, article we are dealing with. So this is for the convenience of the reader and should be less than 8 words. Now the capsule. The first thing that the readers, when they receive the journal, they just open the journal and see the content of the journal. So the capsule, after content of the journal, there is a title, and below that the capsule is written, and it tells about the essence of the paper in the nutshell, brief information of the content, and 2 to 3 sentences about your paper. So you immediately read it in 2-3 sentences and you get the idea, and then you decide whether I should read this article or not. So in the capsule, we used to, in our journal, we used to publish capsule, but some of the other now we are not publishing that capsule in our journal. The reason so far I don't know. So examples of capsules are, it addresses the use of prophylactic HPV vaccine, including who should be vaccinated, at what age, as well as summary of policy and implementation issue. So it tells everything about the paper, including policies. Now, authorship. It gives personal happiness and rewards, helps getting grants, brings professional appreciation, and enhances one's career and builds up reputation. I know abroad, UK and USA, the consultant or the teacher, professor, assistant, they get the grant depending upon their, how much work they have done in the research, and they are rewarded accordingly. So it is very, very important to publish your research work. Authorship of the paper should be decided in the beginning of planning the research work, so that every member of the team knows his or her contribution, and according to that, they will get the rewards. If it is not done, so it generates argument, bickering, and ill feeling at the stage of writing of paper. So this should be avoided. So once you decide, I want to write about this research, or I want to carry out after that publication. So before that research work, you must decide who will be your author and what they will do the work, and according to that, they will get the reward. So after research is done and then you start writing, then everybody would like to be your first author. So you always clarify from the beginning of the research work. Authorship should be earned by contribution to the research and neither bestowed upon nor solicited. So what can be the what authorship can be contribute? It can be contribute in the form of conceiving the study, developing the methodology, rendering valuable guidance at the various stages, giving creative inputs, analyzing and interpreting data, substantially evaluating a large data, preparing and finalizing the manuscript. So these are the people who are working on it deserves authorship. Merely heading the unit, department or institute, allowing the study, permitting the use of equipment, collecting data, giving moral support, they do not justify authorship. In the past, the department OM's name was always mentioned as an author out of the courtesy. Ideally, it should not be done, because once the departmental head becomes the author, the person also carries the responsibility of the content of the paper. And in the journal, we are seeing there are so many, complaints about certain papers. And so we have to remain away from this situation, because we have to give explanation. In the journal, we receive lots many complaints regarding such, research paper. So one school thinks that the research paper should have only contributors and no authors, but I think none of us agree. We want authorship. In the past, there were 4 decades back, most of the paper has 2 to 3 authors. But now there are multiple authors and many journals put limit of 8 to 12 authors. And some journals, if there are more than 8 to 12 authors, then they also put at the footprint, that these are the another authors. So the authors, many journal gives many authors name. Now the authors order of the author's name according to Cochrane collaboration prints the name in the descending order of their contribution. If somebody has done maximum work, then that becomes the first author. Now another common practice is that first author is one with the maximum contribution, and at the last is one is the senior member of the team. In manuscript, the name of the each author is written in surname followed by initial. Some cultures don't mention the father's name, while some cultures have no surname. So you should put as the author name as it is what you are using, then put designation and which institute you are attached. It should be on a A4 size, 12-point size, double space for editorial comments and correction, and number the pages. Now in today's scenario, our journal and most of the journals are online submission. So the hard copy, issue hard copy is not there, but 12 font size and double space should be maintained, and use appropriate punctuation marks. Otherwise, it can change the meaning of the sentence. I can give you example where the punctuation, that is comma, is not put properly. So it will change the meaning entirely of the sentence. So a woman without her man is nothing. And if you write other way, a woman without her man is nothing. So both sentences, meaning has changed because you have put at the wrong places the punctuation, that is comma. Now there is something called as gifted authorship. Here the authorship is gifted. There is no contribution from this author. It has to be commanded and not demanded. So what do I mean by that? Commanded means my senior is there, and the junior wants the senior name should be included out of respect. So the junior will go and say, sir or madam, can I include my name? That is out of command. And there are some seniors, they say, if you don't put my name, I will not allow it to publish. So it should not be demanded. Because when you, and there are some juniors, they are very intelligent. They would like to put seniors name who are well known, so it brings prestige and authority to the paper. And but also gifted author also should remember it brings responsibility also. Some of the juniors, they are very smart, they would like to mention their seniors and superiors name to remain in good books. Now there is something called as ghost authors. Many pharma companies often engage professional writers to write studies involving their product in a way that glorifies their products. So they are called as a professional writers. In a pharma company, there are researchers, but this professional writer takes over them, and then the professional writer glorify the product. It is not good because it is a detriment of science and ultimately patient care. So in a prestigious journal, it has been found that 11% of the article published in 3 highly prestigious peer-reviewed journals had ghost authors. So this should be eliminated. Now summary was displayed. Now the summary is displayed by the abstract. Invariably, it is printed, abstract is printed in the beginning of the paper. It gives the gist of the paper in just 150 words. Today, most of the good journals print a structured abstract consisting about 250 words. That is aims and objectives, material and methods, results and conclusion. In the abstract, you should not use abbreviation. Abstract is a very important part of the paper because most readers read only the abstract. Project all the important aspects of the paper, and this has a wider reach than the paper. Now, after exercise, there are keywords. There are 5 or 6 words or short phrases. It is meant to locate your paper in a various electronic database of indexing agency. You should not use abbreviation, at the same time no non-specific term and long phrases. Use MASH, that is Medline Subject Heading, which you will get majority. These are the public database and you will get the majority of medical journal on that. Now let's come to the text of the paper. As I have already said that it is a IMRD pattern structure. So in the introduction, what it is your goal is to convince the reader about the importance of your study. Begin with current knowledge of the research topic. Emphasize the gaps in this knowledge, especially the one that your study aim to address. And present with hypothesis and the study design adopted by you to test this hypothesis. The introduction should not be having more than 2 to 3 references, and it should not be more than 2 to 3 paragraphs. Material and methods. The type of study, the design of study, which both the speakers have explained very well. Study setting from where it has been done, criteria for inclusion and exclusion, source of participants, whether it is from the hospital, clinics, or by advertisement. You should give us the sample size, full details of the intervention carried out, criteria for assessment of the intervention, follow-up details and drop out with reason, and you should use statistical tools employed for evaluation of the finding, and there should be ethical committee approval. It will also give us clinical trial registration number in our journal, or this is a must. Now, this material method serves 2 purposes. It convinces the reader how research was conducted, and the reader will evaluate himself or herself how authentic this paper is. Some readers may want to replicate the study exactly it is done, so therefore you should provide all the details about your paper. Results give actual facts, can be written in past tense. Present statistics, use graphs and tables and bar charts, pictorial presentation, flow chart, algorithm, pie chart, etc. Remember, in your result, you should not put any references. This is your study, so the references will not come in result. You should do in a chronological order, and you should write p-value and such statistical analysis data in your result. Discussion is the most important part of the paper. Discuss the studies that support your contention as well as those they do not. So if some study they do not, you feel they don't agree with your result, and some study they agree, you have to put both the studies which they agree or where they don't agree. Discuss about important findings of studies, mention short findings and limitation of your studies. Discuss the regular finding also, can discuss in table format also. Discuss the implication of finding of improving clinical practice, and provide information as well as knowledge to your study. Now, I would like to mention that there are so many papers we receive in the journal that they have a similar type of studies, many studies. So on that basis, if the topic is repeated, we may have to reject. So you have to have some studies, which are not, the publication are not on that topic. So such studies you should take up. So conclusion, the essence of the paper based on the finding of your study should be precise, clear and unambiguous, totally supported by your study, and well balanced without any bias. And you may say that larger studies or related studies are recommended. You should always acknowledge your departmental head and dean for your studies. And one more thing, your juniors who may do typing work or who may do something related to this, your junior will be, if you acknowledge your junior like interns and all, it will be really carrying a weight for them as an acknowledgement. Now there is a vested interest or conflict of interest. It is always mentioned in the paper when you want to publish it. These are the sponsored by pharma company, can influence the judgment of the author. right? Editor may not have objection, but readers should know about these types so they can have their own judgment on the reliability of the research of the study. In our journal, we are not taking such type of articles. Now at the end there is a references where it has written surname and then the initial and then et al. It mentions about your title of the paper, ovarian cancer in Europe, cross-sectional trends in incidence and mortality in 28 countries from period of 1953 to 2000. Then you mention about the journal name, then you mention about the year, then your volume and number and the page number. So references when you take, you should maintain in this Vancouver pattern. You should write in this Vancouver pattern. And then in our journal, we also ask for the documents to be attached. Signature of all the authors, particularly format is provided by our journal. So when it is published in our journal, the copyright issues, they don't come. And even though you have written the registration number of your clinical trial, still we need ethical committee approval documents. So what will happen? You will not waste your time. If you attach all these documents, you will not waste time, because otherwise as an editor, we return the paper and ask them to resubmit after all these documents. So everywhere in the journal, whichever journal you want to publish, all the instructions are given. Please go through it and you write your manuscript accordingly. So at the end, I would like to say there is no way to get experience except through experience. I thank all of you for your patient hearing. And I would like to also thank our chairperson for giving, for this session.
Thank you, Madam Patel. This was such a practical and relevant talk. And very in simple way, you have explained each and everything. And the persons who are involved in paper writing, everything is so crystal clear. And really, I loved your talk because it was very simplified. Thank you very much.
Thank you, Dr. Amita. Thank you very much.
Thank you. So I hand over the platform to Dr. Bhani, please.
Now, I think I'm Dr. Harsh and I'm going to introduce Dr. A.G. Radhika. And before that, I think I must say that it was a beautiful talk by Dr. Patel. And she has simplified it in such a way that anybody can write the paper if they follow all the instructions which has been explained to them by Dr. Madhuri.
Thank you.
Okay, now we invite Dr. A.G. Radhika, who is a senior consultant with University College of Medical Sciences, GTB Hospital. And she's got special interest and expertise, evidence-based healthcare and guideline development. And she has been recipient of many awards like Visiting Professor Award in 2019 ICOG, then Foxy Korean Award in 2019 Senior Category, Foxy Best Paper Award, then National Coordinator for Foxy Clinical Research Committee. And she has been chairperson for Multidisciplinary Committee of AOGD and Skill Workshop for AOGD. And she has been editorial in the editorial board for NARCHI. And she's member of South Asian Cochrane Network, member Guidelines International Network, expert reviewer for Jogi, IJMR, and JSAVE FOG publications. And she's got publications in international and national journals and editor of 2 books. She's going to tell us the next step, that what should be the literature search and referencing, because once you have collected all the materials and everything is there, then you have to see that, you have to compare it with others also, that whether this work has been done before or not. So Dr. Radhika is going to explain to us about that, how to do all these things. And she's a very good speaker and she's going to highlight on this. Dr. Radhika, please.
Thank you so much, ma'am. Thank you for the introductions. So very good afternoon to all. I wish to thank Foxy, Mala and Geeta for having invited me here today. So in fact, to actually basically say what I'm going to touch upon today, it is going to be divided into 3 parts. I am also to speak on the importance of evidence-based healthcare for the clinician. So what I wish to do is I wish to start, with the because there are 3 interrelated topics. So I wish to amalgamate all the three. That is, number one, the importance of evidence-based healthcare and relevance to clinical practice, followed by literature search, and then lastly the referencing software. So I wish to start straight away, earliest possible. I'm trying to share. The reason for my hesitation in my talk is because I'm trying to share my screen, and it's taking a little while. So I'm just doing that straight away. So is my screen visible now?
No, ma'am, no, not yet visible.
Okay. Is it now?
No, ma'am, not yet seen.
Nothing is seen?
No,
No,
Amit,
not,
will you
not,
please help?
not yet.
Hello.
Now?
Oh, no, it's not visible.
No, but I'm sharing my slides, no? Is it visible now?
No, we can't see.
My God. So I will need to go to the other computer then. What is seen on the computer, Deepika? Can you just tell me what is seen?
It's a dark screen, ma'am. We don't see your screen.
Nothing is seen?
No, it's just a dark screen. You could try logging in again, ma'am. Maybe that might help.
No, but that I think.
Now we can see your face. Now we can see your face.
It says I am unable to share because the admin has disabled the screen share for this meeting. Deepika, can you please see from your end?
1 minute, ma'am. Ma'am, I'll ask my team to look into it. Are you joining from?
Yeah. Meanwhile, while we are doing all this, I am also opening my other computer and trying to join from the other one.
Yeah.
Is what it is saying.
Ma'am, you are sharing your screen.
Yeah.
So, is there any problem that you're having? Let me know what problem.
No, it says admin has disabled screen share.
No. It cannot be, ma'am. There is no disable that we can do. It's always all are open to share.
Yeah. But that is a message that I'm getting here.
I'll just contact my IT.
That's okay.
Till that time, can you say a few words?
Yeah, actually everything is so much slide based.
Yeah, I understand.
So it's very unfortunate.
Dr. Madhuri Patel, can I say something, madam? You go to the screen share screen, and you keep your presentation open, madam.
Yeah, I have done all that.
Then you do double clicking then over there.
Yeah, I have done all that.
But still it is not happening.
The message is admin is restricted my screen share.
So you have to talk to admin.
Amit,
Yeah,
can
ma'am,
you help?
It is not there. It is anybody can share this.
Yeah, there is nothing like any restriction that the admin can put in Zoom. If that happens in Cisco, ma'am, WebEx.
I'm sure there is a problem somewhere because from your end,
Can
I'm sure
can you log out and then rejoin?
I am now joining from my other computer. I think.
Or you send me your PPT, ma'am. I'll run it and you can then see.
Okay.
You have my email? Ma'am, do you have my email?
Yeah, I'll do that. Deepika, I'm just starting my launch meeting from the other computer.
Okay.
I think by the time that happens, I'm sending you the mail also.
Okay. Okay.
The video is coming on. The problem is with the slides.
When you share screen, ma'am, what does it say?
Unable to share, your admin has disabled screen share.
No. Nothing like that happens with. Are you joining from Mac?
I'm joining from iPad.
iPad. Amit, iPad को कैसे करते हैं? You know better.
Can't say because there's a problem. Can you show me the iPad?
I can see Dr. Vanamail there. Would you like to start his talk? I think I can do that later.
Yes, that would be Dr. Harsha Kullar, please, ma'am.
I think we can call the next speaker. In the meantime, I think Dr. Radhika, you can see for your slides. And we invite Dr. Vanamail, who is going to speak on basics of medical statistics.
Yeah.
Is it all right, Dr. Mala?
Yes, ma'am.
And Dr. Radhika, okay, if we can call the next speaker.
Yeah, madam, that is my suggestion. That would be the best.
Okay, okay. Dr. Vanamail, I think you can start your talk. You're going to speak on basics of medical statistics. And Dr. Vanamail is the professor of statistics and demography at Department of Obstetrics, Gynae, AIMS. And he has undertaken many projects like WHO Project 2, Bill Gates Foundation 2, Institute Funded Projection 5. Current projects at hand are 3 ICMR projects, 1 DST project on female genital tuberculosis, and 5 institute projects. So, Dr. Vanamail, I think you can start your talk on this thing and enlighten us. Are you there, Dr. Vanamail?
Yes, ma'am. Thank you. Good evening.
Good evening.
Hello.
Yes.
Can you hear me, ma'am?
Yes, we can hear you.
Yeah. Thank you very much. Thank you, ma'am. My topic is concepts of. I think for next 1 hour you will not be like this. The important statistical terms, that is, you should know what is the population and what is the sample. Population is a set which includes all characteristics of the population, like disease status with the different stages, continuous measurements like BP, HB, height, weight. These are all continuous variables measurement, and count variables like distribution of patients by occupation, education, then socioeconomic status. These are all variables of interest for a researcher. It is available in the population. From the population, we are taking sample. That is a subset of the population. And you must know what is the different terms in the, well, before deciding about the sample size. What is the target population?
Sir, please put it on slideshow.
Yes, ma'am. Is it clear?
Not yet. You put it on slide. Yes, ma'am.
Yeah.
Yes, sir. Now it is fine.
Yeah. And before going for sample size calculation, we must know the different terms. What is the target population? Target population is a part of general population which satisfy according to your objective of the study. For example, if we want to study the anemic prevalence among reproductive age group, so in this case, your target population is the reproductive age group. Again, if we want to study anemic prevalence among reproductive age group in the urban area. So your target population is all reproductive age group residing in urban area. That is the target population. So always target population is not fixed. It is a part of general population which is satisfy according to your objective of the study. Then what is the sampling unit? Sampling unit may be individual. The smallest sampling unit is individual. The next sampling unit is household or community. So the largest sampling unit is the community. The smallest sampling unit is the individual. What is the sampling frame? So list of all the sampling units from which sample is drawn. So you must know complete details of the sampling target population. So scheme, the method that you are going to take samples. For example, there are different methods are available like random sampling, stratified random sampling, systematic sampling, and cluster sampling. These are all called sampling scheme. The sampling scheme will vary according to your objective of the study, whether you want to go for random sampling, systematic sampling. Again, each sampling scheme will have its own merits and demerits. If you have sampling frame, complete sampling frame, then you can very well go for random sampling. If you don't have sampling frame of the study units, then either you can go for systematic sampling or cluster sampling and whatnot. Next, why sampling is required? Suppose if you have enough resources, manpower, and time, you can very well go ahead with the covering entire target population. No one is going to prevent you. So in that case, sampling issue will not come, right? In majority of the cases, the manpower is limited, resource is limited, and time is limited. In that case, you'll have to get maximum benefit from the target population. So with the less cost, less field time, with more accuracy. So you should get maximum benefit with the available resources. Again, when you take sample, the chances of committing error is very less because you will employ only limited number of persons to data collection. When only limited persons are involved, the chances of committing error is more. Whereas when you employ more number of persons in the entire target population, the chance of committing error is more. That's why less cost, less field time, and the data accuracy of data will be more by minimizing the error. Right. So we have decided we should go for sample. And what is a sample size? How much sample size we should have? Sample size determination is an important step in the planning of any epidemiological study. An adequate sample definitely will ensure better result and a more reliable information. And if you have inadequate sample, is not only wastage of time and wastage of resources, it will give nothing. That is, it will not add any benefit to the scientific world. So different study design need different method of sample size. Sample size is not a fixed one. It will vary according to type of the study that you are going to plan. So again, I want to emphasize that one formula is not sufficient to calculate the sample size. It will vary from one study to another study, right? Determining sample size is very important issue, I told you, because samples that are too large may waste up time. And again, when you have very small sample, that may not add any knowledge to the science. So to make a balance between large sample and less sample, you should decide what is the optimum sample size required for your study. Sample size. Again, you can go for sample size in two approaches. One is a non-statistical approach, another one statistical consideration. If you don't have sufficient manpower and enough resources, you can go for non-statistical consideration. That is, here sample size will not have any issue. There is nothing but your convenient sampling or purposive sampling based on your available resources. What is the statistical consideration? So under statistical consideration, you should have precision of the estimate of any prevalence or mean and the expected prevalence of the disease. So more accuracy and precision is more when you apply statistical consideration. What resources do I need? For example, if you want to study 50 participants in your study, about 5 individuals per year will be enrolled. So therefore, you'll have to take 10 years to finish the study. Again, how much money do I need? If you spend $100 for conducting a lab test per one individual, then you need to have 50,000 US dollars just for lab tests. So all these things will have to take into account before calculating the sample size. Then another issue is time. If you may have only 2 years to finish your thesis work, but 50 people in that year is possible during that study period. Again, is 50 sufficient number of people to test your hypothesis or not? So again, this is another important issue. Time factor is an important issue. At the same time, you should not compromise with the minimum sample size. Okay. So I told you why we should go for sample size calculation. Your sample size is very important in the sense that under hypothesis test, you need a good chance of showing decided differences. And again, you should justify the funding agency. Suppose if your project is funded by any external agency, then you must convince them that, okay, your reasonable chance to obtain the conclusive result will be obtained with the available fund and the resources. So that is one aspect. Another one important aspect is if you have sufficient sample size, then for publication will not be any problem, because always a reasonable sample size with the good power will support for any publications. That is also one important issue. One is the funding agency. You'll have to show the justification for funding agency. Another one for scientific publication aspects. Whatever you are getting funding, that should be justified according to your sample size by minimizing the error and other resources. Then, what do I need to know to calculate sample size? Only you cannot calculate just if you go on to ask statisticians, you will not tell simply this is the sample size, because sample size is not readily available in his pocket. So that sample size calculation is based on the educated guesses, that is based on the available literature. Again, it all depends on your hypothesis testing. So there is no magic involved, only statistical and mathematical logic and some algebra is involved, but you'll have to give some inputs to the statisticians. Then only you will give you the proper sample size calculations. Then again, sample size vary according to your population characteristics, according to your study objective. Then what are the factors related to the sample size? That is, I told you characteristics of the study design and quantities related to the research questions defined by the researcher. These two things you'll have to study, do some homework on the study population characteristics and what are the quantities you are going to measure in your research projects. So where you can get these informations? From the related published studies, you can get the information, or from pilot studies. If information is lacking, again, there is no good way to calculate the sample size. Always sample size is based on your previous published studies. And if you don't have any information from published literature, then you can go for pilot study. Pilot study, the small sample size, you may use that information to calculate the sample size for your main study. Pilot study again should be carried out as per your main study. It should not be conducted in the hospital level, and based on the hospital data, you cannot go for sample size calculation, because hospital visiting patients is different from the field community setup. So pilot study should be carried out as per your main study. Then only you can that information will be more reliable. So use that information to calculate the proper sample size. Again, if you don't have any previous published studies, again you don't have time to do pilot study, then no other way you'll have to go for purposive sampling or convenience sampling. Again, either purposive or convenience sampling, will be lack of scientific merit. Okay, what is a good sample? So you should have accuracy, that is bias is absent from the sample. Always you can minimize the bias, and more precision. Sample represents the population, so you should have more precision. So it's always good sample will depend on, there are two types of error in statistics. What is called the two types of error? Let me tell. So in a truly representative sample, you should have proper representation by taking adequate sampling, by adopting adequate sampling method, and small sampling errors. Sampling errors may be avoided by using proper sampling method like random sampling or stratified random sampling. Suppose if your population is very heterogeneous, then you can classify the population into different strata according to either disease condition or by socioeconomic status or whatnot. So stratified sampling can be adapted. Then your sample size must be viable in context of funds available for research study. So again, you should take into account the available fund for any research study. Then any systematic bias can be controlled in a better way. So there are some random error and as well as systematic bias can be controlled in a planned way to reduce these two type of errors. What are the types of error in statistics? There are two types of error. One is type 1 error and type 2 error. What is a type 1 error? False positive. That is related with the type 1 error. What is a false type 2 error? Detecting the false negative. So false positive and the false negative is all depending upon your diagnostic tools or equipments that you are going to use. So in statistics, it's very difficult to reduce both the type of error. That is type 1 error and type 2 error. And the probability attached with the type 1 error is called level of significance. That is called alpha. And the probability of committing type 2 error is called beta. Okay. So while planning the study, you must decide the level of significance. That is alpha. It should be maximum 5%. You should not go beyond 5%. Less than or equal to 5%. That is your level of significance. That is called alpha. That is probability of committing type 1 error. What is the probability of committing type 2 error? That is called beta. So always beta should be maximum 20%. Because why I'm telling 20%? For any study, you should achieve minimum 80% power. So if you set beta equal to 20%, that is beta equal to 0.2, your expected power is 1 minus beta, that is 0.8 or 80%. So both the type of errors are important while calculating the sample size. You may ask, your power will be, by subtracting beta, you'll get power. But why you should have alpha? Because when you calculate the power, first thing that you should get the significant result for your outcome variable. If you don't get significant results, then calculating power is of no use. Definitely, it will be less than 80%. For example, if your significant result shows that p value equal to 0.06, even 0.06 is not statistically significant because already you set the significance level less than 0.05. Even at the time of when you calculate the outcome variable, and if you get level of significance that is p equal to 0.06, then even that case also your outcome is not statistically significant. So I told you what is a p value. So there is a difference between p value and alpha value. Alpha value you are setting at the time of preparing your thesis protocol. For all statistical data, p less than 0.05 will be considered as a statistical significance. But when you do the analysis, if you get level of significance is 0.06, that is called your p value. So always p value gives the exact at which level your outcome is statistically significant. Okay. So when you should go for p-value, first of all, you should get statistical significance. Alpha should be less than level of significance should be less than 0.05. Then only you can try, okay, at what is the p level that my result is statistically significant. So if you can try to get the exact p-value. If p equal to 0.001, that means highly significant. That is called the p-value compared to alpha. Alpha is just whether it is significant or not. Further, of the interest that you can go for exact value at which your outcome is significant. That is called the p-value. Right. So when you calculate the power, first of all, you should get significant results. Then only you can go for calculating power. Otherwise, when you don't get significant results, there is no point in going for calculation of power. Power, again, why you should go for post-hoc power calculations? Because at the time of framing the study, you must have assumed some values based on the literature available. For example, comparing the difference between two group means. To detect statistical significant difference between the two group means at alpha equal to 0.05, power equal to 80%, what is the sample is required in each group. Then in that case, your power will be 80%, but when you complete the study, actual power you may calculate, that is called post-hoc study power calculation. If you get highly significant, then your power may be more than 80% or 90%. That is more valid for your study. So what is the type 1 error and type 2 error? I just am explaining. Probability of type 1 error, that is probability of rejecting the null hypothesis when null hypothesis is true. So alpha equal to maximum 0.05. So what is the that is smaller error, greater precision, need more information, and that will have large sample size. Always alpha should be maximum 0.05. Then only you can expect error will be small, greater precision, and more sample size will be involved. Beta, what is that is called, I told you, this is called type 2 error, beta, and it should not be more than 20%. So probability of accepting null hypothesis when null hypothesis is false. So that is called beta, and the power of the test is 1 minus beta. That is more power, smaller error, need larger sample size. When you set beta equal to 0.1, your power of the test will be 0.9. In that case, your sample size will be much higher than the 80% power. So more power, smaller error, and need larger sample size. So that is the difference between alpha and beta. So first of all, when you want to have adequate power, your alpha value should be minimum, and beta also should be at least 0.2. Then only you will have minimum 80% power at 5% level of significance. So the statistical power of the study is the power or ability of the study to detect differences if the differences really exist. It all depends on two things: the sample size, that is number of subjects, and the effect size, that is primary outcome effect size. For common studies, for example, if you want to compare two groups of the blood pressure level between smokers and the non-smokers, so usually whether the blood BP measured in two groups is statistically significant or not, that is mean value. So we can do T independent test. By doing T independence, if you get statistical significance, then only you can think about power calculations. If you don't get significant results, there is no point in going for power calculations. So if you know the sample size and the differences, if it is statistically significant, then only you can go for post-hoc power calculations after completing the study. Right. So these are some few studies I have highlighted. What are the inputs you should provide to the statisticians before going for him to calculate the sample size? For example, if you want to assess the mean value, the study type is cross-sectional, and sampling method is more reliable method is random sampling, then what you need to give to statisticians? Mean value of the previous published literature and the standard deviation, and of course acceptable error margin. So these three values are required to calculate the sample size at 5% level of significance with 80% power. So that is for mean value outcome. If the primary outcome is prevalence, then again the study type is cross-sectional, sampling method is random sampling again. Then based on the available literature, you may provide what is the prevalence that they got. Again, you can assume some acceptable error margin. Acceptable error margin, it should not be more than 20%. Again, for either for mean value or prevalence, the acceptable error margin should not be more than 20%. If you allow just to reduce the sample size, if you allow more than 20% error, you will have very less samples, that may be underpowered. Then difference in mean values between the two arms. For example, you are giving some intervention and you want to assess is there any reduction in the mean value compared to other arms. So interventional prospective study, then sampling method, this is RCT. When you go for sample calculation, you should have mean value of one arm and standard deviation, mean value of another arm and standard deviation, or difference in mean value, then standard deviation of each group. So difference in mean values of between the two arms and standard deviation in each arm. Based on that, we can calculate the sample size. Then difference in prevalence between the two arms. Again, interventional prospective study. Sampling method is RCT. Then you need to give what is the prevalence in one group, what is the prevalence in another group, another arm. So based on this, the statisticians will calculate the sample size required for 80% power at 5% level of significance. Then difference in proportion between the two arms. Again, if you want to go for non-inferiority trial, again, the sampling method is RCT. Then you need to give what is the proportion in active control, because in non-inferiority trial, always your comparator is the active control, those who are taking the standard treatment, that is active control. Then proportion in the test group. So even if you detect 10% difference between the active control and the test group, you can say your new test is the non-inferior to the active control. So for that, you should allow some meaningful difference in the proportion. Again, I want to emphasize that this meaningful difference in the proportion should not be more than 15%. If you allow less difference, then you allow more precise estimate. And if you allow maximum 15% is allowed to do for non-inferiority trial. Then difference in mean values between the two arms. Again, for non-inferiority trial, you need to give RCT methods. Then you need to give difference in mean value, that is test versus control. Then meaningful difference. Again, you should not give more than 15%. Then standard deviation in each group. That is for the difference in mean values between the two arms. Then diagnostic measures comparison. If you want to compare sensitivity and specificity of the two methods compared to gold standard, then the type of study is a diagnostic study, and you need to have, for example, if the prevalence of the study in the community is 10%, minimum sample size should have case to control is 1:10. Then only you are expecting 10% prevalence. So this is not fixed actually. It all depends on the nature of study that you are going to study. Suppose if the prevalence is around 5% in the community, then you should have 1:20. Then based on the available literature, you can give the prevalence of the disease, sensitivity and the specificity. So the statisticians will give you how many negatives you are supposed to take, how many positives are you are supposed to take. And this is the common method of study. There are other methods also. You can, for example, comparing the ROC curve, what is the sample size required, and comparing the survival between the two survival rates, what is the sample size required. Again, if you want to go for agreement analysis, that is Kappa statistics. For a given Kappa statistics, what is the sample size required? Then for correlation analysis, you are studying, let us say, 5 markers, and you want to see is there any correlation between the markers, and you should have minimum correlation coefficient between any two markers. Based on that, we can go for what is the sample is required to get significant correlation among the 5 markers. This is just only common studies I am highlighting. So the conclusion is sample size can be calculated if power, alpha level, and the difference between the groups and the standard deviations are specified. For more complex setting than those I presented here, statisticians have worked out sample size calculations for different studies. But the thing is, you should do some homework to give proper inputs. Then only you will calculate the sample size. Otherwise, you will not give any without any information about your study and sampling study designs. This is one part of my presentation, and if you have any doubt, always you can reach me either by email or by contact. Then another aspect is epidemiological measures of association. These all associations is restricted with only overall disease conditions, that is disease positive or negative discriminant, like mean value. These all quantitative values that cannot be applied for this disease of association. So what are the measures of association? Absolute risk, relative risk, risk ratio, odds ratio. These are all measures of association between the exposure and disease. And understand the when we should use odds ratio approach and the relative risk approach. So a statistical relationship between two or more variables. What is the risk? That is conditional or unconditional probability of occurrence of some event in time. Then what is the probability of an individual developing a disease or change in health status over a fixed time interval? It's called risk, and provided that the individuals should not die dying during the same time period. So that event should not take place. Otherwise, you can say what is the probability of an individual developing a disease or a change in health status over a fixed time interval. Absolute risk. The incidence of disease in a population is called absolute risk. So it can be magnitude of the risk, or it cannot be compared with the other one unless you have two groups. Absolute risk does not allow what is the incidence of disease in a population. You may ask a question, is there any excess risk associated with the given exposure? So the objective is to determine whether certain exposure is associated with the given disease or not. What is the methodology? You should have either cohort study, cohort prospective study, or case control study. So based on the cohort study, first assess the cumulative incidence of disease in exposed group, that is absolute risk in the exposed group, and assess the cumulative incidence in the unexposed group. Then you take the, for example, lung cancer among smokers. 1 year risk of, you have 100 individuals, out of 100 individuals, lung cancer is found to be 30. So your cumulative incidence of lung cancer over a period of 1 year is 30, that is 30%. And similarly, lung cancer among non-smokers. This during the period of 1 year, if you got 100, the non-smokers lung cancer is 5%. That is 5 out of 100. So cumulative incidence of unexposed population is 5% of the during the 1 year period. What is the absolute risk? So risk ratio of two risks. That is, you take the ratio of one rate to another rate. That is nothing but risk ratio or relative risk. So in this case, cumulative incidence of lung cancer among exposed population is 30% or 3.3. cumulative incidence of unexposed population is 5% or 0.05. So if you take the ratio 0.3 by 0.05, it becomes 6. What is the interpretation of 6? Smokers are 6 times are likely to develop lung cancer compared to non-smokers. The same interpretation can be given another way. For every 1 lung cancer cases in the non-smokers, there will be 6 lung cancer cases in the smokers. So this is based on the risk ratio or relative risk. How to assess the excess risk? That is called absolute risk reduction. So you just take the difference in two risks, that is 0.3 minus 0.05, that is 0.25. 0.25 is the excess risk due to smokers. So 90% confidence intervals can be calculated using the formula, and the lower confidence limit equal to 15%, upper confidence limit is 35%. How much relative risk reduction? Absolute risk reduction is we got that is 0.3 minus 0.05, that is 0.25 out of 0.3. So absolute risk reduction is 83.3 in the non-smoker as compared to the smokers is 83.3%. That is, if the smokers are 100% risk, then non-smokers will have 83.3% risk of developing lung cancer. So relative risk reduction is also called attributable risk or etiological fraction. 83.3% of lung cancer patients who smoking was the cause of the lung cancer. What is population attributable risk? Because sometimes this is useful to know the proportion of cases for whom the disease is attributable to the exposure factor. It is also interesting to estimate the excess rate of disease in the total study population, that is exposed and the unexposed population. So population attributable risk equal to in the study population minus unexposed population. That is, in the proportion of lung cancer in the total study population is 35 out of 200. Then in the proportion of lung cancer in the non-exposed population is 5 out of 100. So population attributable risk is the 12.5. That is 17.5% minus 7. So 12.5%. What is the number needed to again you can calculate based on the attributable risk or excess risk. How many subjects needed to expose to a risk factor over a specific period to cause harm, or one subject that would not otherwise have been harmed. That is, number needed to harm equal to 1 divided by attributable risk ratio. That is NNH equal to 1 by 0.25. That is 4 subjects needed to expose for smoking to cause lung cancer in 1 subject. So if 4 subjects are smoking, then you can expect 1 lung cancer. So number needed to harm is smaller, that is a worse risk factor. If number needed to harm is very low. Another one, number needed to treat. How many people you need to treat to avoid one case? So number needed to take equal to 1 divided by attributable risk ratio. That is response in drug B, let us say 70%, and response in drug B, drug A is 55%. The difference in response rate due to drug B, 0.75 minus 0.55, that is 0.2. So number needed to treat equal to 1 divided by 0.2, that is equal to 5. So you need to have 5 patients with drug B need to be treated to get 1 extra responders to protect from the disease. Number needed to treat is smaller, that is larger clinical effect. Number needed to larger is smaller the clinical effect. Then come to the odds ratio. Odds ratio, so as I told you, risk ratio or relative risk is applicable for prospective study or cohort study, where odds ratio is applicable for case control study. In case control study, because we cannot calculate the cumulative incidence or incidence ratio, that's why we cannot calculate risk ratio. Instead of that, you can go for odds ratio. Odds ratio is a measure of association between exposure and disease when the data are collected in case control study. Odds ratio can be obtained, however, from a cohort study also. So from a cohort study, you can get either odds ratio or risk ratio, whereas in the case control study, we can get only odds ratio. The interpretation of odds ratio and risk ratio is same, because just based on the point estimate, we cannot say particular risk. If the risk ratio is, let us say, more than 1, you cannot say that variable is the risk factor. You'll have to see the confidence interval of the risk ratio also. If point estimate is risk ratio is, let us say, 1.5, if the confidence interval is 0.7 to 2.5, then because this confidence interval contains 1 means null value. What is the meaning of null value? If exposed population and unexposed population have same prevalence rate, when you take the ratio of the exposed versus unexposed will be 1. So that is called null value. No difference between group 1 and group 2. That is called null value. So if the 90% confidence interval contains 1, then that either risk ratio or odds ratio is not statistically significant. For example, if risk ratio is, let us say, 1.8 and the confidence interval equal to 1.3 to 2.8, this confidence interval doesn't contain 1, so it is statistically significant. The risk of getting disease is 80%, almost 1.8 means almost 2 times higher compared to other group. So that is the interpretation. So when you interpret the risk ratio or odds ratio, you'll have to see the confidence interval. If it doesn't contain 1, then only we can say it is significant. If it contains 1, it is not significant. Similarly, risk ratio, let us say 0.6. You see the confidence interval. The confidence interval is 0.4 to 0.7. In this case also, doesn't contain 1. Again, this risk ratio, even though it is less than 1, is statistically significant. In this case, the presence of that particular factor is the protective effect. So risk ratio, when it is more than 1, again, if it is the 90% confidence interval doesn't contain 1, it is a risk factor. If the risk ratio is less than 1, if the 90% confidence interval doesn't contain 1, that variable is the protective factor. The same interpretation for odds ratio also. Another measure is hazard ratio. Hazard ratio is the time-related event, because as time progresses, your outcome variable will change. In that case also, you can see hazard ratio. That is called hazard ratio. This is the cumulative either odds ratio or risk ratio over a fixed time, whereas hazard ratio is the time-dependent outcome. So in that hazard ratio also, the interpretation is same. Then odds ratio in the case control study. I told you in the cohort study, ratio of the proportion of exposed subject who developed the disease to the proportion of non-exposed subject who developed the disease. What is case control study? The ratio of proportion of cases who were exposed to the proportion of controls who were not exposed. So odds ratio equal to probability that event occurs divided by 1 minus probability that event does not occur. So odds refers to single entity. If an event has the probability P, then odds of same event are P divided by 1 minus P. Just to let me explain with one example. So either risk ratio or odds ratio can be derived based on the 2 by 2 table. One is disease present and disease absent. Another one, exposed population and unexposed population. So this cell value is called ABCD, frequency. So what is A by B? That is exposed odds of getting exposed in the exposed developed disease, that is A by A plus B. Then proportion of disease in the unexposed population is B by A plus B. What is odds of developing disease? So A by A plus B divided by B by A plus B, that is called A by B. If you see the previous table, odds ratio per exposed group is A by B. Similarly, odds of unexposed group is C by D. So the odds ratio equal to C by C plus D by D by C plus D. That becomes C by D. So odds ratio equal to cross multiply this table AD by BC. That will give you straight away odds ratio. AD by BC. Odds ratio in the case control study, because in case control study, risk ratio cannot be calculated as I told you earlier, and because don't know the risk of disease among the exposed and unexposed. Since we start the recruiting cases and the controls, we can use odds ratio as a measure of association between exposure and disease in the case of case control study. Let us say cancer and no cancer, estrogen and no estrogen group. Again, here odds ratio equal to 56 into 390 divided by 18 into 274. So 4.42. Odds ratio is 4.42. Whether it is significant or not, we will have to calculate the 90% confidence interval. Based on that only, you can interpret whether estrogen is the risk factor for cancer or not. Just 4.42 is the overall estimate. We'll have to see the confidence interval, then only you can interpret whether it is statistically significant or not. So odds of cancer among the, just this description, that is prevalence of cancer among estrogen group is 56 by 330, and no cancer among estrogen is 274 by 330. Odds of cancer among estrogen subject is 56 by 274, and odds of cancer among non-estrogen subjects, that is prevalence among cancer among non-estrogen subject is 18 by 498. 1 minus P2, that is no cancer among non-estrogen subject is 390 by 408. Odds of cancer among the non-estrogen subject is 18 by 390, that is 0.0462. So odds ratio equal to 0.2044 by 0.0462, 4.42. That is nothing but AD by BC. So the meaning is the odds of estrogen subjects suffering from cancer compared to non-estrogen subjects are 4.4 times higher compared to non-estrogen group. You may ask, certainly it will be statistically significant. I cannot assure you, because if the sample size is very less, sometimes it may not be significant also. For anything, even whether it is significant or not, anything depends on your sample size. What is attributable risk? So attributable risk equal to odds ratio minus 1 divided by odds ratio. That is here 4.42 minus 1. So the attributable risk is about 77%. So if estrogen causes cancer, about 77% of the cancer cases who had estrogen could be attributed to estrogen. Population attributable risk. So here attributable risk is 77, around 77%, and the population attributable risk is 77.7738 into 56 by 74. That is non-estrogen group, 58.56. If estrogen causes cancer, about 59% of the cancer cases in the study population are attributable to the estrogen. That is the interpretation. Okay. Under what situation both odds ratio and the risk ratio is almost equal? If the disease is very rare, then in that case your odds ratio and the risk ratio will be approximately equal. For rare disease, both odds ratio and the risk ratio will be almost similar. So rare means at what level? Maybe the rare disease we can call it when the cumulative incidence rate is less, if it is less than 10%. So in that case, your odds ratio and the risk ratio may be similar. Matched case control study. So in a matched case control study, each case is matched to a control according to different variables like age, sex, race. So we can analyze the data in terms of case control pairs rather than individual subjects. There are 4 types of case control combinations are possible in regard to matched case control study. That is, there are two pairs, concordant pairs, that is, both are positive, and discordant pairs, both are in a dissimilarity. So matched odds ratio equal to ratio of discordant pairs, because concordant pairs is not useful for calculating odds ratio. In the case of matched case control study, we can use only ratio of discordant pairs, that is B by C. So example, children with higher birth weights are at increased risk for certain childhood cancer. So cases equal to children with brain tumors and the control equal to normal children. What is the exposure? Birth weight greater than 8 lbs. So again, you can form the 2 by 2 table like this. So in this case, the discordant pairs is only 8 and 7. 18 and 7 discordant pairs. The odds ratio equal to 18 by 7, where 8 and 38 are concordant pairs. So odds ratio in this case, matched case control study is 2.57, and chi-square equal to 0.4. So that leaves the probability level of significance is around 5%. So they again, the interpretation is as before with the independent groups. Let me show some demonstration. Is it possible, ma'am? Can I show some demonstration? Hello?
Yes, sir.
Can I show some demonstration?
The chairpersons would be better people.
And Dr. Vanamail,
Yes.
I think you have already overstretched the time. I know it's a very interesting but very complex topic. And for we gynecologists, I think we always refer to the statistician to calculate that how many cases should be taken, and this thing calculate the p-value and all also. So we always this thing. I think I hats off to you, but seeing all these complex calculations and all, it's very interesting also. So you want to have demonstration for few cases on which basis?
Just for 10 minutes. Just for 10 minutes, like how to calculate the sample size.
Okay.
And
How to calculate the sample size? I think that's
everything.
very important. Right.
Yeah.
Right. You
Just
can.
one. I'll share this slide.
Right. Okay.
Yes, tell me.
Actually, this is the open source software, OpenAP. This is developed by CDC Atlanta. You can use it for simple sample size calculation as well as odds ratio and risk ratio. So go to this website is.
Sir, we are still
OpenAP.
seeing. We are still seeing your slides only. You have to stop share these slides and then share your website.
Yeah, please. Just a minute. Is it okay? Now is it okay? Hello? Hello?
Yes, sir. We can see it now.
Yeah. So this is actually OpenAP info software developed by CDC Atlanta. For example, if you want to go for sample size calculations, just let me see how to calculate the sample size for simple proportion in the population level. So here you will have to give what is your target population size and what is the anticipated 40% and what is the confidence interval you want to have. So let us say 5% confidence interval, that is you are anticipating 40 plus or minus 5% in your study. And descent effect. What is the descent effect? Suppose if you go for simple random sampling, you can have descent effect is 1. If you want to go for like cluster sampling, you should have descent effect more than 1. So let me say it is for simple random sampling. So your input is target population size and anticipated prevalence and the confidence interval, descent effective one. Now you can calculate the required sample size. So for 90% confidence level, you need to have approximately 370 individuals in the community. If you want to go for 99% confidence level, naturally your sample size will be more, around 650. Again, when you here, this is the confidence level of 5% confidence interval I have given. If you increase the confidence interval, then your sample size will be less. Instead of 5, if I am giving, let us say 7. Here confidence interval is more, naturally your sample size will be less. The less the confidence interval limit, the more sample size will be there. So now you can see for 90% confidence level, your required sample is only 190, whereas for 5% confidence level with, it was around 370. So that makes a difference, because narrow the confidence level, higher the sample size. Similarly, you can go for sample size calculation for comparing mean differences like that. Now, let us see what is the odds ratio and other things. I'm going for 2/2 table. So this is positive, let us say 15, and this is negative 87. This is positive on the unexposed population, let us say 12, 80. Now you can put calculate. You can see everything will come. That is what is the chi-square value. Apart from chi-square value, you can see the bottom of the table. What is the risk exposure in overall risk ratio and the risk difference with the 90% confidence interval. So just this open source software, for simple calculations, you can use it. And do you want me to demonstrate any other thing? Hello?
Dr. Harsha, ma'am.
I think Dr. Vanamail, I think that is enough.
Okay,
so
ma'am.
I think we can move on to the next speaker now, because I think the session is getting too late. Right? It was
Okay.
very interesting, but it was little complex. But I think everybody needs to know all these things about the medical statistics and on how to calculate, because we have to put it in the papers also. Right?
So
Thank you so much. Thank you so much.
Thank you. Thank you.
So I think if Dr. Radhika is ready with her slides, so I think we can move on to Dr. Radhika, please.
Yes, ma'am, I am ready.
Radhika, you have got 2 lectures, I think, है ना? So
Hanji.
one by one you will be giving, or one after this?
No,
will be
I would prefer to give it together.
Together.
The 2 of them are interrelated, so I would
Right.
like to talk about it.
I think let the organizers also decide whether you can, because from my side, I think, because I was just seeing that, because they are interrelated only, so one by one they can be, I think, read together only. है ना?
Yeah, I had told Mala that earlier, so that was in fact the plan.
Okay. So
Sir,
I think
please
you can
stop share. Sir, please stop share your slide.
Yeah, sure.
I would like to thank the speaker and the chairpersons for such an informative session. I would now hand over the next session to Dr. Ankita, who would be introducing the chairpersons for the next session.
Tell me.
Yes, sir, enter issue. Update कर रही थी बस.
Update हो गया.
कैसे हैं सर? नमस्ते.
ठीक है, नमस्ते. Thank you.
I thank the esteemed chairpersons and speakers for a thoroughly enriching session. To conduct the next session, I invite the chairpersons, Dr. Vatsala Dadwal. Ma'am is Professor Chief, Division of Maternal Fetal Medicine, Department of Obstetrics and Gynae, AIMS, New Delhi. She's a great academician and teacher with special interest in fetal medicine and high-risk pregnancy. She is recipient of various awards like Young Researcher Award 2002 and Rogam Award Foxy 2008. Dr. Vatsala Dadwal. I also invite Dr. Neeti Tiwari. Ma'am is consultant at Center of IVF and Human Reproduction, Sir Ganga Ram Hospital, New Delhi. She is Joint Secretary AOGD 2020 and co-convener SIG Endometriosis IFS 2020 to 2022. Dr. Neeti Tiwari.
Hello, everyone. I think Dr. Dhadwal has left because she had some urgent work. So we have already introduced Dr. Radhika, I guess. We know her passion for medical statistics, and we invite her to give her lectures. Ma'am, please make it full screen, your screen.
Yeah. So thank you so much, Dr. Neeti, for the kind words. And I think I will start straight away. Like I said, I would like to combine the two talks together because the two are interrelated. So overview of evidence-based medicine and relevance to practice. So we all aim to provide the best practical medical care to the patients. How do we plan to do that? We want to find the best evidence for the best care, applicability to the individual patient, and also to see the availability, the feasibility of resources, and the surgical skills. So basically, the nutshell of evidence-based healthcare is to ask, acquire, appraise, apply, and to reassess. So it is an auditable cycle which goes on. So we will talk about this with some more detail briefly. So what is evidence? It is the unbiased view of the truth. What is bias? It is the difference between the study results and the truth. Well-designed and well-executed studies help us to get closer to this truth. So this is what has been spoken about since morning. Ruma talked about the types of studies and how important it is to publish to have the right results, and also been discussed by Dr. Vanamail. And publication is so important other than the practice. So we have to be clever at all the three. So does it mean only the best clinical evidence and the clinical expertise? No. We also need to take into account the patient's choices and her values. And the amalgamation of all the three is called as the evidence-based medical care. And this was what was defined by David Sackett many years back, and still today we appreciate what has been defined by him. So what are the, so like I said, what does it involve? You first ask the question, formulate the clinical question, then you search for the evidence, that is acquire the evidence, then you appraise the evidence, and then you finally apply the evidence into practice, and then you assess what you have been doing. So it's kind of an auditable practice, and it keeps you alert, very active. What is the importance of the practice? It minimizes the risky clinical practice. It has got great medical legal importance when there is a guideline that you have adhered to. You've undertaken a practice and there has been a complication. The court of law gives great importance to what is already in existence. It optimizes the quality of healthcare, maintains a uniform standard of care, which makes it an auditable practice. And it also helps to formulate good practice recommendations. So what is the current scenario? The physicians certainly are in requirement for this relevant information which pertains to diagnosis, treatment, as well as the prognosis. Traditional information sources are, majority of them now out of date because science is moving very fast. However, there is a divergence. There are clinical experience as well as reduced scientific knowledge over time. So you would find many people saying, according to my experience. So experience is something very, very important. You can't be having everything in the book, but there are certain laid down standard practices which need to be adhered to. The reason is they have been found to be safe and assured better success. So it is very important that this divergence doesn't exist. Along with the experience, we need to update our knowledge, from time to time. Of course, there is time constraints with very few minutes to week for reading and reviewing the practice. So what do the people say? See, the point is that there is sometimes a lot of opposition to the evidence-based practice. they say that there is too many clinical queries which may not have an answer. There is no time. It is a cookbook approach. RCTs need to be funded because RCTs are the best forms of evidence, and all evidences produced may not be accessible, and this may result in bias. Publication bias happens to be one of the most important types of biases in clinical practice. However, the points in favor are that today the evidence bank has increased, as we will see through the course of my talk today. And is it no time? Is it no inclination, or is it no time? You say that I'm not finding time, but we find time to do many other things. And it is actually patient-oriented evidence that matters. Evidence-based medicine is also called as the POEMS. It is not a cookbook approach. And then we need to generate contextual evidences, which may be non-RCTs. Non-RCTs as well as qualitative studies form the backbone of other RCTs. So it is very important to have baseline studies which are available on the topics which have not been studied. Tuberculosis, malaria, the problems that we have in our country still are lagging behind with respect to evidence because we haven't really done much enough. And there is better availability and access to evidence. We all know that today electronic medium is the open forum for all of us to actually access. Now, this is the hierarchy of evidence of the studies. You see, it starts from here. The editorials are the lowest, followed by the systematic reviews here. So, case series and case reports, case control trials, studies, then you have the cohort studies, the RCTs, and finally the systematic reviews. Actually, what is in fact considered is from the systematic reviews arise the clinical practice guidelines, and they are considered the best forms of evidence here at the peak. And that is why I was saying that the evidence-based healthcare ensures a safe practice. Now, this is something very commonly that we see. I just want to just touch upon what it all means. See, these are the levels of evidence. We are familiar with 1A, 1B. The systematic reviews form the best forms of evidence, then the RCTs, the cohort, and then followed by the strength of recommendation. So today, majority of the studies talk about the guidelines, especially the RCOG, ACOG that we talk about. You would find that there is a strength of recommendation along with the level of evidence. And here, mind you, that the bias goes on reducing from below upwards. So the RCTs and the systematic reviews have the least bias. Includes, there are 7 kinds of bias as against about 4 or 6 that were earlier spoken about. It starts from the time of recruiting the patient till the publication that is available on the public domain. So the biases, when they are more, then the nature, the quality of evidence falls. We want something which gives us evidence which has got the least bias, and that is basically the RCTs and the systematic reviews. Now, today we also talk about something called the grade. What is grade? Grade is the grading of recommendations, assessment, development, and evaluation. Now, it is a transparent framework for developing and presenting summaries of evidence and provides a systematic approach. Now, I think Ruma had kind of touched upon the systematic reviews. So what is done in systematic reviews? I'm just going to talk about that in the next slide. But briefly, you combine many studies together, identify the commonality of the studies, find how good or bad the evidence by way of the strength of the outcome is. So the strength of the evidence is actually more than the outcome. And this is then graded. Now, what is the biggest advantage is here you are not talking about a study. Here you are talking about many studies. And this is graded in the form of high, moderate, low, or very low. And this today is the mantra in majority of the evidences that are published. So it is important that we become familiar with this kind of legend that comes out at the end of every systematic review, which indicates the grade of evidence that is present. So the authors decide what the clinical question is, and including the population in the question, that is the PICO, that is the patient, the intervention, the comparison, and the outcome. The quality of evidence that is rated for each outcome, because the quality of evidence actually varies between outcomes. For instance, even for a simple thing like anemia, it could be a change in hemoglobin versus quality of life. So the outcome could be different for the nature of evidence, quality of evidence could be different for each outcome, and that is why this grade today is very important. And overall grade quality is then applied to a body of evidence across the outcomes. So we have, I think, since morning understood that depending on the question, we need to also know the type of question that addresses the clinical question. So for cost effectiveness study, diagnostic validation studies, prospective studies, blind comparison to the gold standard, etiology or the harm, cohort study and the case control, and so on and so forth. So what I'm trying to emphasize through this slide is also to understand that when you try to look for the evidence, you should know what to look for. So what is systematic review? It is a summary of medical literature, explicit and reproducible methods, because if I do a systematic review, somebody sitting in any other part of the world should be also able to undertake the same systematic review and come down to the same results. So the external and internal validity is so very important, and that is why it is a serious business, and it takes about minimum 2 years to conduct a systematic review. And the best part is that there is a systematic search for literature which is critically appraised and then synthesized. The results of multiple studies are then which are related to each other are synthesized by using strategies that reduce biases and the random errors. So may or may not include a statistical synthesis. So many people confuse. They think meta-analysis is the same as systematic review. The answer is no. Meta-analysis is the arithmetic form of putting forth the results of a systematic review. The review could be narrative or with meta-analysis. Meta-analysis forms a very small part of the systematic review. And it depends on the availability or the ability to meta-analyze a systematic review depends on whether the studies are similar enough to allow for calculation of the meaningful results. Systematic reviews adhere to a very strict scientific design, like I said, and it is based on explicit pre-specified reproducible method. So why a systematic review? Because the results are reliable and defensible estimates about the effects of intervention. If the benefit of collating the evidence from a variety of sources means that the number of patients which were limited per study, in systematic review, you are maybe combining about 10 studies. So whereas if I were to do a study where the number of samples that I can collect over my certain period of time, if it is 100, if I combine 40 such studies, automatically the sample size increases. Hence, it ensures that the sample size is more. And sometimes the collation also indicates that there is sometimes conflicting evidence, which can also be an important clinical parameter, clinical point which needs to be referred to while translating the evidence into practice. Another important matter is that it demonstrates where the knowledge is lacking. So the systematic review could be of the clinical test, public health interventions, adverse effects, economic evaluation, how and why the interventions work. So it is important to understand that the systematic review is not the same as a literature review. Now, it is a big table. I know that you must all be very tired, and that is why I don't want to go through each point. Now, what I want to just briefly say is that the literature review does not clarify the inclusion and the exclusion criteria or the objectives. The background is common for both. There is no protocol in the literature review, which is done by a group of authors or by individuals. Whereas systematic review requires minimum of 3 to 4 authors. There are 2 of them who are actually getting to the study material, then appraising it, trying to come out with a solution when there is a discrepancy between 2 authors, followed by meta-analysis. So there is a defined clarity regarding the selection of articles, which is not described in the review of literature. Then there is evaluation of the articles, followed by finally the results and synthesis, which doesn't exist in the literature review. So that is why there is a difference between the systematic review and the literature review. Many people call the systematic review is mistakenly called systemic review, which is incorrect. So these are the steps. So you you plan a protocol, search for the study, sift, extract the data, assess the quality, combine the data, and then discuss and conclude the overall findings, and finally you disseminate it. So that is what the Cochrane collaboration does. So what you find there are so many systematic reviews which are available. So in summarizing the evidence, the systematic reviews provide the valid results, and what are the results, and how can these be translated into practice to the patients. So that is the biggest advantage of the systematic review. Not only do the results are published, but also it gives you an idea as to how to translate the evidence into practice. So I would like to conclude to say that evidence-based practice ensures a medico-legally safe, auditable practice. Often contextual evidence may be lacking. Hence, it is important that one develops research, and also, where you don't have a systematic review, you need to have your own studies, as well as, the local data which you could bank on. It is time to develop recommendation and guidelines to standard established processes, which are not, we are still lacking behind, especially in obs and gynae. Rather than primary research, it would be beneficial to undertake systematic review to collate evidence from available studies, especially in India. So now we quickly go on to the literature search. Today we understand that there is a lot of literature that is getting published in the electronic as well as in the hard copies. So there are so many biomedical journals as well as the books which are there. There is also the grey literature, which is the unpublished report, and from the these are some of them are like theses which are just lying in the libraries, or there could be case studies which are not presented, conference proceedings, and of course there is internet. Then everybody has its own guideline, confusing presentations in statistical jargon, and it is important to acquire information which is credible, feasible, and applicable. But then now there are dedicated sites which are able to provide the credible grey literature, and these are some of the places from where one could possibly access the grey literature. It is especially important for authors who are planning to undertake systematic review, because grey literature forms a very important area which has not been actually published in the public domain, and hence much of the important evidence gets lost because it has not been accessed. So that is the importance of grey literature. So this could be e-prints, preprints, electronic network, blogs, podcasts, and so on and so forth. So when you do a literature survey, search, there are two types of questions that can be asked. There are background questions, which are basically general in nature, provide the foundational information, and that is the root questions and about a disorder or some aspect of a disorder. The root question means who, what, where, how, and why. Now, we don't need to look at the internet and go do a literature search to answer these kind of questions. These are very much available in the textbooks, So like, for instance, what are the drugs which are used to treat hypertension? Mind you, I'm not talking about what are the newer drugs which are available to treat hypertension. I'm talking about the established drugs, very well available in the textbooks. What education resources exist for the mothers in gestational child diabetes can be answered by the textbook. So don't spend too much time trying to look for the literature which is already in existence. Whereas when we talk about the foreground questions, these are the ones which bring multiple concepts together to a specific situation, specific clinical situation. So the qualitative questions are basically to understand the phenomena. Quantitative questions aim to understand the cause and effect relationship. And these are best answered by the resources found in the evidence pyramid, which I showed right at the beginning of this talk. What about the books, conferences, and colleagues? Books, I said, are very good for the background questions. However, it is important to appreciate that they take about 3 to 5 years for the books to be published, and the recent updates may not be available because by the time the chapters are invited and the editors start editing, and then finally it comes into the public domain, it is easily anything from 3 to 5 years. By that time, probably the evidence has already gone into history. And then the conference, my experience today, are not validated. So effective literature search means scoping the search, choose the resources, identify the terms, compile the search strategy, find the full text, and manage that information. So what are the criteria for selecting the information source? Soundness of evidence-based approach is very important from that information source, comprehensiveness and specificity, ease of use, and availability. Now let us take the example of this situation. 35-year-old lady presents with low platelet count due to ITP, and as she had thrombocytopenia prior to the pregnancy. In the antenatal period, her platelets fluctuated, ranging from pre-pregnancy 120 to as low as 60. When she presented to the hospital labor, her platelet count was 75, which prevented her from getting an epidural. But she ensured she was given a safe vaginal delivery. She delivers without any complication. After 48 hours, the platelet count had risen to 110. Should a blood test be undertaken to check the baby's platelet count, and if so, when? Right? So the clinical question is, in the newborns of the mothers with immune thrombocytopenia, is it recommended to get a platelet count done to diagnose immune thrombocytopenia? And if yes, when? So it is important to ask the right question. So from here, the entire game starts from here. Now this is called the PICO, or the PS or spider for the qualitative studies. Now PICO is the patient or the problem or the population. I is the intervention, C is the comparison, and O is the outcome. And what is PS? It is the patient or the population and the situation. How does or how do, and experience is what we talk about. For example, how do mothers with a detailed birth plan experience deviations from this plan? So experiential outcome of of a certain phenomena. SPIDER is also an acronym. It is the sample phenomenon of interest, design, evaluation, and the research type, designed specifically to identify the relevant qualitative and the mixed method studies. So here, the example that I gave, it is newborns born to mothers with immune thrombocytopenia is the P. Intervention, blood test to check the platelet count. C is the blood test, and D, diagnose immune thrombocytopenia. So again, you look at the type of studies. I'm not going to spend time on this. So what is the evidence? So there are, like we just now understood, the evidence could be systematic reviews. There are the entire pyramid of evidence exists. So where to look? Now these are the various sources which are available. Now if you find here, if you pay attention here, there is the filtered and the unfiltered information that is available. Unfiltered are the huge gamut of the publications that can be accessed, journal articles, as well as the case series, the case reports, as well as the independent reviews. Filtered is, these are the sites which give you the filtered information, like for instance, the systematic review, as well as up to date is one site in which a group of authors, they go on updating the information as of date, and they even mention as of which date. So there is the biggest advantage of having this filtered information is that immediately you have at hand the most updated information for you to practice. Now, how to search? Now, we understood what is PICO. Now, there are two, these terms which are very important to be understood, and or. These are called as the Boolean operators, which I'm just going to touch upon in the next slide. Now, you combine the P, I, and O with and the problem with the synonyms are put on one side, the intervention or the synonyms for the intervention on the other side, in the middle row, and then you combine all this with the outcome, and this gives you the best search strategy. So I know that this would not be clear, so I'm just going to again explain in the next slide what it all means. That was just just to stir up the curiosity. So these are called as the Boolean operators, and, or, and, not. So when you want to combine the results, when you want something which would include both gestational diabetes and nutrition, probiotics and autism, high risk pregnancy and exercise, then you use the Boolean operator and. Now, if you don't want the two together, obese or overweight, neonate, so these are synonyms. So what did we do in the previous slide? We combined the synonyms together by or. Okay, so records containing either or one or more of the terms, not human or not animal, newborn or not preterm, excludes records which are with the following, with the terms which are not together. So it excludes the newborn without the preterm, human and not animal, So, so that way. So what are the databases for literature search? We have the very interesting databases that are today available. And then PubMed, having understood the importance of the literature search as of today, has actually updated and brought out a new, completely new site, and it is called as New PubMed. And the older one today is called as the Legacy PubMed. And the search strategy for both the legacy and the new is completely different. It is PubMed is a database of more than 30 million citations to articles in the fields of biomedicine and health, and the user domains are research, health development policy, patient advocacy, public health, clinical care, related educational activity, and so much more. Now, there are other databases which can be used. We have PubMed, Ovid, Medline, then you have the Scopus, the Google Scholar, and the Web of Science. Now, today there are many more. I'm just going to focus on these 3 or 4 and tell you the important points of each so that the search strategy becomes easier. PubMed is an interface used to access the Medline as well as traditional biomedical content, whereas Ovid Medline is an interface only to access the Medline, and it allows for a more focused search. PubMed helps you to get additional biomedical content, more user-friendly, allows search which has more content than the Ovid Medline. And in addition to Medline, we have the PubMed Central, which are full text articles which are deposited to promote open access and articles that are in process, that is the preprint, that is prior to being indexed with the mesh terms. Now, somebody had talked about the mesh terms earlier. What is mesh term? That is the medical subject heading. As we know in a hard copy library, as soon as a book comes, what does the librarian do? Identifies the key terms. For instance, if I talk about pain in endometriosis, it is about endometriosis. Subject is identified and the book is catalogued as per the subject. Similarly, in the electronic library, that is the National Library of Medicine, which is placed in US, which gives out the PubMed facility, they also catalog the various the publications that come, and those are then kept as mesh terms, because if you want to do a search, if you do a mesh term search, then the results are much better. So I would be, in time permitting, we can do a hands-on on the literature search. I'm not very sure. I think today it turned out to be something else. So we will just quickly go through the slides and then accordingly decide. Then there are also the ahead of print, like I said, the PMC also has the ahead of print articles which can be easily accessed. Scopus covers a wide journal range of both help in keyword searching as well as citation analysis, but it is currently limited only to the recent publications after 1995. Google Search is a web search engine run by the Google, and it has indexed scholarly literature like peer-reviewed journals. Actually, Google Scholar gives you a much broader result, including the books and also the grey literature. Very good. Google Scholar is very good for grey literature as well as for the books. And same is the case with Web of Science. Web of Science and Google Scholar are almost the same. So the PubMed has PubMed Central. It has the manuscripts which have been published by the authors, and then the Medline articles which are through the journals which have been indexed in the PubMed. And then you have the preprints and the books which are available in the PubMed Central. An important point in PubMed is that the cataloging is done only through the abstracts. They don't go through the full text literature. So if the abstract doesn't show up the keywords well, then the cataloging is inappropriate. So if I were to publish an article on malaria and I don't write the malaria in the abstract in the right way, say for instance, pregnancy and malaria, I go on talking about malaria and by pregnancy the key term doesn't figure in the abstract, then it may not figure in the right place, and my citation of my research may not be much. So one has to be very clever in understanding not only the search strategy but also the publication strategy. In other words, to understand the key terms. So that I would be just now talking about. The PubMed was basically launched in 2019. The new PubMed, it has got a clean and modern look. easy to use interface. It has got an improved search engine to help in the find the best match for the query, and same trusted citation data, and it also runs in the cloud. So it's also available on the mobile. It is very easily accessible. They have made it extremely user friendly and easy to use. This is the opening page. So as you can see here, there is something called learn, find, download, explore. So it is a very interesting data base. I would encourage everybody to have a look. And like I said, time permitting, we can go through it. So mesh terms I have already talked about. This is what a few points about how to do the PubMed search. Mesh terms is basically the cataloging. Search strategy includes the Boolean operators and also truncation, where you use this asterisk. And this is basically to improve the limits of searching, which we will just see in the next slide. And then abbreviations are better avoided. So and is to combine diabetes and obesity, or is to widen the search, not is to eliminate the records. We want only one and not the other. And then you could use the quotes, which helps in searching for the words together. Insulin resistance would be searched together. And this is what I meant by truncation, the asterisk. At the end of the term, to search for the same words with a different ending. For example, if I want to look for nurse, okay, I use this asterisk. It looks for nurse, nurses, nursing, everything at the same time. So use of this truncating is also extremely important. Incorrect strategy, don't use the preposition and the conjunctions. These are the stop words. Try not using them because it limits your searches. So prevalence of malaria and dengue in India not required. Malaria, dengue, India is good enough. Progress towards vaccine for dengue and malaria in children. So it would be a good idea to practice, and just remember not to use these prepositions and conjunctions too often. So when you search the PubMed, will look for records that contain the bibliographic details and the words which are present in the abstract. It doesn't do the complete full text search, and the results may or may not be about your search term. The results may contain your term, but may not be about the term that you are basically wanting to look at. So this was the example I was telling you. So I look for malaria. So it comes out with a few articles. Now it's a good idea to sign into the NCBI. You can sign into the PubMed, and you can also choose highlighting the search words. So I have signed into the NCBI. NCBI is the one which hosts the PubMed, and I have requested for highlighting the search words that I look for. So it becomes very easy for me to place to boil down to the important outcomes of my search when I find the words are highlighted. So the malaria. So this one shows the burden of imported malaria in Cape Town, South Africa. My idea was to look for malaria in pregnancy and the outcomes. I just wrote malaria and look what I find. And then this talks about malaria and hypertension, completely unrelated. So how you search becomes extremely important. So here I give an example. So it's a 35-year-old para 2 L2, dysmenorrhea and pelvic pain, 15 years, lab ligation done by a senior resident 5 years back, noted mild endometriosis. She has tried the medical therapy with temporary relief. Recent ultrasound shows normal findings. Clinical query is the plane of damages, which is a new drug. So the PICO is 35-year-old Paris mild endometriosis is the patient. Intervention is diagnosis. Comparator is placebo or not. Outcome is plain relief. So the clinical question is, how effective is diagnosis in reducing the pain or improving the quality of life in women with early stage endometriosis? When I, with that kind of a PICO and using the appropriate Boolean terms, I immediately get down to a very important article which was published, which showed that reduced pelvic pain in women with endometriosis, efficacy of long-term diagnosis treatment. So it not only gives me the outcomes, but also shows me specifically the reduction in the vascose and the pain relief. So what I'm just trying to convey, I have not now shown the complete filtered outcomes of what I did, the search that I did, but I had got 2 systematic reviews, 2 RCTs, and many observational studies. Other treatment options were also available. The number needed to treat, like Dr. Vanamail had informed us how to calculate the NNT, very important for us as clinicians, Because when you talk in percentages, patients don't seem to understand. Whereas if I say, if there are 3 people like you, and if I undertake this for 3 people, one gets relief. So if you are one amongst 3, this will be the kind of relief that you will have that is better understood by the patients. Then the attendance risks of surgeries are there. Diagnosis seems the appropriate option. The cost and the side effects and duration treatment also needs to be explained, as has been also exemplified by the guideline which has been published by NICE in 2017. So after having done the web search, it is important to also reference it properly. It is important to give the websites from where you got the result, give the name of the website, the URL, the dates when it was searched, the search terms that were used in the results, and also the search engines, name, dates, search terms, and the results. Okay, so it is always important to reference. So the databases, Cochrane is, I am very sure you are familiar. This has free access in India. For a little while it became paid because ICMR was initially bearing the finances. Later they could not afford it. Today Ministry of Health has come forward and they're funding. So Indian doctors can access the Cochrane database of systematic reviews. Then you have the TRIP database where you get everything in one place. You get the systematic review as well as the individual studies, everything in one place, and it is the filtered evidence. And the best part is you can even do a PICO search here. You just can insert the PICO and get all the recent literature. Then you have epistemologies, almost same, similar to the TRIP database, and this gives you the database in a nutshell. It's a one-stop shop as has been advertised by them, and I completely agree. It is very interesting. Please do take time to go through epistemologies. Then the Guidelines International Network gives you an entire array of the recently published guidelines. Okay, so the membership is not free. Incidentally, I am the representative from the low middle income countries to GIN. So there is a lot of literature that is available, and they also mentor as to how to undertake a guidelines development. So a very interesting place to see. Then you have the Campbell collaboration. This basically focuses on the social sciences aspects. So if you want to look for violence against women, intimate partner violence, or it can be sexual problems. So this was a good site to look at, and this they have recently also had placed an office in India. Earlier footfalls in India were few. Today Campbell collaboration is actively participating in India. What are the Indian sites from where you can get various information? So this is the GLOWN, that is the FIGO site for accessing the literature. Then you have the National Health Portal from the Ministry of Health, and this is the Geneva, the website from the Geneva Foundation of Medical Education and Research, which also gives very important recent literature for free access, as well as the full text text which are available. Sometimes the entire literature, after doing all, you might not be able to get the best, whatever you wanted. So phrases, I told you, what are the other strategies? One could use a double quotation, use wildcards, that is using the truncation. It is very important, imperative to check whether the spelling is right. Sometimes alternative spellings, the gynecology instead of gynecology. Now this is called as the UK-US auto mapping. This is available today in the new PubMed. This was not there earlier in legacy. So that is yet another advantage that is present in the new PubMed. So then we also have the evidence and gap maps. Very important to understand what are these. These are systematic presentation of all the available evidence for a particular sector or subsector. It shows what evidence is there, but what the evidence says is not what it presents. So the advantage is that you know what literature is available on a particular subject, and if you want to undertake a study or if you want to access the literature, it gives you in one go. What it looks like will be shown in the next slide, and this may be global in the nature of the presentation. Covers different types of evidence on the same topic, includes primary as well as the systematic studies. So this is how the presentation is. It's a large map which shows bubble diagram. So the various points, the topic was adolescent sexual and reproductive health in the evidence gap map, and all the interventions, the CAP, adolescent behavior, adolescent health, so many things are there. what are the studies which have been done, what are the ones which are on the way, everything gets expressed here. So it is easy to access the literature through an evidence and gap map. Then Google Scholar is a good site, we have already discussed. Qualitative search, it is basically derived from observational data, interviews, verbal interactions, and it focuses on the meanings and interpretations of the participants. Search, it can be very challenging. Text words are a little different from the quantitative studies. This include qualitative, ethnograph, and phenomena. So it is a separate discussion altogether. I don't think I will go into the details of qualitative research. So to end, steps of literature means you start from step 1, go down to step 10, think, identify your key concept, find out the synonyms, choose the appropriate database, combine your search terms, consider how to apply the limit, run your search, adapt the search strategy, get your results, obtain your results, and then you save the results. So how does one save that? So we will go into the next aspect as to how to use the various referencing software to collect your data, what you have collected. In the meantime, to conclude the present talk, basic knowledge of evidence base is important. It is important to understand the quality of available literature. Systematic reviews help to identify, evaluate, and summarize the findings, hence an important aspect of the evidence-based practice. And accessing these is also extremely important, and it is important to also extend this into individual patient care. Now, quickly, the reference managers, you collect so much data, where do you store them all? So hard copy, there is soft copy. Hard copy is writing the references manually. Soft copy is use the reference manager. So these are the reference managers. EndNote is free version is available, but not of great use. The paid version is very good, but I would like to focus on Mendeley and Zotero, which are very, very important. I think every doctor should be aware of Mendeley and Zotero, how to use the basics, how to apply the basics. Then you have the RefWorks and the BibTeX and the LaTeX. So they help to get the software. It is basically software which consists of database in which full bibliographic reference can be entered and generate a selected list of articles in different format. And they are integrated into the word processor. Please understand what I'm saying. You can integrate this into your Word document in which you are typing your manuscript and use these citation managers to simply put it there. You don't have to manually type anything. It allows for the importing of the details of publication. So EndNote, Mendeley, and Zotero. I am not going into the details of this table, as I can well understand that it will be very difficult for you to focus. What I just wish to say that Mendeley, see, EndNote is of commercial use. I am not going to focus on EndNote, though EndNote is very good. It is liked by majority of the professional writers. But we as doctors in India who don't have anything like a funding available for our research, Mendeley is free. It is available on the web, allows up to 5 GB of storage, and it helps about 5 collaborators to share the manuscript as well as the site. Similarly, Zotero is free, open source software, and then while this is available, Mendeley is in English. Zotero is also in English, but available in other languages also. So please take time to have a look at both of these. So I have already described what is Mendeley. It is used for citation. So briefly, what you do is you access Mendeley, create an account, download this desktop version. Now you are ready to add articles from NCBI, Google Scholar, ResearchGate, any of these places. You install the Microsoft Word plugin, and then once you do the Chrome, the Google Chrome add-in is also available for Mendeley. Once you do that, you access the literature, simply download. See how easy it is. It goes into the Mendeley software, and this is how the interactive phase looks like. So here are the literature that you had downloaded. These are the collections, the reasons, the favorites that are there, and then you have the entire article which can be read. The biggest advantage is that you can annotate. So you can mark up, it's like reading from your own book. And then all your markups are saved here. And then you also have the advantage of transferring the entire bibliography to your Word citation. And that can be used directly. So it is extremely interesting. Unfortunate that we can't do a hands-on today. I was very eager to undertake the workshop. but I think on another date we can do that. So this is what I wish to highlight. You can insert the citation from Mendeley as well as Zotero in your Word document. This is about the Zotero. So when you integrate it into the Chrome, this comes up in the form of a small icon here. So whenever you access any of the literature, it goes directly into the Zotero, and this gets stored here and you can access it anywhere, even in the cloud. Right? So that is the way it is. Google citation is also very important. Google Scholar, how you download the citation, you access that, and here you can see two quote marks. You go into the quote marks, and this is the kind of interactive page that opens up. Now, today the publishers, they want you to have the publications in a certain style. It could be Vancouver, AMLA, AMA, APA, etc. So this gives you the freedom to use any of those, Harvard, Chicago, APA. You can choose the type of citation that you wish to undertake. And this facility is also given by Zotero as well as by Bentley. So please take time to see all this, and I think we can have actually each of these is a one-day workshop. So I'm trying to put this all in a nutshell within about half an hour because we are running late. So you can download the citation and note. I don't wish to spend too much time on this. Reference works is also something good because PubMed helps you to save the searches in the collections in the NCBI as well as in the reference works, or you can email your citations into the from the PubMed. So I thank you all for a patient hearing, and to stand out in this crowd of so many flowers. If you want to be like this, you have to be smart enough to be able to understand what is evidence-based healthcare, translate into clinical practice, first understand how to look for it, get that, and then quickly implement and acquire it, and then assess your own practice. So thank you so much for patient listening. So my other session was how to do the search. I don't think I will go into that. So thank you so much for patient hearing.
Thank you so much, ma'am. It's always an enriching experience listening to you. Always a pleasure.
Thank you so much.
Now I would like to invite Dr. Pikee Saxena. Dr. Pikee, who is a professor, Obs and Gynae, Lady Harding Medical College, and she has 28 awards in research and international publications. So the right person to be here in the research workshop. Dr. Pikee, would you please share your screen?
Hi, Dr. Mala.
Dr. Pikee, are you there? Dr. Pikee? Yeah, Dr. Pikee, you need to unmute yourself. Yeah, and share your screen. Dr. Pikee, you may share your screen now.
Okay. I'll just share. It's just not coming.
Amit, please help Dr.
Yeah, it's there.
Is it visible now?
Yeah, it's visible now.
Slideshow. Okay, fine.
Okay. So I will be talking on, but I can't see all of you, any one of you.
You have to make your...
Ma'am, on the side, there is a grid on top right corner.
Yeah.
You change your speaker view or gallery view. Do it there.
You can see us.
Can you see me?
Yes, ma'am.
Yeah, see you. We can see you.
We can
Okay,
see you, we can hear you, Pikee. Just continue.
Okay, I'll just start. Okay, so my topic is critical evaluation of a journal article. So as we know, we have been hearing since morning, since 1 o'clock. So there'll be a lot of repetition and I will try to be short and precise. So as you know, there are about 30,000 medical journals with close to 2 million articles published every year. So it is a real puzzle. How should we, this is an information overload, and it is important for a clinician to know how to systematically apprise an article, how to identify the strengths and the weaknesses of a research article, check its validity, and assess its usefulness for clinical practice. So as we know, the research article, the main body consists of the IMRAD sequence, that is the introduction, methods, results, and discussion. The introduction is prefaced by the title and an abstract. And after the discussions comes an important part, the references and the conflict of interest, which is declared by the authors at the end of the article. So coming to the title, as Dr. Madhuri Patel has already emphasized in her talk, we have to see whether the title is informative. It should be a snapshot of the research study. It should not be very catchy or having fancy words. It should have few suitable words which are appropriately representing the study. It should be very specific. It should mention what is being done, in whom it is being done, what is the comparative group, how it is being done, and what is the time frame. It should not be very broad and neither it should be too narrow. A type of study design adds to the information. For example, in the title given below, a double-blinded randomized controlled trial of mifepristone or placebo before buccal misoprostol for abortion at 14 to 21 weeks of pregnancy. So we have the study design here. We know it is a controlled trial. The comparator is there, that is the mifepristone or the placebo. It is being used to study the study outcome of abortion in women 14 to 20 weeks of gestation before buccal misoprostol. So it is covering all the important components and we get to know an overall idea of what is going to be described. Title is also very important because this is the most read part of the article and this is going to decide whether the reader is going to go ahead with reading the whole article or we are going to abandon it. An abstract comes after the title. It is written at the end of the study after completing the study, taking out the results and discussion. It is a structured paragraph that is coherent and concise and gives major points of each section in 1 or 2 sentences. It is generally comprising of 200 to 250 words and it has a small background, aims, methods, results, and conclusion. So coming to the introduction, we need to see if it is brief. It should not be too long and it should not be containing too much of background material. It should start with what we already know, what is the pre-existing knowledge about a particular topic, what we don't know, that is the lacunae in the study, and why we conducted the study, which should come as the justification. So we need to see that in the introduction, the justification, the research question, and the hypothesis. Hypothesis is what we expect out of the study. All of these are mentioned. The objectives should be mentioned at the end of the study. So this is how we are going to evaluate the introduction. So in the introduction, we need to see if the study's research question is relevant. How do we decide whether it is relevant or not? It may address an important topic or it may just add to the already known knowledge. We know that the substantial new contribution to knowledge is a relative rarity. New ideas and knowledge are developed on the basis of previous work. However, incremental advance can also be of value. For example, a study might increase the confidence in validity of previous research by replicating the findings, or it may enhance the ability to generalize to general public by doing the same research in a new population of patients. Then third question is that what type of research question is being asked. This is the most important part during critical appraisal. And as we are hearing since morning, a well-developed research question should ideally identify the PICOT model. That is the patient, I will not go into details, the patient population, intervention, comparator, O is outcome, and the time frame. When the study results are to be evaluated after 1 day, 6 weeks, when, and for how long the patients are going to be followed up. So in the material and method, we need to evaluate the study design. Has the study design been mentioned? Each study design, as Dr. Ruma said, we know the strengths and weaknesses of each study design, and they all have their own bias. So we need to evaluate that, whether it is congruent with the study question or the research question or hypothesis. The study duration should be clearly mentioned, where we are going to do the study, conduct the study, and from where we are going to enroll the patients. Outcome variables, both primary outcome variables, secondary outcome variables, should be objectively defined so that they can be easily measured. The participants, how the patients were selected, were their patients or animals, how the study is being conducted, whether the ethics approval has been taken or not, what is the sampling frame, has the inclusion and exclusion criteria been appropriately framed. Then in the sample size, which is a very important topic, is the sample size adequate for testing the hypothesis or fulfilling the study aims? This is very important. And how the sample size has been calculated. Then we come to the appropriateness of statistical tests which are being used. If it is a parametric student's t-test, if it's a proportion, chi-square test, if it's a correlation, Pearson's correlation test, Spearman's, or or multiple regression analysis has been done. What software we are using? Freely available. Actually, in the thesis, the children are writing SPSS 21 or 23. We should write the freely available software will be used. The level of significance need to be given. In an RCT or an experimental study, the details of how randomization has been taken care of, has the allocation been concealed, is the blinding done, whether it is an open blind study, single blind study, or a double blind study, all these things need to be mentioned so that we know that the bias has been taken care of. Then the details of all interventions, drugs, chemicals, kits, and instruments need to be mentioned. The next question is, was the study design appropriate for the research question? So this is a very, very important topic, and we should remember for assessing the effectiveness of treatment in terms of efficacy, safety, statistic, or cost analysis or patient satisfaction, the best method is an RCT. While for studying the observation, studying the frequency may be in the form of incidence, prevalence, clinical features, prognosis, diagnosis, risk factor, prediction of outcome, and quality of health. All these studies will come in the observational study. As Dr. Radhika has nicely mentioned, the level 1 study is the meta-analysis and systematic analysis of well-conducted RCTs. But because of dearth of time, cost, ethical problems, and feasibility, RCTs are not always possible, and they can be replaced according to feasibility by non-randomized controlled trials, cohort studies, case control studies, cross-sectional studies. There are another type of studies which are diagnostic test accuracy studies also. So this is the hierarchy of evidence. The in vitro or test tube research forms the lowest category. Then comes the animal research, then followed by ideas, opinions, editorials, case reports and case series. Then comes the cross-sectional studies, case control studies, cohort studies, and level 1 is RCTs, and level 1A is systematic studies or meta-analysis. So we need to see, did the study methods address the key potential sources of bias? Random error is a chance error, which is occurring by chance. It does not influence the results in any particular direction, but it may influence the precision of the study. But systematic biases are those problems, the bias which is introduced due to the way in which the study was conducted. Or how study participants were selected, how the data was collected, or due to researchers' analysis or interpretation. They may not correctly interpret the findings of the study because of the lacunae of a small sample size or some other problem. They influence the direction of the study. It may lead to overestimation or underestimation of the truth. So there are some checklists which have been prepared for effective and objective evaluation of each type of studies. This is the critical appraisal skills program. The program coordinators have developed separate checklists for different types of studies, and each comprises of 10 questions. So for evaluating the systematic reviews and meta-analysis, the risk of bias can be there. We have to see what type of studies have they included in the study. What is the quality of the RCTs they are including in the study? And it could be influenced by the citation bias, which could be citation or non-citation of research findings, depending on the nature and direction of the results. There could be publication bias because generally the positive outcomes, if the hypothesis is positive, only then the publication is being done. Or there may be a language bias. The CASP checklist for different studies is the quorum, which is the quality of reporting of meta-analysis. AMSTER is the assessment tool for appraisal of systematic review. MOOS is the meta-analysis of observational studies in epidemiological guidelines, that is the non-RCTs, cohort, case control, and cross-sectional study. And the STROBE, which is used for strengthening and reporting of observational studies, all the non-RCT studies. So whenever we are appraising or critically evaluating any article, we can have these checklists in front of us and see if the proper steps have been followed or not. So in cohort studies and non-RCTs, the bias is because of selection bias or confounding factors. This could be because of the patient's preference to a particular group, the clinician's preference. This is a very serious case, so she should be put in the conventional group, the standard group, or the referral patterns, current treatment paradigms, or the local hospital policy. All these things are going to influence the bias and bring the bias in the cohort and non-RCT studies. In the case control studies, bias again could be because it is a retrospective studies. We are taking the cases when the disease has already occurred. So there could be a selection and appropriate control, or there could be a recall bias also. The RCTs are the best study design for reducing the amount of bias by random allocation of participants, which will ensure that both the treatment and the control group are equivalent in terms of known and unknown confounding factors. So randomization can be done by computer generated random numbers or random number tables, and less vague methods like concealment method, color coded forms should not be used. For evaluating the RCTs, we have the Consolidated Standards of Reporting Trials, or the CONSORT statement, which is a comprehensive tool to assess all the steps properly. So this is how the CONSORT flowchart looks like. It takes care of how randomization was done, whether concealed allocation was done or not, blinding, whether it is a single blind, double blind study or open label study. Who is blinded, the participants, the investigator, or the analyzer? What were the outcomes? Were they assessed objectively? Were all the participants accounted for in the final analysis? Because some of the patients may not follow up, or they may not adhere to the protocol, or there may be variations, so violations. So was she treated per protocol? That is actual what has happened, or it is intention to treat protocol. Of course, the per protocol where the patients have not adhered to or not followed up is inferior to the intention to treat protocol. So this is what when intention to treat protocol is when complete outcome data is available, no patient is lost to follow-up, which is superior to per protocol analysis, which will analyze only the patients we have at the end with known outcomes who have followed the protocol. So in the results, we have to see whether objective representation of experiment results has been done, and does it support the hypothesis? Is it giving a summary of key findings which are arranged in the same sequence as they are mentioned in the methodology section? Whether the legends, figures, and tables are self-explanatory, and also there should not be any duplication in the text and the figures or tables. In the thesis, it is okay because they are repeating the same thing. They are writing so many sentences and they are representing the same thing in the figures and tables. But this should not be seen in the result section of an article. And remember, it is not a discussion. So no analysis, no comparison with another study in this section. You have to see whether the study was performed in line with the original protocol, because any deviation from the planned protocol can affect the validity of the study. So the common deviations are, most common is failure to recruit planned number of participants. It will decrease the power of the study. The changes to the inclusion and exclusion criteria, variation in treatments or interventions, changes to be employed in the techniques or technologies, and changes in the duration of follow-up. So any of these deviation, it has to be mentioned in the result and has to be analyzed in the discussion section. In the discussion section, we need to see if the results are properly explained and whether the results are comparable to similar studies or they are contradictory. And if they are contradictory to other authors, what are the reasons for the variations? Different ethnicity, different type age group of patients, the study design, or the patient population. All these things can have a difference in the study design of another author and your paper. So all these things need to be seen, whether they have also mentioned the strengths and the limitations of their studies. That should also be mentioned in the discussion section. And then finally, we need to see whether it can be generalized for the whole population. Does the study test the stated hypothesis? Hypothesis we have seen is mentioned in the introduction. It is crucial to identify the study hypothesis and check if all data relevant to the study objectives have been reported without any omission. According to whether it was a non-inferiority or an equivalence trial, in non-inferiority trials, the margin has to be pre-specified. Were the statistical analysis performed correctly? All articles in the methodology give how the statistical analysis is to be done and their rationale. Has it been done actually in the analysis, in the results and discussion? Patients who are lost to follow-up and missing data has to be reported in the results section. And if we follow the consort flowchart in the RCTs, it helps us to evaluate the flow of participants. Then in the end, we have to see whether the data and the analysis is appropriate and the conclusion has been given vis-a-vis the data and the discussion. Sometimes what happens is because of the statistical significance, a useless clinical finding which is not very important to us, or a finding which is not clinically important to us, may appear to be very statistically significant. On the other hand, a clinically significant finding may not come out to be statistically significant. This may be because of a small sample size. So all these things we need to critically evaluate if it is appropriate to the study design and to the study question. Then also we need to see whether in the controlled study design it could be done, or can it be generalized to the general population? Can we adapt it to our own clinical practice? And at the end of the article, we should look for any conflicts of interest, which could be that the person is employed by a particular firm, they have got an aid, they are getting a salary, they are getting a patent, or some professional benefit in reporting particular findings. So all those things have to be mentioned at the end of the paper. And also check for a declaration or open disclosure regarding the sources of funding of the study. The results, the references are also very important. They are generally given in the Harvard or Vancouver, but most commonly the Vancouver style is followed. Whatever is the journal, whatever design they want, we should follow the same. And Dr. Patel had very nicely given the sequence of how the Vancouver style references are to be mentioned. So we should check for the references. They should not be more than 10 years old. We should not give references of papers which we have not evaluated or not read. Okay, so the high-tech tools are there available now, and bibliography software tools like Reference Manager, ProCite, and EndNote. I'm sure Dr. Radhika will be elaborating on that. And I thank you all for patient hearing.
Thank you so much, Dr. Pikee.
I hope I finished in time.
Thank you. Yeah, Dr. Pikee. You were quite elaborative. Still, we could finish in time, and everything was covered. Very nice. Now I will hand over to Dr. Ankita.
Thank you, ma'am. I thank the chairpersons and speakers for the academic feast. I now hand the stage to Dr. Sharmishta Garg for continuing the next session.
Thank you, Ankita. Good evening, everyone. Now, to begin with the last session of this evening, I would like to call the next chairperson, Dr. Mala Srivastava, ma'am, present President AOGD, and she's a senior consultant in the Institute of Obs and Gynae, Sir Ganga Ram Hospital, and Dr. Kanika Jain. She is a Vice President AOGD 2020-21, and she is also senior consultant in Institute of Obs and Gynae.
Thanks, Dr. Sharmishta. We begin the last session of the day, and it's my pleasure to invite Dr. Suvarna Khadilkar for her talk. Dr. Suvarna is the editor-in-chief of Journal of Obs and Gynae of India. She's professor and HOD, OB-Gynae, consultant endocrinologist and Gynae Department, Bombay Hospital. And she's the recognized teaching faculty endocrinology, South Wales, UK. She is the editor-in-chief, and due to her initiative, we are having this program today. And she's also the treasurer of Foxy. Over to you, Dr. Suvarna, for your deliberation. Dr. Suvarna, are you here? In case Dr. Suvarna is not there, then I think we can call upon Dr. Sunita Mailk.
Dr. Mala, I can't see the, Dr. Suvarna is there. She's unmuted also. She's there in the participants list. She's unmuted also.
We are asking you to come for the lecture.
Yes, I'm coming. Yeah. Just now I'm coming. Yeah, sorry.
So we have Dr. Suvarna with us.
Shall I start my screen share or something, or you
Yes,
have
you
any other
can go ahead. We are not having Dr. Radhika's lecture. Madam has combined both the lectures into one consolidated.
Okay.
She has finished.
Okay.
We are now just
So
waiting
how
for.
do I share? But I'm not getting that.
Yeah, we are.
You can see now?
Yes. It's a white screen.
Ma'am, it's a whiteboard.
So now what do I do?
Stop share and then you open the slide and then start sharing.
First I open the slides.
Yeah.
Just give me a minute. I was busy. I got busy with something else, so I just left and I came back again. Just give me a minute. You are able to see my screen?
You are visible, madam, but not your screen. Your video is visible.
Okay. Okay. I will first start my presentation and then I'll share.
Yeah.
Now I start sharing.
Yes. Yes, ma'am.
Yeah, but when I share, that option doesn't come where we need to.
Deepika, you have to stop sharing.
What, that whiteboard thing comes up again?
Mine is stop shared, ma'am.
Okay, so okay, I'll just see now again.
Ma'am, on top you see whether it is basic. You are into base.
Whiteboard on the left side. Okay, I got it. I got it. Yes, I think so. Is that visible now?
Yes. Yes, ma'am.
Yeah, yeah. Okay. Okay. So good afternoon, everyone, and I hope I am audible well also.
Yes, ma'am.
Okay, thank you so much. At the outset, I want to congratulate Mala, Srivastava, and the whole team of AOGD who have painstakingly taken this Picsep program, and they are having a wonderful time since morning. I'm logged in since quite some time, and all the lectures have been very, very good. And I hope the students do get benefit out of all the series of lectures. I bring greetings from Mumbai, and my topic is, of course, of great interest to all. It's not only the students, but also the teachers and everyone, or each and everyone who is interested in scientific research and publication. Before I go to the topic, let me share a few things. This was the new face of Jogi in 2018 when I took over as editor-in-chief. All of you have my message, I hope so. And you know, when the journal was founded, ours is a journal founded in 1950. Founder editor was Dr. Jerusha Girard. People used to tell me that you are the first lady editor, but let me tell you, I'm not the first one. Her founder editor was a lady, a real, you can say, visionary who has, where this journal has gone today, which she started in 1950. And today the journal is circulated to our members, more than 37,000 obstetricians and gynecologists, and the readership, global readership is across the country, it is 2 lakh, but global readership is just beyond, I don't have the figures, but it is quite high, much in, you can say that it improved very much over the years. International edition is also there, and we have online version readership globally. It is abstracted in PubMed Central and indexed in Scopus. I think all this Dr. Radhika has very nicely covered all the indexing databases, the Scopus, Embase, these are the indexing agencies. So, and one feather in the cap, our journal has been taken by the Maharashtra University of Health Sciences, that is MUHS, and they have included our journal in their must read section for postgraduate students. So that was a very, very great achievement, I must say, that all this while, of course, our journal is the biggest and #1 journal in OBGYN in India and even Asia. So it was actually due this honor, but it's happened during my tenure. So I'm very much happy and proud of it. These are the Picsep workshops which we have been holding since last 13 years, more than 100 workshops. These are some of the glimpses where we go and physically visit. But one thing I found in this e-Picsep, that so many societies, they could not organize Picsep. are coming forward. They are asking for Picsep programs, even the smaller societies where, you know, the connectivity is not so good physically, but you can connect very well on internet and have this wonderful research methodology workshops reaching out to them. And the attendance, if you see, earlier we used to have 50-60 students, and today I think there are about 100 people, and there have been workshops recently where we have 700 plus attendees. Now I'm not sure how many of them are actually mentally attending, or it is just the audio video is connected, but they are putting it off and they are not listening to it. But I think this is one of the workshops where you need to be attentive when students, it is important how to go ahead with the research methodology. You have learned throughout the day what should be done and what is right thing to do. Now we will learn what not to do, and we will also learn what are the ethical principles which guide the research. And you must avoid whatever wrong things are happening in the field of publishing. You must avoid them, otherwise you will land up in trouble. So what is ethics, what is guidelines, and what is law? Ethics is the correct behavior dictated internally by one's own moral integrity. Guidelines are the norms for correct behavior laid but not forced. Law is correct behavior governed externally or enforced by state, and then you are punished for not following it. These are the various codes of medical ethics. The oldest medical ethics has been described 10th century BC, Charaka Sanhita, all of you know, and it has gone through different ages, and now we have Delhi Medical Council regulations, revised Helsinki declarations, which we follow, and these are the medical ethics codes. These are the guidelines, right from 1979 going through several different guidelines are available. We have revised ICMR guidelines in 2000, which were further revised with biomedical research on human participants in 2006. And so what are the principles of the scientific methods? Scientific methodologies, the formulation, testing of hypothesis, controlled observations or experiments, and analysis and interpretation of data, oral and written presentation of all these components to scientific colleagues for discussion and further conclusions. So because it is not just you are doing research for your own happiness, your own satisfaction, but what you do, how it is received by your scientific colleagues, and how it is received, and after reading, how it benefits to the readers and the practitioners. That is what is important. So what is ethical research? A good research is well justified, well planned, appropriately designed, approved by its institutional ethical committee or independent ethical committee if you are not attached to any particular institute. Informed consent from the participants must be obtained, and if substandard research of may constitute misconduct. See, without you knowing that this you have performed a substandard research, and mind you, the search. See, I saw the beautiful lecture by Dr. Radhika. She was telling you how to search on Google. Recently, we have had a complaint, or you can say there is an issue where the one complainant has said that another author who has published a paper in our journal, they have stolen their idea, they have stolen the concept of the other authors. So these authors have complained to us, and that author who against whom the complaint is saying that I have searched all the topics on Google and I have not found your paper, so you cannot say that I have stolen your idea. But let me tell you, friends, when I tried to search that, I could get that paper easily. So obviously it was a substandard search that author did, and she is claiming that she did not have that kind of article on the net, and she says that it is her original innovation that she did. So I think these are the issues you must know. You must do a thorough search and thorough research. Any substandard or which is not meeting the criteria, it constitutes misconduct. What are the various practices in science and publication? Unethical patient research, research fraud or untrue data, selective or inaccurate publication, plagiarism, redundant publication, undeclared conflict of interest, inappropriate authorship, inappropriate acknowledgements, and premature public statements. So each of this we are going to discuss one by one. But let me tell you, friends, the premature public statement is one where after you have undertaken a project, you have found something good or a very breakthrough results, and you feel very good about it. So before even it is accepted and published in the journal that you are going to submit, or you are already submitted but it is still not accepted, you are calling media, you are calling social or whichever media, and you give a interview and say that, look, we have found this. So this is not right. Unless it is scientifically accepted in a journal, then only you should go ahead and talk to the media or you make a public statement. So that's also unethical. What is publication bias? Positive trials are more likely to be submitted and published quickly. So where are the negative studies? Because I think it is very important and it's a lesson for us editors, because there is a tendency for on the side of editors also that the negative result, then we tend to say that, look, what is there, they have not proven what their hypothesis was, so why publish it? So I think one should not get carried away by that. That creates a publication bias, and you should give a due balance of positive as well as negative studies and give weightage to both types of studies and accept and publish them. The components of ethical research, first and foremost, is scientific integrity. Without this, scientific community and general public may become victims of scientific misconduct. There has to be a good mentor trainee relationship, and you have to train your students to conduct ethical research. Otherwise, I have seen the teachers themselves are telling the students, okay, just take any 100 cases. The student says, ma'am, there are no 100 cases in our ward, how do I take? Just make it up. So if the teacher is telling the student to make up the false data, what training you are imparting, and what training what student will learn is wrong things, and in future when he becomes a teacher, he is going to also do the same thing. So we must have a very good mentor trainee relationship. You must have a proper data acquisition, management, sharing, and ownerships. Research involving human and animal subjects must be done with principles laid down. Collaborative science is good, and you must not say that the collaborators are plagiarizing with each other. Something like one of the co-authors, when you are suppose two centers, you are collaborating, one center has got a particular innovative idea, and then you have decided to have a collaborative project. But then you cannot say that that particular author has stolen your idea, because you have now decided to have a collaborative science and then the publication. Conflict of interest must be declared. Responsible authorship must be, you must have authorship absolutely appropriate and responsible. Appropriate publication practices must be there, and it is the double blind peer review which will give unbiased scrutiny. So it is, ethics is not to be followed just by the authors who are submitting, but the ethics have to be followed, and you have to follow all these principles. It's on not only by authors, but the editors, the entire editorial team, the peer reviewers, everybody, the science, even the office staff. Because suppose the office staff starts leaking what is happening with their paper, and if there are inquiries, that is also absolutely not. Now certain confidentiality has to be maintained. So all these ethical principles have to be followed. So how do you define scientific misconduct? Research misconduct is defined as fabrication, falsification, plagiarism, and in proposing, mind you, in proposing, performing, or reviewing research. Even if you propose the wrong research, then it is plagiarism in that is scientific misconduct. Even if you have not published it, but you have proposed a copied project, it's a plagiarism. Any action may be taken against you even if it is not published. So author's moral integrity governs his behavior in scientific writing, and truth in science is the goal of the discipline. So what is not scientific misconduct? Honest errors, differences of opinion. For example, I treat all my patients of prolapse with vaginal hysterectomy, but there are other authors, they feel that such type of prolapses can be treated conservatively. So if there is a difference of opinion, both the methods are described in science in the gynecology. So we don't say that this is something which is not appropriate, that paper has come with conservative approach. I will not say that this is wrong and this is unethical and all that. No, it is possible that kind of treatment is also possible. This is just a simple difference of opinion. Scientific collaborators cannot plagiarize from each other, which I have already elaborated. Mentor-trainee relationship, as also I've already elaborated. So mentoring and being mentored are lifelong essential components of professional life. How do we manage the data? Scientific data, there are three types of categories of data. Experimental protocols have a detailed plan of scientific and medical experiments, treatment, or procedure. Primary data includes the instrument setup, output, raw and processed data, and statistical calculations, photographic images, electronic files, and procedures of reduction and analysis, the method by which you process the original data in the study. So any individual involved in the development or execution of an experiment and subsequent data processing is responsible for the accuracy of scientific data. So who are those individuals? It's the principal investigator, postdoctoral fellow, student, research assistant, other support staff. Can a student say that, no, this is my guide? No, suppose without knowledge of the guide, student undertakes some misconduct, he will be responsible provided it is proven that he has done on his own and without taking any, without informing the guide or other colleagues of that particular project. NIH recommends that all the data and laboratory notebooks should be retained for 5 to 7 years. Whatever research I have done, I maintain them for 10 years with the master chart, so that in case there is any query, I have the entire master chart with me. Now, all of you know, I won't go into the details, but research involving human experiments, human participants have to be done with this particular statement, which is given in our journal also. And it is as per the Declaration of Helsinki and its later amendments. We must say that you have taken with keeping in mind the that Helsinki's declaration. A statement on the welfare of animals. Again, if you are conducting a research on animals, then you have to make a statement which is given on our journal website, that when reporting experiments on animal, author must indicate whether international, national, or institutional guidelines for the care and use of animals have been followed, and you have to strictly adhere to those guidelines. Conflict of interest has been defined as a set of conditions in professional judgment concerning a primary interest, such as patient's welfare or the validity of a research, tends to be unduly influenced by secondary interests such as money. Now, understand what is conflict. So anything which is likely to change the outcome of the study is conflict. So there are various types of conflicts, and there are people who all of them are supposed to declare conflicts. Who are they? Authors, contributors, editors, reviewers, and publishers. Suppose if I am the editor-in-chief and if I get a paper submitted by my own daughter, I am likely to, ignore the bad points or wrong data, or I am likely to accept that paper, ignoring certain drawbacks of that study. because she's my daughter. So that's my personal conflict. And so as an editor, I should declare that she is my daughter and I am accepting this paper. So the readers will take due note of it, and they will take understand that there can be some problems with the study, and or the mother has taken the study of the daughter for publication. Various types of conflicts have to be declared: the academic, financial, personal, commercial, and political. So competing interests also have to be declared. Now, a very common, area where misconduct happens is the authorship order. According to the ICMJ guidelines, that is International Committee of Medical Journal Editors, authorship should be based on 3 points, and all these 3 conditions must all be met. What are they? Substantial contributions to conception, intellectual content and design, or acquisition of data, or analysis and interpretation of data. Second is drafting the article or revising it critically for important intellectual content, and final approval of the version to be published has to be done by all authors. You cannot say that let the first author approve the final version, and in case there is any problem with that version, the author who has not approved the final version is also going to be equally responsible for the contents. So the final approval must be published and approved by all the authors. And all the 3 conditions must be fulfilled. If the individuals who do not meet these 3 criteria, but who have assisted the research by their encouragement, advice, or by providing space, financial support, reagents, routine analysis, patient, then they should be acknowledged, not be authors. So many times I've found that the departmental heads, they tend to tell the students that whatever research you are doing, your teacher is doing, as a HOD, I should be the one of the authors, where I don't do that, even though I am actively involved. And if I fulfill all those 3 criteria, then only I insist that my name should be there in the paper. Otherwise, head of the departments, deans have to be acknowledged for giving permission and supporting the research. Acknowledge the funding, sponsoring agencies, the head of the institute, department don't acknowledge routine work or duty. Something like if you have done a paper where just a case, suppose you have done an routine analysis of urine is done, and you just say that urine is normal, so that urine test need not have the acknowledgement here, because that's a routine job of that person which doesn't have any significant role in the paper. What is inappropriate authorship? Commonest area is of the allegation of misconduct. Simply providing cases is not authorship. Must have made a substantial contribution to the research and publication. And each author must take public responsibility for the data. All qualifying authors must be included, and most publications insist on descriptive note on role of each author and contributor, because if any of one of the author has no role in the paper, so you have to endorse that this particular author has done this contribution to this paper. If not, then he doesn't qualify to be the author. One example of irresponsible authorship. There was a study of PIH by authors, author A, author B, author C. Author A is professor and head of OBGYN, author B is lecturer in ophthalmology, but son of A, and author C is PG student in PSM, daughter of A, and acknowledgement to Mr. D, who is associate professor in OBGYN, for collecting the whole data, writing the whole article, and not objecting to omission of his name and inclusion of names of B and C in view of the larger picture of life. So this is what is irresponsible authorship. The person who is associate professor is actually qualifying to be the author, whereas other two are having conflicts with the head of the department. I doubt whether head of the department had any role also in the paper, but that they become authors, which is absolutely irresponsible. One more interesting form of scientific please write an article for me, and Ginny comes with an article. Here it is master. So this is what is called as ghost writing, the phenomenon where someone other than the named authors make major contribution. Typically, this is done to mass contributions from drug companies. It incorporates plagiarism as well as it has an additional element of financial fraud. Believe me, it is conferring authorship as well as omitting author's name. Both are irresponsible authorships and scientific misconduct. So self-citation, strategic placement of self-citation to inflate the bibliometric indicators. Very often this is done, and it may be grouped under irresponsible authorship. What is plagiarism? The literal meaning to plagiar is Latin word to steal or kidnap. So plagiarius means kidnapper. So there are several definitions of this particular plagiarism. The encyclopedia gives, Oxford Dictionary gives a definition. The World Association of Medical Editors gives the definition as the use of others' published and unpublished ideas or words or other intellectual property without attribution or permission, and presenting them as a new original rather than derived from an existing source. So the COPE, that is the Committee on Publication Ethics, in 1999 have defined this plagiarism, which they have given the gradations of the plagiarism. It ranges from unreferenced use of others' published, unpublished ideas, including research grant application, to submission under new authorship of complex papers, sometimes in a different language, may occur at any stage of planning, research, writing, or publication. It applies to print as well as electronic version. So please don't be under impression that if you have submitted an article to journal, which is a copied article, is not liable for punishment. Then if you think you are having that impression, then you are wrong. Just submission of even wrong article or fraud data, it amounts to plagiarism. And if the editor wishes that repeatedly this author is into doing misconduct, then the editor will refer this matter to appropriate authority for taking action. So the COPE has given the features, 5 features of plagiarism to grade the degree of copying. So extent of copying, originality of the copied material, position and context and type of material, referencing, attribution, and intention. So if the extent is from ranging from a few words to whole of the paper, it goes in increasing severity. So if somebody has taken only few words from a paper, it is of a minor degree of copying. Now, originality of copied material, suppose widely used phrases and ideas have been copied, which is absolutely anybody can use, then it's a minor degree of copying. Whereas if you take original phrase and idea of another author and copy in your own paper, it's a severe degree of copying and plagiarism. If you take the position, context, and type of material, if it is standard method, it's minor. If it is entire data and findings if taken from other sources, then it is a severe degree. Referencing and attribution, if the source is fully and clearly referenced, but it is not given the due recognition, it is a minor degree. But source partially or inaccurately referenced, it is a moderate. And totally not referenced at all, unreferenced material, then it is a severe degree. Sometimes it is called as citation amnesia. So the last but not least, I want to tell each one of you that if the intention to copy is not there, so what we call as unintentional plagiarism. Even if it is unintentional, it is plagiarism and it is liable for action. So don't think that it's happened unknowingly. So what? So of course it is of a lesser degree of plagiarism, and with intention, if it is proven that purposely it has been done, it is severe degree. So what all things can be plagiarized? Anything and everything. The ideas, the concept, the hypothesis, the title, the text material, methods, discussion, charts, tables, figures, and nowadays videos, authorship. You can even steal the authorship in the sense. I will give you one example of that. Stealing of authorship. There was a fraudulent case reported to our journal that one author complained that this is there was one case of cervical pregnancy with bilateral uterine artery embolization. The first author was nowhere connected with the institute from where this paper came, and the author then said that first author is nowhere connected, and that first author just happens to be the wife of the interventional radiologist who conducted the paper, conducted the study. So then we talked to the dean of that institute. We did an inquiry. We referred the matter to research integrity, and finally the action that we took was we had issued a notice of retraction of the paper because the original person who had done the study had a strong objection. Now, intentional or unintentional, I've already said, whatever it is academic dishonesty. Various forms of plagiarism. It can be verbatim, mosaic, paraphrasing, cyber plagiarism, or image plagiarism. The entire image can be copied, which I will show an example little later. Other types of plagiarism like self-plagiarism, which are duplication, augmentation, segmentation, text recycling. What is duplication and why it is bad? Same content, if you are putting in different titles and in different journals, the same data, same patients, same period, then it is definitely considered as misconduct. One example of duplication I will give you, that one paper was published in our journal that renal transplant recipients was fertility outcome in renal transplant recipients in our journal, and another journal pregnancy outcome in renal transplant recipients, little bit title change. However, the same data, same center, same authors, and same study period. This is what is duplication. And then we sent a note to the author why the author should not be blacklisted. And this is how, see, this is not a very serious thing. The author was not knowing that we should not undertake such duplication, but this distorts our systematic reviews and meta-analysis, because it exactly duplicates the data, and two such papers are counted in favor or against a particular hypothesis. So what is redundant publication? Why does this duplication matter? This practice wastes time, resources, it is dishonest, it breaches the copyright, so it is intellectual theft, it distorts the systematic reviews and meta-analysis, it can distort the research record and endanger public health. So that is the final impact that it can have by giving extra double publications. What is salami papers? Salami slicing is sometimes called bologna or trivial publication, is the practice of dividing one significant piece of research into a number of small experiments. They are called least publishable units, LPUs. So I have about, say, data of 10,000 patients. So what I do is I do 1,000 patients, under 50 to 1,000 patients. Actually, it is a main project, but we are divided into small multiple projects. So simply to increase the number of publications, you are undertaking this different slicing of the main project. It wastes valuable time and resources. It simply increases the number of studies that appear to support it. And it is acceptable if there is difference in message to the different readership, but unacceptable if degree of overlap is very, very great. What is augmentation? Very often I've seen 50 patients you have first done, and then after a year again you give 70 patients, then you give 80 patients, 100 patients. So this is the same study published previously is expanded. So it's not really of good practice. Text recycling is also again not a good practice. I was talking to you about citation amnesia. This is a very, very important plagiarism type. And this is also called as the disregard syndrome. Means somebody has done a good paper, published it, and you are disregarded that, and you are publishing something and you say that this is my paper, this is my original idea, and without, if means forgetting what has been done in the same field by other authors. So this is called as bibliographic negligence. So we should not undertake this, and you have to do a thorough search and research to find if any such previous papers have been published, and then claim that you have innovation of your own. Now, there can be misappropriation of data, significant findings due to the results being adverse to the interests of the sponsors. So that's all something wrong. So COPE has defined 2 degrees, major and minor degrees of plagiarism. Major degrees, when all these things are there, I won't go into the details, it is available on the site. And if just in short, if the verbatim copying of more than 100 words, if you find in from the original material in absence of any citation to the source material, it is major. If it is less than verbatim copy of less than 100 words without quotation from an original work, you must take it as a plagiarism of little minor degree, but it is plagiarism. How to avoid? That is a very, very important way. Try to have your original hypothesis. Do not steal ideas. Because you are in practice. If your curious mind must continuously think why that is happening, I must try to correlate and have your own original hypothesis. Keep reading, keep seeing what others are doing, but don't copy their ideas. The study design should be well justified. You must have all informed consents from all the participants. If you don't take consent, then it is absolute scientific misconduct. Define contributions from each co-author, approval by institutional ethical committee, and always keep a copy of approval letter with you. And nowadays our journal is asking for ethical committee permission letter to be uploaded for all the original papers. Search what has already been published on the subject, read it, study the literature, assimilate it, understand, then organize your thoughts. And when you start writing the manuscript, please keep away whatever you read and try to start writing in your own words without looking into the main source. So that is the way you will avoid copying the text. If there is any issue with the language, take help of a senior author or a translator or a native speaker. Divide the write-up under proper standard section headings. And if you, the discussion and introduction are common areas where one gets tempted to copy. So always do paraphrasing or reword or write in your own original word. Do not copy paste. And in case, suppose you think that your paper needs that particular para or that text, for short quotes, use quotation marks in the sentence. For longer quotes, indent the entire passage. For extensive quotation, obtain permission from the publisher of the original work. Attribute references to all of the above. Describe all sources of information. Do not forget to give acknowledgements and provide footnotes. Now, what is important is when you give references, you must refer it to the appropriate text or the figures. If you need to copy paste from your own article also, you have to obtain permission from the publisher. How do you use figures and table and illustrations? Obtain permission for use of published drawings and other illustrations from the publisher. And if you have used a table, cite the source directly below and not somewhere else in the text. It is not enough to have cited the reference somewhere in the text. Seek permission to copy tables and figures. Duplication to be avoided. Avoid writing several articles of the same type. Please do not submit the same article in different journals. Run your final document. This is the best step, I must say, to all students. You all are very net savvy. Run your final document after you write through a plagiarism check software, so that you will know how much of the text is showing that it is already published on net. One example I will give you, a copied figure. It happened with me, and I had done this original work, and then this exactly the same figure appeared in another journal without having any citation below the text. Now my paper was cited below in the reference list, but this paper was written here. I mean, this image was included here without having my reference there. So it appeared as if this figure was done by the author. So this is where the trouble begins. So we wrote a letter to the journal and author, and then they published the errata in the same journal that this figure has been. Then I gave permission to the author, you know, with for copying it retrospectively. I did not want any trouble for any author that way. I mean, you want to help people, and then after getting permission, they have written this errata that this was copied and reproduced with permission. So innocent or coincidence or purposeful fraudulence. Great men may think alike, but remember they are not permitted to write alike. You cannot say that even that author and myself, both of us were, you know, thinking on the same line and we wrote the same lines. So you must avoid self-plagiarism also. I will skip. Why do these unethical practices happen? Easy accessibility, copy paste culture. We have electronic, publications. So it is so easy to copy and paste. Lack of awareness that plagiarism tools exist and editors can detect copy pasting. Authors may get overconfident, you know, if they have done successful attempts, 2 or 3 papers have gone unnoticed that they were copied. They may think, who checks? So another 4th paper they will give. Poor language skills promotes copy paste because they are scared that if I write in my own words and if language is not good, paper will be rejected purely on language grounds. Ignorance that such ethics of scholarly writing exist and they should follow that. So lack of moral integrity, pressure to publish because there are career prospects, ambition, fierce competition, pressure from seniors, publish or perish system. So if you don't publish, your promotions are gone, your post is gone. But remember, in that pressure, if you want to publish unethically or with publish absolutely with plagiarism, then instead of publishing and perishing, you will publish such an article and you will perish, because believe me, action can be taken against you if you publish a plagiarized article. Misuse of power and position is also for this. There are various softwares available. We are using Authenticate. It's a very powerful software that we have for Jogi. Almost 37 million published research articles are searched in a matter of few minutes, and 500 global scientific, technical, medical publishers including PubMed and EBSCO host are included in this. So even though it gives you certain percentage, believe me, I myself go through each and every line and manually I decide whether the percentage numbers are important or the text matter which is copied, that is important. So it has to be both electronic as well as manual detection of copying, and then you apply or take the paper for further processing. What are the penalties? Don't think it is a minor degree of offense. No. There are graded penalties for plagiarism ranging from simple dishonesty to a serious problem. Formal disciplinary action can be taken. What I do is, I simply reject the paper if I find that there is a lot of this thing. Instead of going into taking action, I simply reject so the question doesn't happen. But if I really find that one author is repeatedly doing it, yes, then I'm going to take action on that. So then what can we do? What formal disciplinary action? We can publish errata, which I showed you one example. Apology letters can be seek from the author who has copied. Retraction of the published article is the severe most disciplinary action that we can take. Author can be blacklisted for a specified period. Medical council can suspend authors on these grounds of unethical practices. So you have to think whether you want your registration intact or you want to undertake these risks of copied material. And sometimes I have seen some authors, criminal charges have been levied against them and suspension has happened and prosecution of authors have happened. So these editors can action can take. What I do is I reject information to ombudsman of medical writing. If repeated I do, if repeatedly any author is done any misconduct, I inform the original author. He may take necessary action. He wants to go to police, he wants to go to council, let him do. Why journal should go into that? Our job is to retract that article. If it is of serious nature, criminal proceedings may be undertaken by the author. Remember, proposing plagiarism is also a scientific misconduct. It's not unnecessary that it has to be published. So our country is highest on the list for retraction of articles for fraud. I'm feeling so sad, but this is a 2000 data of year 2000. But let me tell you, our at least last 3 years, I have seen very minimal complaints, and our quality of articles definitely improving in last 10 years. So this is the committee which is I am very proud to say that our journal is a member of this committee. We take all the possible action. Research integrity team is also there, committee is there, and this scope whenever we require any help, we so these are the benefits of avoiding plagiarism. You will earn immense respect amongst peers. Your genuine work will contribute to scientific progress in the field. You will prevent scientific community from becoming victims of untruthful evidence. And this will go a long way to improvise quality of health of our women and community at large. That is our final goal. This is the goal of research otherwise. So I must tell you that all this ethical research and sound publications, they go hand in hand. All the possible people involved in publication, they fulfill their responsibilities as researchers, authors, editors, must understand and be committed to your duties. Good ethical research is a step towards scientific evolution, which will help us achieve our final goal. So let us all pledge against the plagiarism, zero tolerance for plagiarism. Thank you so much.
Thank you. Thank you so much, Dr. Suvarna. That was indeed you had thrown light from the editor's point of view. We have all been talking about what to be written, how the publication needs to be done, how research needs to be done. But if you see from the editor's point of view, like you may be reviewing thousands of publications each day. So from that point of view, we need to really know what all other factors are based on which the research work is rejected or sort of sent again for corrections and for repeat publication. So you've really thrown a very good light upon those aspects, and thank you for that. And I would now like to call the last speaker of the day, the very renowned Dr. Sunita Mailk. Ma'am is the Senior Consultant Head of Unit at Safdarjung Hospital and VMMC. She has been past Vice President of AOGD in 2008 and 2015. And she has held various positions in AOGD in the past years. And she's had many publications to her credit. Her chief areas of interest are gynae-oncology, high-risk pregnancy, and critical care ops. So over to you, ma'am.
Okay, I think I'll take your leave. Thank you so much for having me here, and thank you for being patient. Okay, I have to leave for some work which I was,
okay.
I came in the.
Thank you, ma'am. Thank you for joining us and giving us this opportunity.
I really appreciate the quality of lectures also, and I'm going to miss this wonderful lecture by Dr. Sunita Mailk. So wish you all the best. Thank you so much. Bye-bye.
Okay, bye-bye.
Okay, good evening. Without wasting time, I have started sharing my screen. I am thankful to all the previous speakers. You know, my lecture is a synopsis of all the previous speakers. If a manuscript is written well, why shouldn't the editor accept it? So that is what we have. So I think I'll start it with the other side, what the editors and the reviewers want.
एक्स्ट्रा ऐड तो नहीं किया ना? नहीं, आपका ऐड नहीं किया है, बस डिलीट कर दिया है. कौन सा डिलीट?
Okay, should I go on? We know that now that Dr. Suvarna has also spoken, the Pikee has also told so many things, and Radhika and the first Dr. Geeta and Ruma, everybody has made my life easier. So, but there is pressure on journal editors. There is ever increasing submission volumes. Authors demand for rapid publication. There is difficulty in finding suitable peer reviewers. The need to identify and tackle increasing cases of misconduct. There's increased competition also with other journals. There's new industry development to keep pace with peer review, open access. So many things are there for the authors, editors to see. So what is there inside the mind of a young researcher? Just a minute. My view is getting obstructed. Can I? So, I'm sorry, there's some technical problem on my side. It has been going on since morning. Anyway, so what is there in the mind of a researcher? I wish I had a coach to teach me about journal publication. Even after following all guidelines, the editor thinks I have plagiarized. So that's what you've seen by Dr. Suvarna. She's told you how the plagiarism can be there. I wish I knew what the editor really wants so I could communicate with them better. Why all resources on the research? Again, this. I can't see my own slides, I'm sorry. Yeah. Why are all research resources and research publication only in English? I find it so difficult. I don't understand what is there. So what is inside the mind of an editor? He is so perplexed. All these requests for rapid publication and yet another reviewer turning down my invitation. He has to deal with the reviewers. I'm just swamped with submissions and most of them don't even match my journal scope. Why can't the authors not follow simple formatting guidelines? If they were doing it, I would have gone further. Looks like a plagiarized article, so much to educate the authors about. Wish I could tell my author what exactly we are looking for in a submission. This is what has been taught so far. That is the thing. So I'm going to talk about a little bit on this. So submission is not a black hole that it is going to be rejected. The author submits a paper. The editor sees whether the basic requirements are met. If they are not met, they are outrightly rejected. In fact, 40 to 90% papers are rejected outrightly by the editor himself or herself. But if it is there, basic requirement is met, then they assign it to the reviewer. The reviewer reads it and then sends back the recommendation. The editor collects the reviewer's recommendation. They make a decision based on that. It may be rejected or they may ask for revision. Then the author has to revise the paper, submit, and it goes back. And finally, it is accepted. So this is a cycle which goes on. The process, the editors and reviewers are the most precious source of the journal. Practicing scientists are even leaders in their own field. They have their own work. They do this work to contribute to science on top of their own research, writing, and teaching work. Editors may receive small payment, but reviewers are unpaid. Every month, manuscript takes their precious time. Nowadays, they are even working harder. So I think so many of you have been peer reviewing, and you know how much time does it take to read an article and then critically evaluate, like Pikee said. So that's very important to see. So what editors want? They want a clear match between the research and the journal's editorial focus, guarantees that science is relevant, novel, and timely, superior authorship credentials, writing in a manner that is clear and concise, A guide, they should, young scientists should have a guide to know how to get research papers reviewed, accepted, and published by your leading scientific journal. So before you start, don't panic. That's the most important thing. We know the general structure of this is going to be a little bit of revision of the thing. General structure of full article has title, authors, abstract, keywords, and main text. In the main text, we have IMRAT, introduction, methods, results, and discussion. Then finally, acknowledgements, references, and supplementary material. So starting with title, start with stellar pitch. But this pitch should be according to three things: the magazine, the journal where you are sending it, the article, the section that the editor handles. I have actually cut short my slides. Like I want to send some article on benefits of breastfeeding. Instead of writing like this, I may give this title as breastfeeding eases a child's susceptibility to obesity. Maybe it's a better title. For bone health, I may be writing so many things, but one particular I have taken up: soy milk is good for bone health, and then pros and cons of that and other aspects of bone health. So that's what is required. Editors hate titles that are too long. Don't go on, the whole abstract comes in the title. That also should not be there. Boring, misguiding, or contain repetition of terms or notions. Avoid technical jargon. That's another important thing. Now, coming to abstract after the title, it should stand alone. This is the advertisement of your article. So many times when we are asking for a topic to be selected, for the students to bring abstracts, so we don't go to the full articles. We always ask them to bring the abstracts, and then we decide according to that. So that this is worth doing or not. So it should tell the prospective reader what you did and it has all the key findings. That's very important. It should be accurate, specific. A clear abstract will strongly influence whether or not your work is further considered. Follow the word limitation. Different journals have different requirements for the content of the abstract. So keywords, which is very important if you want your article to be cited, like Dr. Radhika said. So this is important to give proper keywords. These are the labels of your manuscript and critical and correct indexing and searching. It shouldn't be too broad or too narrow. If you want to use abbreviation, then use the one which are well established, like PROM for premature rupture membrane, and like that. Check the guide for authors, the number, the label, design, thesaurus, range, and other specific requests. And there are guidelines for even getting the keywords also, which has been told earlier. Now coming to the main article, the introduction. It's your chance to convince the reader of the importance of your work. Describe the problem. Are there any existing solution? What was the main limitations of previous article? And what are you going to do in your research? That's important to write an introduction. Provide a perspective consistent with the nature of the journal. Introduce a main publication on which your work is based. So you should definitely cite that publication on which you got the idea and then you want to improve on that, or it's an original idea. Cite a couple of original and important work, including the recent review articles. Editors hate references irrelevant to the work and that cause inappropriate judgment on your own achievements. They will think that you have no sense of purpose at all. So that's very important when you are writing down the thing, that you should be citing the things properly. The methodology, the methods. It has to be in details. That's very important. To write down how you are going to go about it and what are the inclusion, exclusion criteria, aim, objective, everything should come in this. Knowledgeable readers should be able to reproduce the experiment. It should be written so properly. However, if references and use references and supplementary material for the previously published procedure, like if you are doing urine routine examination, so everybody knows what was the routine, how it is being done. So you don't have to repeat the details of that established method. General summary with reference is sufficient wherever you have picked it up. Reviewers will criticize incomplete or incorrect description, and may even recommend rejection just based on methodology also. So that's what has to be seen. Now coming on to the results, only the representative results essential for the discussion should be presented. Show the details of secondary importance or secondary outcome measures in supplementary material. Don't overshadow your main results with the secondary importance material. But also do not hide data, like Dr. Suvarna was saying. Don't do slimy slicing. Do not hide data in the hope of saving it for a later paper. You may lose evidence to support your conclusion. So if you have a big research project, give it proper so that your conclusion comes out to be right, your results are better. Use subheadings to keep results of the same type together so that they're easier and to review and read, and tell easy to understand story. Discussion. This is the most important section of the manuscript. It's a chance to sell your data. Many manuscripts are rejected because the discussion was not good. The discussion should be corresponding to your data, but do not reiterate the results. So many times I've seen, especially even with my postgraduate students, I have seen that while writing discussion, they'll again repeat the results and then start comparing. So don't reiterate, be proper so that you are comparing it proper. And you don't need to compare it with the published results which are similar to yours. You are supposed to compare the results with yours in discussion, but do not ignore the work which doesn't match you. Rather discuss why your results are better or more correct than theirs, or why is it not matching. So that's very important to give in discussion. Now the scientific language, the grammar should be proper. So many times we have seen the present, the past tense, and future tense all being mixed. So just an example, present tenses for known facts and hypotheses. Like I did a project on pro-BNP in hypertension. The average level of anti-pro-BNP normal pregnancy is 60 picogram per ml. So it is. Past tense for experiments you conducted. The sample was stored at a temperature of minus 15 degrees centigrade before testing. Past tense when you describe the results of an experiment. So every level in hypertensive women was found to be 700 picograms. So that's how, this is just a small example. But the language has to be very proper, the grammar and everything. In fact, once you've written your manuscript, please ask somebody who's better at English to read your this thing and point out your mistakes so that you can rewrite. Now coming to conclusion, this is the most important part of your manuscript. Should be absolutely clear so as to facilitate the readers to judge your work, whether or not it merits the publication. Do not repeat the abstract or just list the experimental research. Provide a clear scientific justification to your work and indicate possible applications. This is very important. Why, what you have achieved, what is the justification, how can it be used in future? And you may also suggest further recommendations for future experiments or point out which are already underway being done by others also, and how it is going to help the readers, the others in this. So conclusion is most important part of your manuscript. References. More mistakes are found in this section than any other section, which causes great headache for the editors. Cite and now that has been already told, Vancouver, Harvard style can be used. Mostly we use Vancouver style in our manuscripts. Cite the main publication on which your work is based. This has to be properly cited. Do not impair the manuscript with too many references. That's important. It doesn't have. And avoid excessive self-citation. Glorification of your own previous work you want to do. Please don't do that excessively. Avoid excessive citation of publications from the same region also. That's very important when you are quoting the references. So you should see the data, the research should be done properly, like Dr. Radhika said, and now then find out what publication need to be cited and how they are going to help in your manuscript. Now, after my publication is complete, I need to write a cover letter. So I will write, Dear Editor-in-Chief, I'm sending you our manuscript entitled so-and-so by researcher so-and-so for publication in journal. Please let me know of your decision at your earliest convenience. I'm so much in a hurry that I want it so that if it is not accepted, then I could go to the other journal. So that's what, with best regards, sincerely yours. This is not the way to write down. Instead, check to see whether journal instructions to the authors have any cover letter requirement, for example, to give disclosure statements, potential reviewers. If yes, then cover the following points. If known, address the editor who will be assessing your manuscript by their name. Include the date of submission and the journal you are submitting to. The cover letter, in the first paragraph, you should write down the title, the type of study, brief background of your study, not the one which you have written in your introduction or abstract. The question you sought out to answer. The second paragraph should include concisely explain what was done, the main finding, and their significance. Third should include why the readers of the journal will be interested in your work, include a sentence on the importance of the result to the field, and to conclude, state the corresponding author, any journal specific requirement that need to be complied. Ethics, that's very important, ethical standards, which Dr. Suvarna has told in so much in detail. So peer review process, it could be a open peer review with where author and the reviewer, they know each other. It could be one-sided, like reviewers know the author, but the author doesn't know whom the article has gone. Or it could be double-blind reviewing also. So if my paper has gone from the initial submission to peer review, so that's one step I've already crossed. Don't be afraid, it's a positive process. Through the peer review process, the manuscript becomes more robust. The reviewers may point out gaps that need explanation or additional experiments. It becomes easier to read. If parts of your manuscript are difficult that even an expert cannot understand, how will a reader understand if he's from a different field? It becomes more useful. Peer reviewers understand the importance of your paper in your field and can make suggestions to improve or better highlight. In fact, if I get reviewer suggestions, I'm happy. That means at least peer reviewers have accepted my main idea, and then further improvement needs to be done. So now once they have written me back that these are the suggestions of the reviewers, now how to go about the second letter, which I need to do, revising and the responding. Thank the reviewers for their time and comments. Address all points raised by them and give point by point reference. Analyze the reviews recommended unless you believe that it will not make your paper better. So if you disagree with their points, then provide a polite and scientific rebuttal to any points. Differentiate between reviewer comments and your response. Clearly show the major revisions in your text, either by highlighting or by Microsoft track changer features or any other features or tracker we can use. And also describe it in the cover letter, what you have done point-wise. And return the revised manuscript within the allotted time by them. That's very important. So now to summarize, what are the common reasons for rejection? It could be technical, it could be editorial. Technical reason could be incomplete data, too small a sample size, missing a poor control or something other wrong with the size calculation, poor analysis, inappropriate statistical methods have been used, inappropriate methodology for answering your hypothesis, old methodology that has been surpassed by newer methods and better results, then it will not be accepted. Weak research motive, your question is not right, hypothesis is not clear, data does not match the research question, inaccurate conclusions not supported by data. So these are the important technical reasons where so these are the things which are seen by the editorial board. These are there, then they're outrightly rejected even before sending to the peer reviewer. Editorial reasons could be out of the scope of the journal, not enough impact for the journal, research ethics have been ignored, lack of proper structure, or not following the journal format requirements, lack of specific details for the readers to fully understand the author's analysis, lack of up-to-date references or too much of self-citation, poor language, difficult to follow logic or poorly presented data, violation of publication ethics. That's very, very important. which has been highlighted previously. So publication ethics, I'm not going to go into the detail. Could be data fabrication, falsification, plagiarism, multiple submission, redundant or slummy publications, improper author contribution and attribution. It has been discussed in detail, not going into that. So this is the final, how to please your editors and peer reviewers. Make sure the message is clear in the paper and abstract, not just in the cover letter. Include extras for, like stop checklist site and send and closely related papers and peer review reports also. Communicate clearly and promptly. That's very important. So to conclude that it's not that author everything or editor is everything. It is a symbiotic relationship, which is without writers, the editors don't have any content, and without content, publications would fall apart. So we need the authors, and authors need the editors. So both way, it goes a two-way process. Thank you very much. I think I've cut short. I have been cutting short my slides, depending on the lecture since morning. I thought I will not go into the details. Thank you. Thank you, Dr. Mala and your team for inviting me over.
Thank you, Dr. Sunita. That was indeed a very, very crisp layout, and you've sort of briefed what all other speakers have also mentioned. So you've just touched base and moved ahead. So that was very nice. And now I would like to take up some questions which have come up in the Q&A box and otherwise. For the speakers, I hope we are all there. So I would start with the question by Dr. Manisha Agarwal. She wants to know, do we have to take do we have to take permission from the Drug Controller of India to compare the use of Vicryl and catgut for wound closure in the research studies?
See, I'll answer that. If a thing is already been approved by the government of India, the DCGI, and it's in the market, so then we can very well use and compare it. But if there is a certain drug which is like so many times we see the FDA approved thing, then and not approved by DCGI, then of course we need to take permission from our local authorities. That's very important. We can't do any trial.
Okay. And she wants to know in the introduction if there is a WHO study. So if we copy and paste with reference to this, will this be included in plagiarism?
Pikee, yes, go ahead. Yeah, copy pasting is not allowed. You have to have your own language. That's very important. Dr. Suvarna has told so clearly. That's the thing.
Okay. So I think Dr. Pikee has muted herself. Also, another question from Dr. Vidyadhan Bengal. Rather question is she wants these PPTs because she wants to these PPTs to be circulated with faculty members so that they can teach their PGs and they can be helpful for them for further research work. So I think maybe Dr. Mala or Dr. Deepika.
Actually, ma'am, our YouTube channel will be having the recording of it later on for reference. Okay. So they could always go back to the YouTube channel. We'll be uploading in 2-3 days time.
Okay. And there's a question from Dr. Mala Srivastava. She wants to know, can we have a study with only 30 patients? If there's some newer surgical technique or a newer investigative technique they want to explore into. So can we start a study with just 30 patients? Who would answer this?
Yes, you could. There is something a pilot study. Okay, Dr. Radhika, you go. I'll wait.
No. Carry on, Ruma. I joined in. I didn't hear you speak. Please carry on.
Yeah. No, I'm saying there's something known as a pilot study where there hasn't been anything known on, let's say, this technique that you talk about, and you wish to compare it with an established technique. So in that case, a small numbers of people, now your small sample size would be fine, and then you call it a pilot study. So 30 should be all right.
And it's also, if it's a rare this thing and you have a time limit, then you can give 30 cases. That's a minimum requirement actually for that. some rare events or rare which you want to record. I mean, not a very prevalent disease. And the statistical significance is there, then also we can use that. Of course, mostly it's used in pilot studies.
Actually, there is something called the rule of thumb.
Yeah.
So it is 30 and 300, so if you want to do a population study, it is taken as 300 for anything. But generally accepted, the problem is with the thesis, because they have a short duration of stay in the department. So by and large, like what Dr. Sunita and Ruma have already said, piloting, yes, 30 is acceptable. Piloting for rare things can even be lesser. But yeah, generally depending on the prevalence of the condition, 30 is, for a thesis, 30 is generally accepted. So with the controls, it becomes 60 actually.
Okay. And Dr. Mala also wants to know what time frame is normally given to review for the review of an article. What time frame should be given rather? Like for how much time should we wait after submitting an article?
So it depends on the journal where you have submitted. I was reading a elsewhere publication. They wrote down that they get around 2 million articles every year, all over, not only medicine, all over. And they have 7,000 editors and 50,000 reviewers, and of course, so many other factors to be seen. So it all depends on that, and how good is the reviewers. They give you the articles back. Generally, these days with open access and all, time is now less as compared to
But
previous.
I guess I think she's right. There should be a time limit given at least, because I remember I had sent a very unique case for report in the PubMed Index article, and it took 2.5 years. After 1 year, I got
no, Kanika, majority of the good journals, if you were to visit the home page, they give you a brief idea of the time that they take for reverting, So
Yeah,
nowadays it has become all the, it's become a part of the introduction to the journal. I do
Yeah, they
agree
do.
with you. This used to be the case, but with the electronic communication now coming in, 5 years from today, this was not the case. But now things have become much, because authors are free to retract their articles also, they if they take inordinately long time, then you are very much free to say that you are not wanting to wait and you are withdrawing your article. So
But ma'am,
the
what
journals.
happened was, I'll tell you my case. What happened was, it was a PubMed Index, and I got, after a year or maybe 9-10 months, I got a mail from them that it is under review and it is under consideration and all that. Then you would definitely like to wait. But ultimately, the time it got published was 2.5 years.
Yeah, I can understand that. So sometimes there is also a difference between charged and uncharged. So things like, the BMC group of journals, because we belong to LMIC and they have a huge publication fee. So you ask for free publication, then again, they put you in they don't say as much, but it happens. So sometimes those are factors.
If
Money
you have to
also
go for the
plays.
PubMed Index, then you have to just wait and wait. That is what I realized.
No, if they also have now open access, then where you pay and get it published. So that's they also have now even BMJ and BGOG, they have also started it. So you have to see where you want to send and where you want to get it published.
Right.
Okay, and a question for Ruma from my side. Ruma, can we have a descriptive study in a short span?
Yes, a cross-sectional study, a prevalence study is a descriptive study. So, tell me the question. I mean, basically, you first define the question before choosing the study design. So, let us say you're looking at, and it has to be, if you want it to be published, it has to be a question which hasn't been answered before for a descriptive study, a purely descriptive study to be published. So if there is a hypothesis in your head, if there is something about, so let's say we talk about coronavirus and there's a whole lot of publications that are happening, but you wanted to see, let's say, the post-COVID complications in women delivering at your hospital within 1 month of delivery. Who are the ones? So you define who your post-COVID complications were. I mean, what is a post-COVID case?
What you're looking for.
And then what are the complications? So once she's been deemed negative, and then you look at complications within, let's say, a period of 6 months in pregnant women. So here you are basically talking about a case series, maybe about 5 cases, 10 cases, 15 cases. That also becomes a descriptive study. But let's say you knew that you're looking for the incidence of pulmonary complications in women who have delivered at your hospital within 6 months of delivery. Then you are only sort of interviewing them and you're looking at whether one had it or not. You define what is pulmonary complication, what it is, and then you of course present your results. That is again a descriptive study. So you could do it defining the time frame that this is what I'm looking at. It's possible, except that the question has to be relatively new. You're dealing with something novel, something that has not been dealt with.
So the research question needs to be very crisp.
Yeah, you need to define the research question before choosing the study design.
Before choosing.
Yeah.
Okay, yeah. So that clarity has to be there beforehand. Okay, yes. And another question for you, Ruma. Can a retrospective study be taken up as a thesis study? Like normally we do, I think we are allowed to take up a retrospective and going on as a prospective. Can just a retrospective study be taken up for a thesis study?
See, again, we have 2 kinds of fellows, and the Department of Obs and Gynae has programs for 3 years. So it would be a shame for a student who comes in for 3 years to not take up a prospective study.
But sometimes students are there for just 1 year. Say the post-diploma.
Okay, yeah. So if they are, and sort of you were doing it for, let's say the time frame was 6 months and you were looking at a question which is of paramount importance, hasn't been answered. Again, retrospective study, like it has been said, the biases can be very high. And you take up a retrospective study because you have the data and there's a question which has not been answered. Okay, you don't take up a retrospective study just for the heck of it, just because it's an easier study to do. So of course, for a student who is there for 3 months and is supposed to finish their job in 3 months, a good question has been defined by you, and then the student goes back into data to look at answers, and then does that. So some of our, let's say for instance, IFS student, the sample size was 150 for a question that we were asking. And it wasn't possible in the current pandemic to generate those numbers. So we had to do a combined retrospective and a prospective. And in fact, 70% of the data is coming from retrospective analysis.
For that, our university doesn't allow retrospective studies. But then, yes, in present COVID era, we have written to the university if some gynae cases, especially, we are not getting. So then if university allows you, yes, ethically, and your ethical committee allows, local ethics committee allows you, then it can be done. But ideally, for thesis purpose, it is prospective study.
Right.
Yeah, can I add a comment to that, Kanika? This is, so what I wish to say is, while people are thinking about retrospective study, this is a good opportunity to learn something called a rapid review. Today people don't do only systematic review. There can be short scoping reviews and the rapid reviews which are possible. So while people are talking about retrospective data, it is also a good idea to do that in a global format and answer the research question in that brief 3 months time, where the postgraduate ends up learning so many things about the evidence, how to search for the evidence, how to and that scoping or rapid review is going to help her lifelong with her CV. Today, it's of great importance to be undertaking such kind of studies, because people now don't fund the primary studies. The world is full of primary studies. The problem is we don't have a good base of evidence after collation of these studies. So I still think if the clinical thing is not possible, the second best would be to undertake a review, and not a personal review. It has to be a systematic review. Systematic review is of different types. So it could be a typical 2-year one, or today we have various kinds of short systematic reviews. So one of which is a rapid review or a scoping review. So I would suggest that is a good option.
May I come in here, ma'am?
Yeah.
Okay, it's generally believed that systematic review it's a form of secondary research. And again, it could be subject to the biases of the reviewer. And the reviewer needs to understand the process. In fact, primary research a lot more before undertaking something like a systematic review. So for someone who's not into primary research, do you think it's possible for them to get into secondary
Certainly,
research quickly?
certainly.
Yeah, it's still possible.
I would disagree with most of the points you made, Ruma.
Yes, ma'am.
In fact, the leaders today in systematic review are from the allied sciences and other Ayurveda and dental sciences.
Really?
Who, yeah. And they are the ones who are heading the major portion of, especially, like Indian Institute of Public Health. They are undertaking training programs and themselves the lead authors for various systematic review. So primary research is not a precondition, number one. Of course, training is very important. One has to understand the process, and also the research question has to be clear. And that is the way it is. The protocol is very, very specific and to the point. You can't have a broad. So that kind of a training is required, but primary research is not a must. And I think this brief duration is of a great advantage, especially for our country, where there is a huge lack of evidence in majority of the areas that we have. So we have a lot of literature coming from the West, and we are actually aping RCOG and ACOG guidelines and trying to make it more contextual. So even when ACOG, Foxy tries to bring out a guideline, it is kind of almost copy paste. I'm sorry to say that. There is a process of developing a guideline, and that starts from the systematic reviews. So do you develop a robust evidence and then come to a recommendation or guideline? So it has to start from there, and I think postgraduates is the best time to actually learn and feel comfortable doing all that.
Yeah, actually, the background of my question was that I had a PG who was a post DGO PG, and she was there with me for just 1 year. And during this COVID pandemic, the endoscopic procedures as it is are like will cool on the down. So I was just thinking if I could do a retrospective thesis with her. But then our HOD changed and I got a 3-year PG, so hopefully things should improve. But
no, you can do that. You can do whatever. But the point is, she is going to again go through the data. It is going to be the study of the case records.
Yeah, obviously case records with us.
Yeah, so she might as well. And the publication of retrospective data today is not easy at all. So whereas rapid reviews today are in great demand, and then when you do a literature survey, you know where exactly you wish to focus on. So the same thing, instead of doing it in one center, if she were to do it, develop a generator, even country specific data is good enough. For instance, developing countries.
Radhika is asking whether she could have given this topic to the thesis as a
So
thesis.
that is what I want to know. I don't want to
It can
know
be given,
3
of
months.
course.
It can be given as a topic for thesis.
Yeah, certainly, of course. Because collection, search of data takes about 3 months, followed by report writing. It just fits into the scheme. It's only that we as gynecologists who are very actively involved in surgical practice, we don't find it very interesting. But today, if you ask me, there is a paradigm shift in my understanding. So I would be very much happy to, it is extremely exciting. Yeah.
So we can maybe start that. So thanks a lot. I think that covers most of the questions. Some of them were overlapping, so I didn't repeat them. But that was an interesting. I mean, all the sessions were very interesting, and I would like to take this opportunity to propose a vote of thanks on behalf of AOGD. I thank the Foxy for giving us the opportunity to hold this E-Picsep for the first time in Delhi. And I would like to thank Dr. Alpesh Gandhi and Dr. Jaydeep Tang, especially for having taken out time and joining us today here. He was very encouraging. And I would like to thank Dr. Suvarna Khadilkar, the editor-in-chief of Jogi. She had very good inputs which she gave us as from her perspectives. And I would like to thank all the chairpersons, Dr. Gujral, Dr. Achla Batra, Dr. Harsha Khullar, Dr. Amita Suneja, Dr. Vatsala Dadwal, Dr. Neeti Tiwari, Dr. Mala, and Dr. Mamta. And I would like to thank the speakers, Dr. Geeta Mediratta, she spoke on the selection of a topic for research. That was very interesting. She was the opening batch person and very crisp and timely. She finished off with her lecture. It was good. And Dr. Ruma Satwik for the types of studies and research. And there were a few things which we really didn't know about. And she threw light on them very nicely, although I can't see her face, the light is off. now. And Dr. Madhuri for the art and science of scientific writing she spoke about. Dr. Radhika, she concised 2 lectures into one, and which were very elaborate and nice, and especially the question answer sessions also she's taken well on the literature search and referring an overview of the evidence-based medicine and relevance to practice. It was indeed very interesting, ma'am. And Dr. Vanamail for the basics of medical statistics. I don't know whether she's here with us. And oh, sorry. And Dr. Pikee Saxena, we're so used to saying she. Dr. Pikee Saxena for the critical evaluation of a journal article. I think Pikee has also left. And then Dr. Suvarna Khalidar, as I said, she talked on the ethical principles of guiding and research. She's also left. And Dr. Malik, of course, she spoke on the other side, what editors and the reviewers want. It was indeed very interesting, ma'am, and good for us to know. And I thank the Master of Ceremonies for the day, Dr. Bhavani Shekhar, Dr. Ankita Srivastava, Dr. Sharmishta Garg, for being the sutradhar of all the lectures. And I would like to thank all the faculty and the participants who made this show a success, and the organizers from Jackson-Pal, Dr. Deepika, Dr. Tyagi and their team. They've always been very helpful, and Dr. Arvind Singh too. And so thank you, and a very good evening to all. Thank you.
So I from my side also wish to thank you all, and sorry my slides did not open, and then we had to literally run through the...
It doesn't matter, ma'am, but it was good.
Yeah.
Really good.
Anyway, thank you so much.
Very
Thank you.
day today. We learned a lot.
Yeah.
Okay.
Okay. Bye.
Good idea, Dr. Mala.
Dr. Deepika wants to say something.
Yes, ma'am. On behalf of Jackson-Pal, makers of Lycorate soft gel for preeclampsia, IUGR, and infertility, Cyclorex CR 10, that is norethistron 10 mg controlled release tablets, and Dynogest 2 mg tablets for suspected and confirmed cases of endometriosis. My teammates, Dr. Vipin Tyagi, Mr. Arvind Singh, and Mr. Amit Saxena join me, Dr. Deepika, to thank all the experts for the present, your so much of time and so much of effort that has been put in. We would like to reassure all the experts our extended support to all your future activities also in the service of women's health. Please do remember us. And we hope to go a long way in knowledge sharing with the unending support of the attendees. We hope to see all of you again in our next webinar. Thank you. We have our AOGD monthly clinical meeting tomorrow being hosted by MAMC New Delhi, which is going to cover a lot about COVID and pregnancy during this COVID pandemic, the pregnancy, the problems which are cropping up. And it will be a good, interesting lectures by all of them. Do attend, please. Thank you so much.
Thank you, Dr. Deepika. And we have a dry run after this?
Yes, ma'am, 7:30.
Between 4 to 5 p.m. I'll request
between 4 to 5 p.m. Yes, tomorrow between 4 to 5.
Thank you.